He really
has such a vibrant and
He is doing this event dil se.
bilkul dil se. True, very true.
They'll
With
say
other-
very quietly without any
committed.
With many other state societies, we have to push for our OTSI session again and again, again.
Mehul sir, in fact, I should say a few words about Sujit. He just proposed me. He said we will do it together, but everything he took it and he did it.
Yeah.
Absolutely. Absolutely beautiful.
And that's the same thing is happening in our society also, sir. He does everything. We just have to say, be with him. That's all.
Yeah,
The president just has to guide.
That's
teachers
the
and all
biggest
were
support. Sir.
absolutely wonderful. Absolutely wonderful. Means seriously speaks about his commitment.
One man army, sir.
One man.
Kozhikode has done excellently well.
Thank you, sir. Thank you.
I think it's 8:32. We can
Yes,
consider.
sir. We can
Yes,
start,
we
sir.
start again.
Yes, recording is on. We are live. So I would request all to kindly mute your mics, and we'll have a silent prayer for a moment. Thank you. A very good morning to all esteemed faculty and the delegates who are present here today for our annual CME of Kozhikode Ophthalmic Society. Myself, Dr. Sujit, Secretary, Kozhikode Ophthalmic Society. Today we are having our annual CME of Kozhikode. We normally name it Caldiscope. This is Caldiscope 2021. We are conducting it, we always conduct it under the aegis of Kozhikode Kerala Society of Ophthalmic Surgeons, our parent body. This time we are happy to partner with Ocular Trauma Society of India, just because we are having this program on the World Trauma Day. And I'm sure that the details will be given by our president in the official welcome speech. To begin with, we'll have a small formal inauguration. So let me start the proceedings by inviting Dr. Vijayalakshmi MS, President, Kozhikode Ophthalmic Society, for the official welcome address.
You're muted.
Madam, you are muted, madam.
A very good morning to all. We KOS team is extremely happy. It is a proud moment for KOS to have renowned international faculties, a galaxy of national and our own faculties participate in your annual CME Caldiscope on this World Trauma Day. Warm welcome to all of you. Now let's welcome our KSOS President, Dr. Baba Krishnuma sir, to our Caldiscope. Warm welcome, sir. We also have a General Secretary, KSOS, Dr. Mahesh. Has he logged in? Okay, fine. We are happy to have both our leaders here in spite of their busy schedule with the upcoming Drishti, our state conference. Thank you once again, sir. On behalf of KOS and on my personal behalf, I welcome the pillars of Ocular Trauma Society of India, the President, Dr. Ashok Grover, sir. Welcome, sir. Secretary, Dr. Mehul Shah, warm welcome again, and the Treasurer, Prashant Bavankule. He's another pillar to, standing with Sujit throughout the program. Welcome, sir. And there's a warm welcome to this vibrant team to our Ocular Trauma Symposium. Let me also welcome Dr. Natarajan, sir, immediate past president of OTSI. Now it's a great privilege and honor to have with us an eminent speaker and Associate Professor Dr. Rupesh Agarwal from National University of Singapore. Warm welcome, sir. We have with us two more international faculty from National University of Singapore, Dr. Gangadhar Sundar as a senior consultant, and Dr. Blanche Lim, I hope I'm pronouncing it correct, from National University of Health System, Singapore. A warm welcome to our CME. And it's an immense pleasure on behalf of KOS, I welcome all the esteemed speakers, my teachers, and the excellent panelists on to our Ocular Trauma Symposium. Last but not the least, let me welcome my teachers, our own members, and all the delegates who have joined with us on this webinar. Thank you all, and welcome and enjoy our CME.
Thank you, Dr. Vijayalakshmi. We prayed 9 days, all Lakshmis. So we are praying you today. Dhanya Lakshmi, Dana Lakshmi, and Vijayalakshmi.
Thank you, sir.
That's great, sir. Thank you, Madam, for the welcome address. It's my honor to invite Dr. Babu Kushma, sir, President KSOS, for the presidential address.
Good morning to all you. Respected Dr. Ashok Grover, sir, Dr. Vijay Lakshmi, Dr. Sujit Naina, Dr. Prashant Bhavankule, Dr. Suma Unnikrishnan, faculties and delegates. Let me at the outset congratulate Kozhikode Ophthalmic Society for highly active performance during the last 1 year in academic as well as non-academic fields. Also thanking them for inviting me to this CME. Today they have their Caldiscope major CME on World Trauma Day, incorporating Ocular Trauma Society of India and 37 faculties from India and abroad, led by Dr. Ashok Grover, sir, President OTSI. Ocular trauma, along with the trauma on other parts of the body or alone, is an increasing threat to vision. Fearsome are the statistics that quote the yearly global count of injury to 55 million eyes, 7,50,000 eyes per person are hospitalized, open globe injuries to 2 lakh, 1.6 million goes blind, 2.3 million are bilateral low vision, 19 million with unilateral blindness or low vision. World Trauma Day is observed annually world over on 17th of October. The day highlights the increasing rate of accidents and injuries causing death and disability across the world and the need to prevent them. Ophthalmologist's role in this is two-pronged. First is preventive and other is managing the eye trauma. It's always better to prevent trauma than happening it and losing productive hours and days. We have to identify the target group from children to adults at their habitats prone to accidents ranging from home, school, road, or factories. Public awareness eye camps on eye trauma are conducted at respective workstations. Speak to them on type of eye injuries they may come across, assisted with slideshows and videos. Demonstrate to them various eye protective devices and first aid measures. Interviews and messages in media are extremely useful. In managing an injured eye, promptness and competence are important. Manage them if facilities are sufficient or refer to a higher center. Assure the patient and be realistic with the close relatives, or else it may create misunderstandings that we are answerable. Timely intervention will always leave satisfaction in a traumatized eye. In tune with World Trauma Day, I am inviting to focus your attention to a movement KSOs have initiated. It is pledging 1 lakh eyes by logging into wepledgecampaign.com. This project is helpful to those with corneal injuries from trauma. Help the initiative. The annual conference of KSOs is on 26th, 27th, and 28th of November 2021. Our request to all the faculties, delegates, and all the KSOs members to register for it. The virtual conference can be attended from your home, live or recorded for next 3 months at a meager fee of ₹1,000. Visit ksos.in to register. I wish this function all the best. Thank you.
Thank you, Babu Kushma, sir. Your support and encouragement is always our strength. You mentioned a very specific point, prevention of ocular trauma. So we will be coming to it. We have got a special awareness program which will be launched by yourself after the inauguration. So now let me invite our chief guest, Dr. Ashok Grover, sir. Let me introduce sir officially. My slides are visible.
Yeah.
Coming.
It's a proud moment for Kozhikode Ophthalmic Society to have a great prominent figure like Dr. Ashok Grover, sir, as a chief guest for today's function. He is awarded Padma Shri by the President of India. He is a chairman, Department of Ophthalmology, Sri Gangaram Hospital, and chairman, Vision Eye Centers, New Delhi. He's currently the president of Oculoplastic Society of South Asia. He's the president of Ocular Trauma Society of India, counselor at large, Asia Pacific Academy of Ophthalmology, past president, All India Ophthalmology Society, past president, Asia Pacific Society of Oculoplastic and Reconstructive Surgery, past president, Oculoplastic Association of India. He is a recipient of many awards, of which the most coveted one is the Colonel Rangachari Award, AAOS, and many international and national awards. He is editor of 4 books and more than 100 chapters to his credit, more than 60 peer-reviewed publications. We are extremely happy to have Sir with us today for the inauguration. So, with his permission, may I play the lamp lighting?
Thank you, Dr. Sujit. A wonderful occasion, World Trauma Day, and such a wonderful initiative which highlights the prevention management of ocular trauma. Very happy to have you play out the inauguration, virtual inauguration of this meeting. Thank you.
Fantastic.
Thank you, sir, for officially inaugurating the CME. Let me request you for an inaugural address.
Thank you, Dr. Sujit. Thank you, Dr. Babu Krishna Kumar, President KSOS, Dr. Vijay Lakshmi, President KOS, all the delegates, all the faculty. It is a great privilege on behalf of Ocular Trauma Society of India to be a part of this program organized by the Kozhikode Ophthalmic Society as well as the Kerala State Society on the World Trauma Day. As the President pointed out, World Trauma Day reminds us of the enormous extent of trauma the world over, and particularly in India. Almost 5 million deaths are caused world over by trauma, and over 1 million in India. The figure 5 years ago was 1.17 million deaths in India due to trauma. And as we know, the face and particularly the eyes bear a disproportionate extent of this trauma with disproportionate consequences as well. As he pointed out, there is a huge amount of blindness world over. He quoted 1.6 million estimated cases of blindness in the world and 19 million cases of monoocular blindness. So this is the enormous extent of the problem, and this highlights what we need to do. There is a lot that we need to do in order to take care of this condition. As societies in ophthalmology and ophthalmic trauma, it is our responsibility to take care of all the aspects, increasing awareness at all levels amongst ophthalmologists and among general public, and particularly advocacy with those who matter in making legislations is very, very important. And we need to work consistently towards it. Over the next few years, that will be the effort of the Ocular Trauma Society to increase awareness, create advocacy forums for appropriate action for prevention and management of ocular trauma. We need to improve the structure in the institutions for management of ocular trauma. And that, I believe, will only be possible if we have a nodal officer or a coordinating officer or a service, ocular trauma service in charge in every specialized institution. That person need not be a trauma specialist alone. He can be a vitreoretina surgeon or a trauma or a oculoplastic surgeon or an anterior segment surgeon. But if he has a little orientation of about 3 months in one of our institutions of excellence, and we will work with all those institutions to provide those kind of orientations. If we have a person of that kind, the services will be coordinated much better so that the patient can get a much better service. Data can be collected in a much better way, and the services for the patient improved in a huge way. And this is what I'm going to exhort all of you to do. And this will be the effort over the next few years. We'll be listening about eye gates, which is an excellent way of creating the data, which is a registry. And we ought to be working with that or another way of collecting data, getting more epidemiological data as well, which is essential to persuade the policymakers to go in the right way for the prevention of ocular trauma. So I'm grateful again to the Kozhikode Ophthalmic Society, Kerala Society, for this wonderful initiative on behalf of the Ocular Trauma Society of India. We hope that this initiative will help us all. There is a wonderful prevention of ophthalmic trauma activity, which is also being started on this occasion. Gopal is also taking out a handbook on this occasion, which is again a very, very important step for creating awareness. And I'm grateful to all of you for having brought about this initiative. And I'm sure with this wonderful faculty and a beautifully crafted program, you'll have a very successful program. My best wishes for a program to be very successful and for all your future activities to be greatly successful with the kind of wonderful work that we've seen from Kerala, with the kind of initiative and the kind of hard work that is put into these activities. I'm sure these activities have a bright future. My best wishes again, and thanks again.
Thank you for the wonderful message, sir. And as you said, we will also be looking into the prevention part as part of the awareness program. I'm extremely happy you inaugurated a program. Second point, I'm extremely happy that you could pronounce a name Kozhikode properly.
Trying to.
That is one thing we always face, like whenever external faculty come, they find it difficult to pronounce a place. Thank you, sir. So I would invite Babu Krishna sir once again. He'll be launching for us the awareness program. I'll talk about it after the launch. So with your permission, can I share the screen? Babu sir.
Babu sir, unmute it.
KOS has produced a short film, Alert, to make awareness among public on harmful effects of eye trauma and methods to prevent it. I am happy to launch the Ophthalmic Trauma Prevention Awareness Program of Kozhikode Ophthalmic Society. Thank you.
Thank you very much, sir. Actually, the program, I'll give a brief idea about what the program is all about. We have termed this awareness program as Alert. And this is actually the brainchild of our president, Dr. M.S. Vijayalakshmi. Madam is always worried, genuinely worried, like how we can prevent the ocular trauma and ocular morbidity from trauma. So we thought of this program, and we are launching this program. We have put out a short movie, which I may not be able to play it now. I'll show a small trailer of that. We will be playing this movie in the various schools and the industrial areas with the help of the administration, and we'll try to spread the message of the importance of preventing the ocular trauma using the gears, the protective gears during the work and in school, the children should have the idea that they should not be playing with this sharp objects, pencils, compasses, and all those things. So we will be, with this launch for the next few months to 1 year, probably we'll be taking up this initiative, and we'll be presenting it in the various schools and the various industrial areas. That's the plan, and we have approached local administration, and they are totally supportive, and we hope to get the support from them as well. So I'll play a short trailer of the movie which we have made. Please excuse me, it is in the local language.
മനുഷ്യ ശരീരത്തിലെ ഏറ്റവും പ്രധാനപ്പെട്ട അവയവങ്ങളിലൊന്നാണ് കണ്ണ്.
എന്താ മോളെ, എന്തു പറ്റി?
തോമസാ കുത്തിക്കേറിയത്. ഭാഗ്യത്തിന് കുറച്ചെങ്കിലും കാഴ്ച തിരിച്ചു കിട്ടി.
അലേർട്ട് എന്ന ചെറിയ ഒരു സിനിമ, ഒരു ഹ്രസ്വചിത്രം നിങ്ങൾ കണ്ടിരിക്കുമല്ലോ. വേൾഡ് ട്രോമ ഡേയോട് അനുബന്ധിച്ച് കോഴിക്കോട് ഒപ്താൽമിക് സൊസൈറ്റി ജനങ്ങളെ ബോധവാന്മാരാക്കാൻ അവോയ്ഡബിൾ ബ്ലൈൻഡ്നെസ് എന്ന ഒരു ആശയവുമായി മുന്നോട്ട് വരുന്നതിൻ്റെ ഭാഗമായാണ് ഇത്തരത്തിൽ ഒരു ഷോർട്ട് ഫിലിം ചെയ്തത്. നമ്മുടെ നാട്ടിൽ പലതരത്തിലുമുള്ള അശ്രദ്ധ കൊണ്ട് കുട്ടികൾ മുതൽ മുതിർന്നവർ വരെ കണ്ണിൻ്റെ കാഴ്ച നഷ്ടപ്പെടുത്താറുണ്ട്. അതുകൊണ്ടാണ് അവോയ്ഡബിൾ ബ്ലൈൻഡ്നെസ് എന്ന് പറയാൻ കാരണം. പല കാരണം കൊണ്ട് അന്ധതയുണ്ടാവാം, പക്ഷേ നമുക്ക് ഒഴിവാക്കാനാകുന്ന ഒരു കാരണം കൊണ്ടാണ് അന്ധത ഉണ്ടാകുന്നത് എന്ന് പറയുമ്പോൾ അത് ഒഴിവാക്കേണ്ടത് എങ്ങനെയാണ് എന്നത് എല്ലാവരെയും പഠിപ്പിക്കേണ്ടത് ആവശ്യമാണല്ലോ. ആ അർത്ഥത്തിലാണ് നമ്മുടെ കോഴിക്കോട് ഒപ്താൽമിക് സൊസൈറ്റി ഇങ്ങനെ ഒരു ഹ്രസ്വചിത്രം എടുക്കുകയും അതോടനുബന്ധിച്ച് അവർ നടത്താൻ പോകുന്ന വിശദമായ പദ്ധതികളെക്കുറിച്ചും പരിപാടികളെക്കുറിച്ചും അവർ ഇപ്പോൾ തന്നെ പ്ലാൻ ചെയ്യുന്നതും. ഈ ചെറുപ്പക്കാരായ കുട്ടികൾ നമുക്ക് ചുറ്റും ശ്രദ്ധിച്ചാൽ കാണാം. നിങ്ങളൊക്കെ വർക്ക്ഷോപ്പിൽ പോകുമ്പോൾ വെൽഡ് ചെയ്യുന്നവർ പെട്ടെന്ന് എന്തെങ്കിലുമൊക്കെ റിപ്പയർ വണ്ടിയിൽ വേണ്ടി വരുമ്പോൾ വെൽഡ് ചെയ്യാൻ വരുന്നവരൊക്കെ തന്നെ തൽക്കാലത്തേക്ക് ഒരു ചെറിയ ഗ്ലാസ് ഇങ്ങനെ പിടിച്ചിട്ടാണ് ചെയ്യുക. അവർക്ക് വാസ്തവത്തിൽ അത് അവരുടെ തലയിൽ ഫിക്സ് ചെയ്യാം. ഈ കയ്യിൽ ഇങ്ങനെ പിടിച്ചിട്ട് ചെയ്യേണ്ട ആവശ്യമില്ല. പക്ഷേ അവർ പലപ്പോഴും അങ്ങനെ ചെയ്യാറില്ല. പല ജോലികൾ ചെയ്യുമ്പോഴും കണ്ണിനോട് ചേർത്ത് ഫിറ്റ് ചെയ്യാവുന്ന കറുത്ത കണ്ണടകളുണ്ട്, അതും അവർ ഇടാറില്ല. അതുകൊണ്ട് നിങ്ങൾ പറയണം, നിങ്ങളുടെ വണ്ടിയിൽ തൊടുന്നതിന് മുമ്പ് ദയവായി നിങ്ങൾ ആ കണ്ണിൻ്റെ ആവരണം ധരിക്കൂ. ഒരു സ്പാർക്ക് നിങ്ങളുടെ കണ്ണിൽ തട്ടിയാൽ തീരാവുന്നതേ ഉള്ളൂ നിങ്ങളുടെ കാഴ്ച, അതോടുകൂടി നിങ്ങളുടെ ജോലിയും എന്ന് അവരെ ഓർമ്മിപ്പിക്കണം. സ്കൂളിൽ ഈ അടുത്ത് നമ്മൾ പത്രത്തിൽ വായിച്ചില്ലേ, ശ്രദ്ധിക്കാത്ത ഒരു കുട്ടിയുടെ നേരെ കയ്യിലിരുന്ന പെൻസിൽ എറിഞ്ഞപ്പോൾ ആ കുട്ടിയുടെ കണ്ണാണ് പോയത്. നമ്മൾ ആലോചിക്കണം, അതാണ് അവോയ്ഡബിൾ ബ്ലൈൻഡ്നെസ് എന്ന് പറയുന്നത്. നമുക്ക് ഒഴിവാക്കാനാവുന്ന കുറേ ദുരന്തങ്ങൾ. നമ്മുടെ ശരീരത്തിലെ ഏറ്റവും പ്രധാനപ്പെട്ട ഒരവയവമാണ് കണ്ണ്. കണ്ണില്ലാത്തവൻ്റെ ജീവിതം നമുക്കറിയാം എങ്ങനെയാണെന്ന്. പക്ഷേ ആ കണ്ണിനെ എങ്ങനെ സുരക്ഷയോടുകൂടി ശ്രദ്ധിക്കാം, സൂക്ഷിക്കാം എന്ന് നമ്മൾ കുഞ്ഞുങ്ങളെ തന്നെ പറഞ്ഞ് പഠിപ്പിക്കുകയും നമ്മൾ അവരെ ഓർമ്മിപ്പിക്കുകയും അവരുടെ പാഠപുസ്തകങ്ങളിൽ അതിനെക്കുറിച്ചുള്ള പാഠങ്ങൾ ഉണ്ടാവുകയും ചെയ്യേണ്ടത് ആവശ്യമാണ്. അങ്ങനെയാണ് ഈ ഒരു അവോയ്ഡബിൾ ബ്ലൈൻഡ്നെസ്, ഒഴിവാക്കാനാവുന്ന അന്ധത, അതിനെക്കുറിച്ചുള്ള ഒരു ചിത്രം അറിഞ്ഞും അറിയാതെയും കുട്ടികളുടെ ഉള്ളിലേക്ക് അത് വരികയും ഏത് സാഹചര്യത്തിലും കണ്ണിനെ സംരക്ഷിക്കണം എന്ന തോന്നൽ കുട്ടികളിൽ ഉണ്ടാകുകയും അതുവഴി ഒരു വലിയ ജനറേഷനെ, ഒന്നല്ല പല പല തലമുറകളെ നമുക്ക് അന്ധതയിൽ നിന്ന് രക്ഷിക്കാനായിട്ട് സാധിക്കും. ഇത്തരത്തിൽ ഒരു ശ്രമവുമായി മുന്നോട്ട് വന്ന കോഴിക്കോട് ഒപ്താൽമിക് സൊസൈറ്റിയെ മേയർ എന്ന നിലയിൽ ഞാൻ അങ്ങേയറ്റം അഭിനന്ദിക്കുന്നു. നിങ്ങളും അതുതന്നെ ചെയ്യുന്നുണ്ടാവും എന്ന് പ്രതീക്ഷിക്കുന്നു.
So basically it was in the local language. Madam was just supporting this cause, and she's giving a message supporting the awareness program that will be initiated by the Kozhikode Ophthalmic
May I
Society.
say a word? That was
Yes,
an excellent film. I think some efforts like this will be very, very important for prevention of ocular trauma in the country. And I have a request to you and to all others to join Ocular Trauma Society of India, provide your dynamism to the society, and provide these initiatives for us to carry it forward to. We are looking forward to carrying this to people in all their regional languages, and we will need help from Kozhikode Ophthalmic Society and Kerala Society for those activities. Let all of you become part of the ocular trauma movement as well. I ought to be able to pronounce Kerala things well. I have a daughter-in-law who's from Kerala.
Thank you, sir.
Thank you, sir. Thank you for the support and the best wishes from you. So this actually with this, okay, we are taking it up as Kozhikode Ophthalmic Society President's project because it's a pet project of Dr. M.S. Vijayalakshmi.
Thank you, Sajid.
So with this, actually, we come to the conclusion of the inauguration program. Let me invite Dr. Suma Unnikrishnan, our scientific committee member, for the official vote of thanks. Madam.
Suma, madam.
So madam's net is having some problem. We'll join in a few minutes.
Okay, we'll wait.
Okay.
Dr. Gangadhar sir is joined. Good morning, sir. You can hear us.
Good morning. I'm sorry, I had to be somewhere else and just joined you all. Congratulations. And
no problem.
Don't let me interrupt your program, but just a quick comment. Wanted to thank you all for organizing it, and most importantly, to inculcate the word ophthalmic, not ocular, because it goes beyond the globe, the lid at Nexa, and I appreciate all the efforts you're doing. Carry on. Thank you very much.
Good morning, Ganga.
Morning, Nati. Good morning. The president is here. The presidents of all the societies are here. So that is just simply a...
Morning, Ganga.
Good morning, Ganga.
Morning, Dr. Grover. Morning.
Good morning, sir.
Morning. Hi, Prashant.
Grover, sir, one word that regarding the nodal officer and the ocular trauma, you are going to start, sir? You're planning or?
We are going to start this initiative all over the country for each institution which has specialities to have a specialized person as a nodal or a coordinating officer, so that the ocular trauma services as well as data collection as well as educational activities are all coordinated by one person.
Plus, there is an initiative of Ocular Trauma Society of India. Yes. We are training the Ocular Trauma Fellow, which is the extension of any of the fellowship for 6 months. And there are fixed formats for education and curriculum. They can join any of the institutions which are listed for the ocular trauma services.
It's a 3-month program, sir.
6 months program. It is extension of any ongoing fellowships.
In fact, we are working now on a curriculum for a formal and complete ophthalmic trauma fellowship program. So ocular and adnexal. So the new manuscript is also going to be highlighting the value of ocular and adnexal, or globe and adnexal trauma, or that's where ophthalmic trauma comes in. It can be, the lead can be a cornea person, the lead can be an anterior segment person, the lead can be a posterior segment vitreoretinal person, the lead can be an oculoplastic person. It doesn't matter. Every institution has its own strengths of anterior segment, posterior segment trauma, adnexal trauma. So they get trained in all aspects of ocular and adnexal trauma with a special emphasis on the specialty that the institution is good at. So they take the lead, but they make sure that all other aspects of ophthalmic or adnexal trauma is better managed and the person is trained well, and in turn starts building teams, because one single ophthalmologist cannot do all from pole to pole. And the adnexa, they start building teams, and then the allied health and prevention, management, rehabilitation also comes in.
Okay, sir.
We are hoping this will become a movement.
Okay.
Initiative, sir. Suma madam, are you ready? Madam has joined.
Yes, sir. Yes.
Yes, madam,
Okay.
please.
Okay, madam.
Can you hear me?
We can hear you, madam.
Yes, madam.
Yeah.
Yes, madam, we can hear you.
A very good morning to one and all. Respected President, Dr. Ashok Grover, OTSA President, Dr. Ashok Grover, President KSOS, Dr. Babu Krishna Kumar, President KOS, Dr. Vijay Lakshmi, Secretary, Dr. Sujit, invited faculties, and dear friends. Today, we have inaugurated the annual CME, the much awaited one. The Kaleidoscope 2021 has been inaugurated. This is an apt time because today is the World Trauma Day. So, in collaboration with the Ocular Trauma Society of India, we could organize this function. So, at this outset, it's my duty to give away the vote of thanks as the last event of this session. First of all, let me express my sincere gratitude to Dr. Ashok Grover sir, who has very willingly and kindly accepted our invitation to inaugurate this session. Thank you, sir, on behalf of Kozhikode Ophthalmic Society and my own personal behalf. And thank you for your encouraging words also, sir. Now I express my sincere gratitude to Dr. Babu Krishna Kumar, President KSOS, for launching the Trauma Prevention Awareness Program. Thank you, sir. Now I extend my sincere gratitude to all the office bearers of OTSI, Dr. Mehul Shah, Secretary, Dr. Prashant Bavangle, Treasurer, Dr. Nagarajan, the immediate past President, for joining us with this CME today, this morning. Now I thank all the invited faculties, both national and international, the panelists, for joining us and sharing their vast experiences and knowledge. I also thank Dr. Mahesh, Secretary KSOS, Dr. Raju Sukumaran, Scientific Committee Chairman KSOS, for joining us in this today and this meeting amidst their busy schedule for the preparation of Drishti 2021. Now I thank all the delegates who have joined in this CME to make it a grand success. I'm sure that we all will be benefited abundantly during this special occasion. And thank you once again all, and Jai Hind, Jai KSOS and JKOS. Thank you.
Thank you, madam. Thank you for doing the vote of thanks. So after this official meeting, we can official part of the meeting, so we can go directly to the academic event without much delay. Before starting the event, let me introduce officially my co-moderator, Dr. Prashant Bankule, MS Ophthalmology. He's a Retina Fellow from Shankar Nethralaya, and he is the Secretary of Ocular Trauma Society of India. So he has more than 25 publications, and he has given multiple oration at Gujarat, Assam, and Maharashtra Society. He has got Best Video Award in the
We can move ahead, Sujit.
It's my duty to do that. Best Video Award at Asia Pacific Ocular Trauma Society of India. Best Paper, Anand Saxena Gold Medal at Chhattisgarh Ophthalmic Society. Best Video Award in the World Congress of Ocular Trauma. He is the Joint Treasurer, Retinal Society of India, Treasurer, Ocular Trauma Society of India, and the past President of Maharashtra Ophthalmic Society. Officially, I welcome you, sir.
Thank you. Thank you, Sujit.
Yeah, so let's go to the first talk. So actually, Dr. Jane Chiman will be delivering the talk. Sir is having some issue with his net, so I'll share the screen for him.
Once again, thank you, Dr. Prashant, for being with us. You have to be there the whole day with us.
Actually, I'm enjoying it, ma'am. It's part of my duty as well as I'm enjoying it thoroughly.
Yeah, thank you, thank you.
So this will be our first talk. We all know that the most important thing when we are dealing with a trauma case is immediate decision making. So we have to make a decision. We have to convey it to the relatives or the whoever is along with the patient, and we have to take an immediate action. So we have to be very careful in our dealing. We have to be well trained in conveying what we have to actually say, because we cannot predict the results all the time. And we have to keep ourselves safe. At the same time, we have to do the best for the patient. So we'll be having a talk on this, the medical legal aspects of ocular trauma, what are things we should take care of. And the topic will be discussed by Dr. Mehul Shah and Dr. Mihir Shah.
Hope I'm audible, or should I start straight away, or should wait for the moderators?
I'll share the screen for you, sir. Is it okay for you? Are you sharing, or let me do it?
No, please share, Sujit. Please share.
Yes, sir. Just open it.
Yesterday, after the rains, my net is down. I'm joining with my mobile Wi-Fi.
Actually, presentation is not opening.
Okay, I'll try joining with my computer.
It's opening. It's opening.
Okay.
Yeah.
Yeah, that's it.
Dr. Jane Chiman is a senior. Let me tell you and introduce you, sir. Senior KSOS member. He is a consultant ophthalmologist at Daya General Hospital, Thrissur. He is an expert in this particular topic, and he has given multiple talks on this particular topic. He is a KSOS executive member. He is a treasurer, past treasurer, website editor, and state secretary of Professional Protective Scheme. So please, sir.
Can we have a full screen?
Yeah, it's coming.
Okay, thank you, Sujit, for introducing me, and thank you, Kozhikode Ophthalmic Society, for coming out with such a relevant topic, and that too at the beginning of CME. Usually, medical legal topics are pushed at the fag end of any CME, and I should just at the outset I should say that during my term as the Professional Protection Scheme Secretary, State Secretary of Indian Medical Association, Kerala State Branch, we didn't have any cases of trauma against an ophthalmologist, medical legal case of trauma against an ophthalmologist. So I think we should not be that afraid of dealing with trauma per se. Only thing is because just unlike other aspects of ophthalmic surgery, trauma, they are always tuned that they might have some problems. But if it is a cataract surgery, they see it as a routine surgery and they don't expect any complications. But always trauma, they expect a complication. So if they end up in a complication also, they may not drag the operating surgeon to a court. That's what I have seen during my term as Professional Protection Scheme Secretary. So the basis of any medical legal case, the thing that you should know is about the basic thing that is expected of you is that you should be able to provide reasonable care and exercise caution and give due attention to the patient while the patient is under your care. You are expected to give ordinary skill, have an ordinary skill of an ordinary practitioner. It is not that you should be a highly skilled man to undertake any ophthalmic surgery. If you are a specialist ophthalmic surgeon, according to Medical Council of India regulations, you can operate on any patient. Only thing is, if you have any litigation against you, you should be able to prove that you have had adequate training in dealing with similar cases. Next slide, please. So negligence, definitely, you can have any type of complication, and complication per se is never negligence. As I always tell in all my talks, you can have whatever complication that is described in textbooks, and it won't be considered as negligence. Negligence is just mainly two things. One is omission, to do something which a reasonable man would have done at that circumstances, or a commission which a prudent or reasonable man would not have done. So if if you have not done anything that an ordinary man would not have done, then definitely it's not a negligence at all. And definitely if you are operating and if you are having complication, that is not considered as a negligence. The main thing, as somebody said before me, is to have a proper consent. We should disclose of known and anticipated complications. You should explain in details in regional language about the known complications that might arise during the surgery and post-operative complications. You should detail in regional language and get it signed by the patient or relatives. And ensure that you are equipped. You have sufficient equipments in your OT to deal with any complications. And also you should be properly trained to deal with any complication that might arise in mainly managing any ophthalmic trauma. And proper management, definitely, if there is any complication, you should be able to properly manage. And if at all, if you're not able to manage, then you should be able to refer at that appropriate time. So you should have a proper referral center. You should be close with your seniors, and you should be close with your colleagues also. I'll just briefly go through a few case scenarios, what you might expect. I'm not going into the management per se, but these are the case scenarios that might happen while you are practicing as an ophthalmologist, or if you are in a ophthalmic setup in a multi-specialty hospital that is dealing with trauma. Suppose a patient is brought to casualty with an RTA and a head injury, and lid tear and superficial scleral injury is that this anybody can manage. So lid tear and superficial scleral injury is not a big problem. And if there's a head injury also, you will definitely call in to manage that patient, and you can go ahead and manage. And usually no complication is suspected, and the patient outcome will be good. Next slide, Sujit. So this is a lid tear that was that had come to our hospital, and we had managed it. No other complication was there, and since head injury was there, that patient could not be taken to a pure eye hospital. So the lid tear was managed beautifully. Next slide. Usually, you will be, if you are in a multi-specialty hospital, you will be asked to deal with many multiple trauma, where a trauma team will be managing the patient. Whether there will be head injury, there will be multiple fractures, and definitely the patient won't be able to be shifted to an eye hospital where a full setup is there, with which can manage the retinal problems or scleral problems. So you will be called in to manage the ophthalmic part alone. That time you can manage that ophthalmic part, or you can shift the patient. Next slide, please. This is a patient which was brought to following an RTA, head injury, and corneal tear and iris prolapse. If you are well versed in managing corneal tear, or if you have a corneal surgeon, or if you are trained in any corneal procedures, you can manage this patient. Or you can, at the time, if the patient cannot be shifted to a higher center or a tertiary center where the patient can be managed, both head injury and also the corneal tear management can be managed, then you will have to give a supportive treatment. You will have to give first aid to the treatment. And then later on, once the patient is stabilized, you can shift the patient to a higher center. So all these cases, if there is any complication also, you won't be dragged to a court. And if there is an head injury and RTA, iris prolapse, this is a very peculiar case. This was a RTA and iris prolapse had occurred to an incision wound. The patient had got operated for cataract surgery in a nearby hospital, pure eye hospital, and the patient had an RTA and the iris had come out to that incision site. And the patient could not be shifted to a eye hospital because there was a severe head injury. So he had to be managed in the multi-specialty hospital itself. And here the problem is the patient is not at all confident with the eye surgeon of that hospital, but the patient would be very happy with his eye problem being managed by the same surgeon who had operated him. So here is what your relationship with your colleagues comes in. So if the surgeon who had operated on the patient for cataract surgery, if you are giving the writing all the complications that can happen, because if following an RTA, if there's an injury, you can always expect a post-operative infection. So in this patient, the cataract surgery had gone off well. The patient was fine. The patient had 6/6 vision, and the RTA had occurred after 1 month after surgery. But since it was an RTA, and definitely there will be a lot of foreign bodies and materials and post-operative complications will be there, including infection. So after reading all the written consent, the patient was afraid, the relatives were afraid, and they had taken the consent to the surgeon who had operated him for cataract surgery. And that surgeon had given confidence, saying that, okay, fine, you go ahead with the same hospital, the surgeon is competent, you can go ahead and operate. So we could operate on the patient. So these are the peculiar instances that can happen, because in a eye hospital, you are not equipped to you manage a head injury. But at the same time, if it is a multi-specialty hospital, that ophthalmologist, if is not that confident of managing any severe complication, then this type of problems will happen. But if you are managing according to the textbook or with the setup that is possible, and with the knowledge that you have, and with the limited expertise you have, then you won't be dragged to court. So these are a few cases. And if there is a severe globe injury needing retinal surgeon, definitely you can call in a retinal surgeon to manage the patient there, or you can shift the patient again in toto to a tertiary multi-specialty eye setup, where multi-specialty hospital, where there's a trauma surgeon and also a retinal surgeon, where the patient can be managed. So these are the various instances that we come across usually. And only thing I have to again stress is that if you are managing a patient according to the textbook, and if you are having any complication, and with your knowledge or with your limited knowledge and with your limited equipment, if you are still having complications, then definitely you won't be dragged to a court of law. So only thing I have to stress is, if you are managing as a team, keep united and don't have differing voices. If you are talking to the relatives, the trauma surgeon and the neurosurgeon and the ophthalmologist should be having a united voice and should be talking in the same voices, and stick on to ethical and scientific practice. Don't try any shortcuts, and always keep on updating your knowledge. CMEs like this will definitely go a long way in updating the knowledge of an ordinary general practitioner ophthalmologist. Thank you. And next slide. And of course, membership in IMA and professional protection scheme of IMA definitely helps if there is any litigation, even after taking care and managing the patient. If you are dragged back to a court of law, and PP scheme, professional protection scheme of IMA, will definitely step in to support you and also fight the litigation in court up to the Supreme Court. And KSOS and district ophthalmic membership definitely, and being active in such organizations will build up a good rapport with your colleagues, and also build up a rapport with your seniors, and also allow you to interact with other members, and also update your knowledge with such similar CMEs. Thank you. Next slide. To conclude, maintenance of high standards in daily practice with continuous training and clear communication, along with the appropriate documentation, which is very, very important. Because if you have done something and if you are not written it down, then the court will find that you have not done that at all. So proper documentation is very, very important, and for any procedures carried out, and will definitely improve the professional safety of practicing eye specialists in the event of medical litigations. So have a safe practice. Go ahead and operate. Thank you. Next slide. Thank you. Thank you for patiently here listening. Thank you.
Yeah, great highlights for all ophthalmic surgeon. It is very important in our busy practice. We keep forgetting many more things which is required to do in ocular trauma. And as very clearly you said about the documentation. So documentation will be very, very vital if something goes wrong. And one part what we would like to include is you should have a CCTV camera and you can take the video consent for all these cases. So when you discuss your recorded video always will be helpful to you. Secondly, if you have got an electronic medical record everything during the multiple visits, have all investigations, all documentation ready with you, particularly cases where you might be treating the no PL cases, or we might be treating the cases where you might require the destructive procedure. Those video consents will be very, very important for us, for all practitioners to be to have a safeguard in the court of law.
Thank you, sir.
May I ask one question? Basically, what, sir, would you recommend as an ideal consent for a case of a trauma?
Should be definitely no typed consent is admitted in court nowadays. So it should be in a regional language written by the relatives, but it is very difficult to get it written by the relatives. So what I would recommend is to ask your sister to write in regional language, explaining in detail what has happened and what you are planning to do and what are the complications that you might expect. Even detailing all the known or unknown complications that you might expect, even if you don't have all those complications, but it's always better to get it in writing.
Sir, may I add?
Yeah, please.
Yes, sir. So I think this is one of the incomplete tasks from my end. Dr. Bavankule has asked me only one thing, if we can do it at a POTS level or at he wanted to come up with some kind of a consent form, which I did promise to Dr. Bavankule sir a couple of years before. I think, sir, just to share about my experience when I was in Chennai, Shankar Nethralaya, and also in Hyderabad and Jalna. So I did met up with many lawyers, and we did discuss about the consent form, appropriate consent form. All the lawyers very blanketly, and these were all kind of very top criminal and medical legal lawyers, and they all said that no consent form can save you in the court of law, even if you do extensive documentation, because there can be many things there. And you can write it down, but on the day of the patient says that I could not understand anything, I was in severe trauma, I was in pain, and I just could not understand anything, whatever doctor has said and all, then it will be very difficult. So he only suggested, all the lawyers suggested is, one is the documentation, and of course your rapport with the patient is something which can probably help you. But the consent form, which we used to take it in Shankar Nethralaya one-liner, was definitely inadequate, which was written there. So I think there is no kind of good answer on behalf of from the law aspect about any specific consent.
What about validity of video consent?
The video consent are taken by the cochlear implant surgeon, so you can check with them. So that's the only practice which people are doing, the cochlear implant people, and when it goes wrong. But as of now, a lot of countries do not allow video consent to be taken, particularly in Singapore and even lots of in Western countries, the video consent is not allowed. If it is allowed, probably yes, it can help us. But cochlear implant surgeons, they do take video consent. We need to check with them how they can obtain the video consent.
Can I add a point?
Yes, sir.
Prashant?
Yes, sir. Please.
Yeah. No. I think I agree with the Rupesh, what he said. I think we routinely take video consent for all my retina, for my surgeries, whether it's retina or regular VR or a trauma, for a long time, particularly from Kashmir. And I think Kashmir, I openly told them that I'm operating no PLI and they cannot expect a miracle, which I took opinion from Farhan Spoon and Fernando Arviolo. But I think Rupesh, what he told important is developing a rapport with the patient and the family and the doctors around our family, people around. And I think that's the most important. So Malcolm Gladwell has written in the book Blink for American physicians. If an average, a physician spends 15 minutes talking to the patient after examination, the litigation cases are very high. And if he talks 3 more minutes, and the last question asked by the doctor is, do you have any more questions? And have you understood everything? And if the patient and the family says, I've understood everything, I think that usually the litigation goes down. So I think the development, now I'm propagating that I operate only in trauma patients, no PL. Whoever cannot do, send it to me, and I will do it. And I think, fortunately, touch wood, because of precautions and all the contingency plan discussion, nobody has gone, and I'm sure nobody will go. The reason is we discuss a lot, discourage a lot, and I call every relative, talk to them, to the referral doctor, or usually they're referred by somebody known to the patient. They say it's a gone case and no PL, and still you can try. And they also sometimes refer either to Shankanetla Ames, and they come to me. And I tell them, I think most trauma patient, but no guarantee. Which patient will see, we don't know. But I think it has definitely worked a lot. You have to develop a rapport, apart from counselors talking, but you as a surgeon, and how confident you are, and whether, and then second, I ask them another question. After doing everything, you lose your money and you can't see, what are you going to do? I tell them, if you're going to cry or grumble or fight, no point. I don't want to operate it. Because rights of admission reserved in a hotel, rights of surgery is also done. Because for me, fortunately, they come as a secondary or a tertiary care, not a primary. So primary, I think, is a problem which Rupesh said. The patient will say, I'm in shock, and even no PL, they will tell wrongly, and it just happened. So I always tell, don't do a primary enucleation. Recently, I won't tell the name of the hospital. One of the patient called me at 1 o'clock in the morning and said they are taking this patient to some hospital, and then the bike, the eye is hanging. So I said, okay, go to the hospital and connect me to the surgeon. The surgeon, I specifically requested that please don't enucleate, even though the eye is hanging. But somehow they enucleated next day, in spite of one oculoplastic and one well-experienced anti-segment surgeon. But I think we have to do something, because if you don't enucleate, at least the patient has a hope, and hope after hope, that even if it is no PL 1 week later, and nowadays we don't have any fear of sympathetic ophthalmia. And once upon a time in Australia, I think millions of dollars are fined for a sympathetic ophthalmia patient because the patient was not informed. So we write the risk of sympathetic ophthalmia and the consent. But as Rupesh said, if the advocate proves you are negligent, whatever your consent, one is whether rule there or not, but it doesn't have a code of law, because I think, and also the expert opinion given by somebody. So you should know that giving an opinion also, I think we all have to be trained. So sometimes the government doctors give, and I'm not against them. So I call them and tell them, please make sure you do a general thing. It's not supporting the doctor. The question is supporting the science and what can be done in trauma.
Thank you, sir. I think it's time for us to move ahead. Sujit, can we move to the next presentation?
Yes, sir. Can you please introduce Dr. Rupesh?
Yeah, in fact, it's my privilege to introduce my own intern. I would very proudly, I keep on telling people he was my intern once upon a time. Now he's a big man to be called an intern of mine, you know. So Associate Professor Rupesh Agrawal is a person who hails from India, from my own city, Nagpur. He's a senior consultant. As you can read through his articles, basic most important thing is a humble human being. He has a multiple research interest, right from ocular inflammation, HIV, and importantly, ocular trauma. And he's a lead investigator with CODS, eye gates, all these diseases, and just only 300 publications. I can't even count the number of publications he has. So proud of you, Rupesh. Over to you. You can share your screen.
Thank you, sir. It's again indeed a great honor, and I also call myself as a student for Dr. Bavankule. I think I remember that March 1998 when I was in Nagpur assisting Dr. Bavankule in one intraocular foreign body, and we just bumped into. Said I was just putting the water on the eyes and saying, "Are you interested in doing trauma or fellowship there?" I said, yeah, I'm interested. Then he said, why don't you kind of consider Shankar Netral? And that was probably the journey, the start of the journey for ophthalmology. So otherwise, before that day, sir, to be very honest with you, I was more into orthopedics. I never thought I'll be entering here. But just before I start my presentation, I would like to really thank the organizers. And as you rightly said, Dr. Sujit, it is difficult to pronounce. And I was doing Google to make sure that I pronounce it correctly. Kozhikode Ophthalmic Society. And very rightly said when you said to Dr. Grover. So I was just trying to do my homework to make sure that I pronounce it correctly. And but one other thing, probably I don't like myself to be called as external faculty. So I'm as much internal faculty, if not focal or local or a regional faculty, but definitely one of the internal faculty, at least for Ocular Trauma Society of India. So again, once again, thanks to Ocular Trauma Society of India for having me here. So as we have heard from the president talk and from all the other talks also, we'll be hearing also, I think I go back to COVID. So I think what COVID has done to us, besides everything, it is the most important thing it has done to us as educators is that it is a teacher of the lifetime. So I think the best teacher which has taught us many, many things. And it is because of this, we are all sitting in different parts of the world, but we are still united. And this is what which we need to do moving forward, particularly with regards to the subspecialty of ophthalmic trauma, which does not have any less incidence than as like a COVID. It is again like a virus, which is there in practice of ophthalmology, and we need to tackle it together. I think this is something which we need to learn from COVID. And what it has taught us, the COVID, is the art of collaboration, the art of working together, art of using technology, art of staying together. And this is something which we should do it. And I'm really, really thinking that how Asia Pacific Ophthalmic Trauma Society and International Society of Ocular Trauma can work closely with KSOS, with KOS, with Ocular Trauma Society of India, with All India Ophthalmic Society to take the concept of alert forward. I think really glad to see. I could not never think of doing that alert when I was with the Ocular Trauma Society of India, but this is something really good. And I think we should take it forward. And I don't know whether Dr. Ganga managed to attend that trailer of that, but I think that's something which I will be very glad, requesting you to take it forward. And I think we can all work on this together. And I will definitely put it up to APOD's board and ISOT board, how we can work together with KOS to take it forward. Now, I will sound like a broken record to Dr. Grover and Dr. Bonkule and some of the esteemed panel on this thing, because I've been talking about this every now and then in every meeting. But I think I still will continue with this because I really want to convey this message, which is given by none other than Sir Arthur Conan Doyle, is that it's a capital mistake to theorize before one has the data. And we keep doing that every now and then. We don't have the data, but we keep putting up theories and hypotheses without the data. So insensibly, one begins to twist facts and the theories instead of theories to suit your facts. So I think if you can remember this basic concept or this basic thing about the data, and this will make my point very clear that why I'm sounding like a broken record about collecting data and all. We did spoke about in the inaugural function today that how much the burden of the blindness. So we can see that ocular trauma, definitely Dr. Ganga will not like this slide. We do like to call it as ocular ophthalmic trauma, but all my other slides have probably the ophthalmic trauma. And it is a most common cause of reversible and preventable cause of visual morbidity. And this is something which really excites me. And we do know that any kind of trauma, probably you can probably do something, because these are all relatively good, healthy eye to start with. These are not macular degeneration eyes. These are not glaucomatous optic atrophy eyes. These are not bad diabetic retinopathy eyes, which is a bad retina. These are all very good eyes. So if you put in your heart and soul, probably you can save some eyes, if not all the eyes. But unfortunately, the situation here is that we don't have an established training program or fellowships, despite all the efforts. So I did my trauma fellowship from Shankar Netral in 2001 to 2003. And I used to enjoy that. I used to have a pager number 023 and manage each and every patient coming to the Shankar Netral during that time. And I really like the concept proposed by Dr. Grover of the nodal officer or the coordinating officer, or you can give any kind of fancy name. But they should be the one, the center point for connecting all the patients with the trauma to make sure that we eventually set up the standardized guidelines for managing these patients of the trauma. So as we move forward, where do we lack? We do lack in recognizing this as a subspecialty. We do lack in a good classification, which is ready to be used. We do call vaguely each term interchangeably between other. It's a great step OTSI and a lot of other societies are taking forward in education and training, and we do need to do that while other things are really setting it up. The research is moving forward in ophthalmic trauma, and there are a lot of papers now being published, but unfortunately the regulatory framework still we need to work hard to get them on the same page as we are. So as I said about the training, so you don't want to be seeing your patients coming like this. This was the eye supposed to be enucleated and be or eviscerated, and we did manage to fix these eyes again, and he still sees 636. This was again poorly repaired thing done there. And we can go on this for the entire day, why these eyes end up like this. Is it because of the improper training? And that's one of the aspect which was brought up by Dr. Jain in his talk about the inadequate training. Will it constitute medical legal? But before you go to the medical legal, I will say morally, ethically, does it make enough noise to you that, hey, this is a patient, a young boy, and are you justified in giving it to the junior most surgeon into your hospital who has not even started doing the suturing for the SCC? And but whereas a patient comes in from a Mercedes car or a BMW car, and then the best surgeon of the hospital goes and attend it. So I think this is something which we need to sit down and reflect upon ourselves and introspect and think about it morally and ethically, even before we think about the medical legal cases about it. So when it comes to the classification of the trauma, we do have an old classification, and which has been standing still today after 25 years. And very recently, Professor Farrington published about the 25-year celebration of this classification, which is a BED classification, BEDS classification. There are certain things which can be improvised upon, and we do have revised and revised classification, even including the ETDRS or all the other classification. So here also, it probably needs some more effort, some more work from us. And here only the mechanical eye injury has been classified, does not take into consideration lid, adnexal and orbit. Visual acuity is given a lot of significance, and RAPD is probably given a lot of weightage here. And zone 1 does not segregate itself into the visual axis involvement and non-visual axis involvement. Now, we looking at all these things, looking at all the kind of aspects which are missing, we did set up in 2016, 2017 registry. And the idea was to get all the people on the same page, whether it is the Ocular Trauma Society of India, whether it is Asia Pacific Ophthalmic Trauma Society, whether it is International Society of Ocular Trauma, whether it is Chinese Ocular Trauma Society, and to all of us to use the same language. And that is where we introduced this term of the eye gates, which has been now popularly used by many people, including Dr. Giridhar from Kerala, who has been one of the kind of highest contributor for this registry. And the concept and the idea behind setting up this registry was something which we want to kind of get all the facts right, execute it, get the right mentors like Professor Ganga, Dr. Natarajan, Professor Grover on board, and making sure that we can take this forward in the right direction. And of course, getting a team along with, it was the most important thing which we managed to achieve. And now we are into this stage where we are able to kind of present the concept to you. We will probably eventually move into the big data analysis, which is the O part of the femto, and which we try to use some of the buzzword. Hopefully we can receive some funding if we use the word femtosecond here in the trauma. So the objective of iGates was to set up a registry, which is a both prospective as well as a retrospective registry, and eventually to develop some form of image analysis algorithm for classification and hopefully prognosticating a patient with ocular trauma or ophthalmic trauma, and to also develop the survey-based guidelines and eventually come up with the CDSS, what you call it as a clinician decision support system based on the AI tools to eventually help us predict a patient with the ophthalmic trauma. Now, what are the tools available to us? Again, going into some of the very standard tools, how do you collect data? So now you spoke about collecting the data, but how do we go about and execute it? So we have a very traditional way of collecting the Excel chart, but again, there are limitations of the Excel chart. You can do some bit of work, but not in a great work. And then there is something called as a red cap, which is very institutional based. And this is how a record can look like on a red cap also. Then I used in the earlier part of the iGates, something called as a cognitive form. And this is how a form will look like on a web page like this. And this can be a link which can be shared with that. Using some of these tools of Excel chart, using the tools of cognitive form, we did manage to publish quite a lot of work. We did manage to present some bit of work, but now it's the time to move forward, getting more people involved. And that is where we came up with this concept of a web-based data collection form, which I like to take next 5 minutes to show you what is the concept about. So this is a single stage platform to allow you to do retrospective as well as prospective entry everything can be recorded here, including all the images. There is an image bank, there is a data bank, and it will also allow you to do a longitudinal entry. And while you are doing this, also it will allow you to put in the APIs to kind of compute and analyze the data whenever you are entering there. We'll just see a glimpse of what can be done. And this is how the form will look like. It will be able to classify into open globe, closed globe, and also will give you ocular trauma score. And also we are able to integrate into this schematics, which is able to kind of classify the orbital trauma into different things, because it is not very easy to remember. And this is all based on the clicks. You're not going to type there. You're mostly going to click, click, click there. And this is again the click, which will automatically classify and give a diagrammatic representation of how a trauma will happen. And this will be available to you in your desktop. So this is how, again, an IT-based platform. So this is again using a remote setting or an office-based setting. It can be done anywhere with a secure HTTPS and appropriate firewalls being put up there. And you can have the servers within your institute, or if you want it in the cloud, it can be done there. So now I will quickly show you how the tool will look like. Allow me to share this web page, which goes by the name of igates.oculartrauma.com, and all of you are invited to be the member of it. It is open. It does not require for you to pay any money, and we have got more societies moving forward, including the American Society of Ophthalmic Trauma, APTO, also an All India Ophthalmic Society. Dr. Namrata has said that we have to still continue with our dialogue with AIOS. So once you log in into this page, you can see what will happen. So this is the admin login. You can see already 1167 records have been entered from multiple sites. One of the major contributors is Dr. Mehul Shah himself. And you can see which are the different sites. So you have different sites of Singapore. You have sites from Madurai. You have sites from Jakarta, Malaysia, Gujarat, Sydney, Colorado, Tehran. You have got sites from Chitrakoot, Chicago, Dr. Hugo. And then you've got sites from Indonesia, Nagpur, Amritsar, Aditya Jodh from Bombay, Shankar Deva Netralaya, National University Hospital, Gangaram Hospital, and Argentina. And recently we have also added, and you can see Dr. Giridhara Institute has contributed 232 cases. We have sites from Kathmandu, and we have also added site from Guatemala. You see 204 records from Guatemala. This doctor has been very pro in entering the record. Now, how does this record look like? You can see an entire record like this, and you can find out about the details of the record from here. But let's say I have to create a new record. I can go into this new and then I create a demo record, and you can have a retrospective data entry for any patients which you have been seen in last 5-10 years. And you can just get a ID, which is a iGates ID. This can be a male patient with whatever age you want to give. You can give any date of presentation, the duration of injury, you can put it there. Selection of the race, you can put it there. And maybe let's say Burmese, and the masked medical history and past ocular history. After this is done, you go into this injury. So maybe I need to fill up something. I need to save here. And something is asking in the save. I did not save this here. May, then 6 hours of injuries, selection of the result. There are certain components which we have put it up mandatorily, which we need to do before we move on to the next page. And if you don't do that, it will not allow you to. So that this is overcoming the shortcomings of the Excel chart. Injury details, again, we have put a lot of emphasis so that when we go to the regulatory bodies, we know what we are talking to them, that whether the injury is happening at home or at workplace, and what is the nature of the injury. Is it accidental? Was the eye protection present or not? And if the eye protection was present, what kind of eye protection was it? And what was the mechanism of injury? If it is a blunt, was it a metal? And description of the metal. Let's say you can say iron nail or something like that. You know, a non-ophthalmic injury, was it present? Any kind of head injury? You can say he was a patient of a polytrauma. So once you fill in the form, you will realize the importance of it, and it is including all the eye-related findings also here. And then if the patient undergoes surgery, and then follow-up visits. If the patient comes from a week follow-up, then you say week 1, you enter record. If patient says 3 weeks, you enter a record, and you can start entering the record. So you can create multiple records for the patient, and eventually you can come up with the final anatomical and visual outcome. How many total number of visits? How much was the total number of follow-up? What is the final visual acuity? Was there a loss of vision? And if there was a loss of visual acuity, what was the cause of the loss of visual acuity? And also there is an image registry when you can incorporate all the images at baseline, during treatment, and during follow-up. And you can also have right eye, left eye, OCTA scan, X-rays, your OCT, your fundus photo, and everything. Now just let's look into one thing very important, which you will see from a record filled up by my friend from Iran. And you can see, if I click this page, what comes up is an ocular trauma score. So he has filled up, this is a patient with an open globe injury, penetrating injury, with a vision of PLPR inaccurate, zone 2 and 3 injury. Then with this, the ocular trauma score was computed, and we can predict what is the 6 months visual acuity probability. So this is how useful a tool can be if you can incorporate in your practice. And this will also help us to build in with the trauma units, which Dr. Grover did spoke about, and this can become a useful tool. With that, I like to thank once again Ocular Trauma Society of India for giving me the opportunity, particularly Dr. Bhavan and Dr. Sujit. Thank you very much for your patient listening.
I request
Thank you.
Ashok sir and Prashant sir to have quick comments on the talk.
Thank you, Dr. Rupesh. As I said earlier, Rupesh has galvanized ophthalmic trauma the world over. And we are looking forward to some really concrete action in all the deficit areas over the last few decades, all the deficits that we've had to be filled by the efforts of Rupesh and ISOT and APOTS and OTSI and all organizations getting together. This iGates is an excellent initiative because in previous years, we've been making efforts at a Intraocular trauma registry with efforts from Professor Natarajan for nearly 2 decades or more. But with the coming of web-based and digital technology becoming commonplace in all institutions, this will become much simpler. And it will only work if there is a coordinating or nodal officer in that organization who spends time to involve all the cases, get all the specialists to work together and is able to put his data together. The great thing about iGates is that it, as you saw, puts together all the data, which you can also double up for your own software, for your own hospital information system as well. So you can use the same data. You don't have to do a repeated filling of the data, and it can serve as a useful data for yourself as well as for the international study. And you can use this data for your own publications, either with iGates or on your own, which is a great thing, I think. So it has been designed with a lot of effort, with a lot of input from everyone, with involvement of everyone. So I think this is going to be a huge game changer. But one deficit area in addition will be the epidemiological studies, the estimates of blindness. The study that Rupesh cited is actually a part of a publication by Inaugural in 97, which is a WHO publication, an estimate from 97. So over a quarter century, we've had no fresh estimates, no fresh epidemiological data. So this is one deficit crying out to be filled. And I think we'll all need to work together a lot and work together on organizations, work together on individuals, advocacy, starting from the corporation level to the parliament level, to the minister's level, in order to be able to do some action. But first, we must all act, appoint nodal officers or a coordinating person for ophthalmic trauma so that we can move forward. Thank you, Rupesh.
It is very, I think why iGates is unique is because I think we have multiple publications in multiple forums, people present with loose data, with different formats, with different data in local city, state, region. Again, all these data are not coordinated. So it is extremely difficult to generate the policy out of all this hodgepodge data. If we have one clear data in single format, that will be valued. And that's what iGates is doing.
Dr. Mehul, you are one amongst the person who have registered maximum for this iGates, your patients. In spite of your busy schedule, what is it that may gives you more, you spare some extra time for this particular iGates?
Yeah, always you need to do
also
that.
Also learn from you. What's the incentive you have for spending some extra time in registering? Yes, it is
obviously. We have created one group. We have created one group in our society. Everybody who does the entry in iGates, they update every day in morning, in the evening. I keep monitoring those entered data for every day.
So yeah, so friends, all of you who are watching, each one of us has to contribute to this. Hello.
Yes,
sir. Yeah.
I think it's pure dedication, like Rupesh Mehul is doing, and Rupesh is also pure dedication, and he works with passion. That's why Dr. Badrinath says 99% hard work. I've changed to 99% work with passion and love, and 1% inspiration. They both are inspiration for the young people, and I think there are professors here. I hope they will keep inspiring the young to do it. I mean, in spite of, as Dr. Ashok said, in spite of having my own fellows trained, when they're there, they do, and when they go out, they forget. Same thing with optometrists. But I patiently and persistently and persuasively, I'm going to keep trying. And Rupesh sometimes feels frustrated, like banging his head on the rock like me. But I keep taking like a cushion, not a rock.
Great. So friends, it's
so
time
just
for
one
us
question,
to
sir.
understand the great efforts put by our own person, Dr. Rupesh Agrawal, and to reciprocate the noble work which is doing selflessly for this particular cause. So our only simple contribution can be by registering into that particular iGates your cases, so that we can achieve the target which he has for his dream. So it's now time for us to move to the next talk. Can we have it, Sudhi?
Yes,
Yeah.
Can you please introduce sir?
Yeah. So Dr. Rajiv Raman is a senior consultant at Department of Vitreoretinal Services, Shankanethralaya, Chennai. He is also a visiting professor at Vision and Eye Research Unit, Anglia Ruskin University, Cambridge. He is a section editor in Nature Journal Eye and reviewer of 32 international peer-reviewed journals. He is a member of National Task Force for Diabetic Retinopathy for Government of India, National Board of Examinations, Ophthalmology, National Expert Certificate, Course Evidence-Based Management of Diabetic Retinopathy by Public Health Foundation of India, member of National Task Force of Diabetic Retinopathy for All India Ophthalmological Society and whatnot. He has received multiple awards, to name few: Asia RO Young Investigator Award, Ruby Bank Memorial Award, at then Dr. TLK Rowe Memorial Endowment Award, and lot many. I think I would exhaust all his time if I keep on eliciting all his contributions. So over to you, Dr. Rajiv.
The topic
Thanks,
will be
Prashant.
discussed by Dr. Jyoti PT, our own KOS member. Madam is HOD and professor at Kozhikode Medical College, and by our Honorary General Secretary KSOS, Dr. Mahesh G, Senior Veterinary Surgeon at Giridhar Eye Hospital. Over to you, sir.
Thank you. Thank you, Dr. Sujit. Thank you, Prashant. Next few minutes, I'll be sharing views on closed globe injuries, the acute stage management, and planning the management strategies. So we have seen the classification of trauma, and that's the BETS classification. You have the closed globe and an open globe injury. The closed globe injuries are the ones where you have no full thickness injury in the eye. And these are the ones which I'll be today discussing a little more detail. So it's classically described that there are 7 rings of blunt trauma. These are the weak areas which give way whenever there is a blunt injury. So you have sphincter tears, radial tears, that is one. The second ring is the iris base, where we see iridodialysis. Can have anterior ciliary body where there is angle recession. The ciliary body to the scleral spur, where you get a cyclodialysis cleft. Trabecular meshwork, where you can get a trabecular meshwork tears. The zonules, where can lead to a lens subluxation and dislocation, and retina to ora serrata, retinal detachments and dialysis. So these are the areas which get involved whenever there is a blunt injury or a closed globe injury. So first things first, what needs to be done is definitely reassure them of your intention that you want to do the best for these patients. Children, whenever you are dealing, make sure that they are with the caregiver. You want to rule out any life-threatening injuries if present, and you want to know how and what caused the injury, which part got hit, what was the duration of this hit when this happened, and vision and refraction. If you can know prior to injury, definitely it helps. So I would tell the 8 steps of acute stage evaluation and the lab planning strategy. So definitely want to measure visual acuity in these cases, both eyes, glasses and pinhole. You examine the glasses, and if you are not able to record vision, like a tense lid or an uncooperative child, do mention or record it so that it can be re-evaluated at a later stage. You do external eye evaluation, which is so important. Just looking at movements, to many times, the blowout fracture, the orbital injuries can very well be picked up by just this external eye evaluation. It's important to do a pupil evaluation, especially to look for relative afferent pupillary defect, because that gives us a very good idea about the visual prognosis, the involvement of optic nerve. So it's important. The next step, the third step, is the pupil evaluation whenever you're dealing with a closed globe injury. A good slit lamp evaluation can give a lot of clues whenever you are dealing with a closed globe injury. The first thing is you want to rule out occult globe ruptures. The features which are suggestive of a globe rupture, they have less vision, they have severe chemosis, ballooning of conjunctiva typically, which has been described, subconjunctival hemorrhage, and if you can see pigment, these pigments are the uveal pigments. You can see in this case, inferotemporally or inferiorly, you can see that pigment line, and presence of hyphema with a low IOP. These are the features of a occult globe rupture, and these are the cases where you plan for a globe exploration plus repair. The slit lamp, you can make out many other features. So this is a case of hyphema, where the management strategy would be initially a conservative management, close observation, and at some stage may need surgical removal if there are some features like blood staining of cornea. So these are the cases where definitely you would prefer to go ahead with the evacuation of hyphema. Can have iridodialysis with a cataract and associated, majority of them, it's not like trauma will cause only one abnormality. There are multiple things which happen. And these are the cases you can plan iridodialysis repair with secondary procedure. You want to do it early in the course of the disease, because sometimes it becomes very fibrous, where suturing these iridodialysis is a bit difficult in the later stages. If you see this case, you see a traumatic cataract, you see sphincter tears, some hemorrhage, some fibrin, and also some vitreous, which is there in the anterior chamber. So these are the cases you'd like to do a cataract surgery plus vitrectomy, plus depending on what is there in ultrasound, you want to do additional procedures. All these can be done in a single sitting. It's important that traumatic cataracts you should deal early, because they tend to, especially in children, the lens absorbs and becomes intumescent very quickly, and that leads to an increased IOP. Again, traumatic cataract, you'd like to do a cataract surgery. Subluxated lens, and especially when it is subluxated in the anterior chamber with a high pressure, without removal of this, the vision will never, the pressure will never get controlled. So these are the cases where you want to go ahead removing these lens. If posterior segment things are all fine, you can plan a concomitant scleral fixating IOL. In a setting of closed globe injury, you can have both low IOP and a high IOP. Whenever there is low IOP, you think of occult rupture, retinal detachment, ciliary body injury, or a cyclodialysis cleft. It's important to do a gonio if you can in these cases to identify these CD clefts. In a high IOP settings, you can have wherever there is obstruction, outflow, the outflow is obstructed, like hemorrhage or a hyphema or severe inflammation, or if there is an aqueous misdirection, a suprachoroidal hemorrhage can cause an increase in the intraocular pressure, pupillary block, or pupillary block by lens. As I told you, the lens has moved and caused a pupillary block, or there is an inflammatory membrane causing this. So each one of them have to be dealt depending on the pathology which is there to deal with intraocular pressure. The next important step is retinal evaluation, which is very important. And many times it may not be possible to evaluate retina, where you go ahead with other investigations. But if retina is seen, Many times you see a diffuse vitreous hemorrhage or a little vitreous hemorrhage which is down. These are the cases you tend to observe initially, but you have a low threshold for vitrectomy, because what you do is you follow them on a very regular basis to look for these dialysis in the periphery or a retinal break. And if you are not able to visualize the retina well, unlike diabetic vitreous hemorrhages where you can wait, in trauma, you don't want to wait for a long time, just go ahead, do a vitrectomy, and then see these, identify the peripheral lesions if present and treat them. You can have these choroidal ruptures, and these are the ones which essentially you don't need to do any treatment, but they need observation. You may need sometimes, if they come to you in a little later stage, to do a OCT, because many times it's difficult. They may not have the classic features of choroidal neovascular membrane. So better to document with a OCT, or if they don't have, better to give them a home Amsler so that any distortion, if they identify, they can present in an early stage. The blunt trauma can cause hemorrhages in nearly all the layers. So you can have, this is a case of a sub-ILM bleed. And these are the cases you want to go ahead, do ILM peel and do vitrectomy so that this heme is clean. Why you want to clean, do a surgery? It can clean by itself. Yes, that thought is always there. But sometimes it can cause retinal toxicity or visual requirement is there. Better to go ahead doing it procedure. Or you may have this large mold of heme and you do OCT. Here you can see it is the subretinal heme. It's not, the first one was a sub-ILM heme. And these are the cases, if they present within 2 weeks, you can think of doing a pneumatic displacement. And if they present late, yes, sometimes even when they present late, you still go ahead with the displacement. But these are the cases again where the recovery is possible by a surgery or a pneumatic displacement. If you look at this type of a hemorrhage, looks very typical like a subretinal heme. OCT is a very valuable tool. You do OCT, you can make out it's actually sub-RPE heme. So it is again not amenable to your surgery, not amenable to pneumatic displacement. Observation is the best strategy in these cases. Sometimes you may have subhyaloid hemorrhage. These are the cases where either you can observe if it is clearing, or if it is not clearing by itself, you can do a YAG and DYAG hyalodotomy and make this heme come in the vitreous cavity. You need to tell to the patient very clearly that there may be a temporary drop in vision because the heme comes in the vitreous cavity, but over a period of time, it will clean and the vision will improve. A very common feature which is seen, this whitening in the macular area called as commotion. And these are the cases where we don't do anything. It's observation. However, never give a prognosis because these have varying level of photoreceptor and RP damage. Sometimes they may, the whitening will go away, but it can leave RP atrophy or an area of photoreceptor loss, which may lead to a decreased vision. So never comment on visual recovery whenever you see a commercial retiny. Can sometimes have these large holes or macular holes. Sometimes in this case, you have a choroidal rupture along with a macular hole, traumatic macular hole. Traumatic macular holes, you can plan vitrectomy plus ILM peeling and gas. Usually you don't want to do it in acute trauma settings because there is a chance that these holes, this will never close. It's a large hole, but sometimes small holes may have a spontaneous closure. You can wait for about 1 or 2 months and then plan for your surgical procedure. Retinal detachment in a trauma setting, especially with a closed globe, is definitely needs early surgery because you have all the things. You have heme, fibrin, inflammation, all the components of a PVR are already present. So you don't want to wait for a long time. You want to go ahead do early vitreous surgery in these cases, vitreous surgery or buccal, but you want to attach this retina. A giant retinal tear, traumatic giant retinal tear, these are the cases, again, emergency. You want to operate as early as possible because, as I had mentioned, they have a very high tendency of causing severe PVR. And very soon, if you don't operate, it may even become an inoperable RD. So you want to go ahead doing early surgery in these cases. The subluxated lens, or again, needs a surgical intervention. You can plan based on the support and other things, you can plan for a lens with plus scleral fixating IOL. Sometimes because of trauma, you can have the whole intraocular lens with the bag going inside, and these cases you remove them, and based on again the other conditions, you can plan a scleral fixating IOLs in these cases. If you look at this, you have a typical feature of a central retinal artery occlusion, but you also have a optic nerve avulsion. These are the cases where visual prognosis is really poor. You need to explain the guarded visual prognosis. You don't need to do surgery, but sometimes when there is vitreous hemorrhage, not very sure about the diagnosis, and you have not got many times, even with VEP, which is bad, sometimes in an acute trauma setting, you still go ahead doing a vitreous surgery, but you need to tell when you have all these features, give a very guarded prognosis to these patients. The next step is, so once you have done the retina evaluation, then the next is plan your additional investigations. And that planning is based on whether it is an open or a closed globe. Open globe, definitely you don't want to put a probe of ultrasound on it. You want to do a CT scan, and closed globe can do both. The presence or absence of media opacities, clear media, as I told you, some cases OCT is an important investigation. And when there are media opacities, ultrasound B scan or a UBM, especially when you're looking at the cyclodialysis cleft anterior angle anomalies in eye where the gonio cannot be done. These are good ways to look at these structures, and you want to assess the functional aspects by doing a VEP. I'll just cover one of them, ultrasound B scan in the cases of blunt trauma. It's important to understand these hyperreflex. So this is an ultrasound of, okay, 1 minute. Yeah, so you have low to moderate reflective mobile echoes which are attached to the disc. This is a case of a PVD with a vitreous hemorrhage. On the contrary, you have another case where you have this a little more high reflective echo which is attached to the disc with a limited movement, which is retinal detachment. So this is important to differentiate retinal detachment with PVD and vitreous hemorrhage. Sometimes you get these hyperreflective echoes which are in the periphery. You see this dome-shaped elevation not attached to the optic nerve head, the choroidal detachment. You may have blood within it which will reflect as a hyperreflective dots. In these cases, you give steroids and wait for it for liquefaction and then take for surgery. How long to wait? Not more than 7 days. If it's not liquefying, go ahead with an early surgical intervention. Sometimes you may see a clear, like a clear suprachoroidal fluid there, where it can again resolve by itself with steroids. Sometimes you see this bridging vessel, which is in this convex. You can see this convex thing, hyperreflective echo in the periphery, not attached to optic nerve head, and you see this bridging vessel on this suprachoroidal heme. The next step is the further management. It's important that your management doesn't get finished by identifying and treating them. Many times you definitely want to protect the other eye, give them protective glasses. If they are one-eyed, you need to explain them about the need for regular checkups, because as I told you, they have all the components of PVR which promote PVR. So they tend to develop PVR quickly. Chance of retinal detachment is high. Secondary glaucoma is high. So you definitely want them to come on a regular checkup. And in some stage, when you have done your all best and vision is not improving, give them the benefit of low vision care or a vocational rehabilitation if required. So must understand whenever you're dealing with this closed globe injuries, the 7 rings, the various types of damages, and the 8 steps which are there to make sure that you evaluate these cases in a right way. Thank you very much. I'll be happy to take any questions.
Thank you, Rajiv, for a lucid presentation and how to approach a case of a blunt trauma. So I expect Dr. Jyoti and Dr. Mahesh to take over the discussion further.
Okay. I'm Dr. Jyoti. Very happy to be part of this ophthalmic trauma team. And thank you, Dr. Rajiv Raman, for highlighting the meticulous importance of the meticulous evaluation and how to plan management in closed globe injuries. Being in a government setup, we do see a large number of ocular trauma cases of all varieties involving the anterior as well as posterior segment. And we should remember that every case is unique, and it is very important to rule out the associated systemic ocular injuries in every case of ocular trauma, especially road traffic accidents and blast injuries. Sometimes the injury which looks very trivial may be associated with long-term consequences. We had a patient who came with an unilateral glaucoma, which was investigated, and on slit lamp examination, we found small sphincter tears, and gonioscopy was done to find angle recession. And he had even forgotten the trauma. Such trivial trauma can also cause ocular manifestation. We should keep that also in mind. And always we have to give a guarded prognosis in every case of ocular trauma. And because complications can occur years or months after the trauma. And I just have few questions. In what all situations we need urgent intervention in closed globe injuries? Because in closed globe injuries, we can always wait for some time. But there are certain situations where we need an urgent, immediate within 24 hours, or sometimes we can wait for 1 to 3 days. So can you just enumerate? You have already said most of the conditions.
Majority of things I have told actually, but as I told you, as you rightly said, many times these closed globe injuries, you don't have to intervene very early. But I would say a giant retinal tear, or no, if you have IOP which is uncontrolled, having hyphema, you want to evacuate it. But so depending on case from front to back, if I talk about unresolving hyphema, corneal blood staining, this again needs an urgent intervention. Retinal detachment comes in an early surgery. It doesn't need, but if it is a macula involved, macula is uninvolved, you definitely want to do surgery as early as possible. If you are suspecting occult rupture, definitely go ahead doing a global exploration as early as possible.
Suppose there is an expanding orbital hemorrhage or a compartment syndrome. Again, that is one thing.
Absolutely true. Absolutely true.
What is your line of management in such cases? There is an expanding orbital hemorrhage or a tight orbit, which is compromising.
So usually, as far as Shankaretrala, I refer it to oculoplasty clinic. But in general, I would say if it is though you can plan for a canthotomy, and if that's not recovering, they need systemic steroids too. And if canthotomy doesn't have medical decompression, or you go ahead doing a decompression in these cases.
I think every ophthalmologist should be trauma specialist, should be trained in trauma.
True. Absolutely
I think that is one thing that we have to think of.
I agree.
And
I
this,
agree with you.
This plan of nodal officers is also very good. We should go ahead with it.
I think Dr. Rupesh was the first and the last trauma fellow of Shankaretrala. It needs to be revived at many places because there is no specific trauma fellowship anywhere in the country. So because they need, as you rightly said, they need all the specialty exposure. They need exposure in retina, cornea, oculoplasty, especially these three in a good manner.
Very well said, Rajiv and Dr. Madam Jyoti ma'am over there. So every ophthalmologist needs to be a ocular trauma specialist, if not specialist, at least a primary treatment giver should be offering that role, at least so that the patient gets a primary care in the form of adequate and right suturing and then referred to the higher center. So it's now time for us to move on to the next presenter. Over to you, Sujit.
Yes, am I audible?
Yeah, you can. Sujit, go ahead.
Yeah. So our next topic is approach to the orbital trauma. The topic will be presented by Dr. Blanche Lim, and Dr. Gangadhar Sundar from Singapore will be joining the discussion along with Dr. Marian Pauli from Kochi. Dr. Lim, over to you, Dr. Lim.
Thank you very much. Can everybody see my slides?
Yes.
Okay. I'd like to first thank the Kozhikode Ophthalmic Society.
Can you change that to,
PowerPoint.
Full view, slideshow
From here?
view?
Slideshow view? Yeah. No.
But I think this is.
No, you need to
can
come
put full screen. Go back.
Yeah,
Yeah,
this is fine.
now that's fine.
I just wanted to thank the Kozhikode Ophthalmic Society for inviting me to speak on a topic that's very close to everybody's hearts. I have a lot of seniors and giants around whom I'm learning from continually, and I'm also grateful that Dr. Ganga as well as Dr. Marian are here to share as well as to discuss the experiences with regards to orbital facial trauma. So I was asked to talk about an approach, and I think we are always learning from the giants around us and the patients, and we're always looking towards the future to see how we can improve much better. So there are a lot of tomes of texts around us from which we can learn from, and these are the teachers whom I learned from as well. So there are 10 lessons that I have to share today, and the very first is that basic principles are extremely important. To us and to the patient itself, it is always important that we give the patient a very fair evaluation. An approach is very important to consider that the patient who has undergone trauma is vulnerable. The family is also vulnerable, and this includes both psychological as well as physical aspects. The nature of injury is also important to determine whether there was any mechanical trauma, any chemical injury, any thermal injury, or any electrical injury as well. The location of the injury is also important in the case of ascertaining medical legal aspects as well as compensation, such as that of the workplace, at school, at home, or elsewhere. And these 1 to 3 will be important to determine whether there was any foul play involved. Protection of the patient during the occurrence of injury is also important, whether there was any protective eyewear, whether there was any face shield that was present, and also whether the patient has any history of any tetanus immunization. And we will also talk about the systemic evaluation of the patient. So the first thing we ask ourselves, is this an at-risk patient? Is this ocular or ophthalmic trauma alone, or are there other related injuries? What is the urgency of these injuries to which we must rush into? What is the risk to the patient? And of course, we go back to our basic principles as we talked about, and we do our primary survey, inclusive of that of airway, breathing, circulation, determining whether there's any disability to the patient, and also the environment and the exposure of the patient. And so therefore, we come to lesson 2, that no globe is an island alone, and the eyes of the patient are always considered in relation to the face, as well as the other vital organ structures of the patient as well. And so it is important to understand the orbital facial anatomy, to understand that the orbit also has its adnexae, the soft tissues, as well as to understand the buttresses of the face that hold it up together. And to this, we look towards the international anatomical nomenclature for guidance. And also, we also remember that there are other structures that we should not forget: the sinuses, the outflow systems as well, because these have implications down the road on complications which may be chronic and may not be seen at a point in time. There are also certain structures around which we, to the ophthalmic trauma surgeon, is also critical. For example, structures such as the angle of the inferior medial orbital strut, the orbital foramen, as well as understanding where the posterior ledge is. We also understand that there are soft tissue structures around the orbit, which are also important in any form of trauma, and we may be called upon at any point in time to evaluate the patient. Over here is a patient who had undergone a blunt trauma to his face, but this had caused deep laceration. And you can see that over here on the X-ray, whilst there was only one little foreign body that was reflected, when you open up the wound, you do see that there are a lot more pieces of metallic foreign bodies that were removed for him, up to 40 pieces. There can be other forms of globe injuries. It may be very devastating. In this case, an open globe injury. Or it may be even a blast injury, okay, where there are many pieces of foreign bodies embedded all over the patient's body, even up to the cornea, and in this particular patient, even up to his recti, which required this insertion. There may be foreign bodies that may be also in the patient's eyes that may need to be removed, and also the involvement of the other adnexae. And this is important to enable us to determine the extent of intervention and the number of teams we have to pull in to be able to help this patient recover maximally. And so therefore we go to our next area, which is to determine the further investigations to evaluate injuries. Frequently, we look at the usage of and the utility of a CT phase, not with orbits alone, and we request for an IGS protocol rather than brain or orbits. In very rare occurrences, we may just rely on X-rays and ultrasonography. We do highlight magnetic resonance imaging in the instance of patients who may have embedded metallic foreign bodies, and this is contraindicated as well. So we go on to the next two lessons. Lesson 3, which is to speak the same language, and lesson 4, in speaking the same language, to understand a good documentation is critical, as spoken with the previous speakers for today. And this is important because definitions must be clear. This places each injury type within a comprehensive system of approach. It enables us to convey prognostication from one team to the other. Definitely to the patient, this is important in terms of compensation and medical legal purposes. And it also helps us to demonstrate the journey of therapy to the patient and the family, as well as the important stakeholders. And so I won't belabor the point anymore, okay, which was already brought up very well by our speakers for today. The classification systems and the evaluation of ophthalmic trauma are critical. Using the BET system, there are systems which Prof. Renkun has also elucidated in his book, namely that in open globe as well as closed globe injuries with mechanical trauma to the eye, which may be further refined after surgical exploration of the wounds. We do also employ the ocular trauma score, which is important in predicting final vision of the injured eye and determining rehabilitation and management. For fractures, we do use a series of classifications. For here, we have the Arbeitsgemeinschaft für Osteosynthesephagen classification system for the cranio-maxillofacial group, where they divide the cranio-maxillofacial fractures into 3 levels. We talk about simple and complex fractures. And of course, more recently, we also have Dr. Ganga as well as Dr. Rian, who have taught us that there is a very nice directed approach to describe orbital and orbital facial fractures, the A, B, C, D, E, F, G, and now H descriptors, which includes H, laterality, complexity, displacement, entrapment, foreign body, whether there is the presence of any globe injury as well, and involvement, and definitely, last but not least, the risk level of the patient. And so we talk about the other, and we consider the other fractures which occur as a complex, whether there is the presence of nasal-orbital ethmoidal fractures described by Markowitz and Manson, and we talk about the 3 different types over here. There are also the very classical Lefort classification of maxillary fractures, which are important to consider, especially in the area of repair, to enable us to restore the facial projection, as well as the involved sinus cavities, as well as the support structures of the face and the orbit. Frequently and more often than not, a mixture of classification systems may be required to enable us to understand the full extent of injury. Over here, we also do include, and a special note is the fact that we also include photo documentation of ocular movement, as well as that of full face photographs, which are also nice to document both for recording purposes, as well as to document the journey of recovery. Occasionally, a very good physical examination is sufficient, and this is where sometimes facial imaging may fail us. In this area, we do have a patient who has experienced a trapdoor fracture, and although on an initial CT orbits, the fracture site was not seen, he was, however, symptomatic, vomiting, having limitation in upgaze together with that of diplopia. And over here in the video, you can see that once exploration is performed, you can see entrapped tissues in a trapdoor fracture that is being released for him. And this is him after his recovery. The 5th lesson we have to share here is that timing of intervention is also critical. And over here, it is important to understand first the classification systems, to understand and delineate the full extent of injury. And then we consider the timing of intervention with regards to globe injury, as we have discussed previously in the previous talk, and also to understand the hierarchy of intervention with regards to orbital facial fractures. Just as a general rule of thumb, urgency-wise, broomstick fractures of entrapment and consequent vasovagal reflexes tend to be more urgent, followed by blow-in fractures, and nasal orbital ethmoidal fractures and unstable fractures, followed by the others. Sometimes we do find that we are held back more often than not because of our need to further stabilize the patient. We have here a patient who we struggled with because his fracture surgery did occur 2 months out from his initial trauma. And so therefore finding the sweet spot of timing for surgery is important. And we may frequently need to use other imaging systems in order to ensure that there is maximum and proper recovery and rehabilitation. So this is him with a very obvious inner thalamus here, with restoration of the inner thalamus post-surgery, just about 1 week out. The sixth lesson we have here for us in the event of an orbital facial trauma is what is the right implant we choose in the event that there is a facial fracture. And so therefore we think to ourselves, what is the ideal implant? Usually we think about cost and availability in the institution that we are with. We want to have an implant that is stable and strong, one that is able to fixate the implant down to stable bony landmarks to prevent migration or extrusion. We talk about and we consider the contour and handling of the implant that we are having. We also consider the biologic behavior. Ideally, this should be innate, i.e. to say that which is non-allergenic, non-carcinogenic, with a low risk of infection or a foreign reaction, and it's able to enable us to biointegrate easily. For permanent implants as well as bioresorbable implants, they should carry certain characteristics to encourage healing. And more often than not, we do have to also consider, and hopefully not quite too frequently, if implant removal is needed, this should be amenable to dissection for implant removal during secondary reconstruction. And so therefore, there are so many implant materials that are out there for us to use. They may be autologous, allogenic, alloplastic. There are permanent or bioresorbable implants. Over here in our institution, we have a mix of both. We are very fortunate to have a broad range. There are porosity of implants that we can use as well. And we think to ourselves whether these are stock implants or more often than not, and more frequently, and more in recent times, customized or patient-specific implants, which may also be unfortunately costly. So the question we ask ourselves is, do we want to use permanent or bioresorbable implants? And this usually is dependent on the location of the fracture, whether this is a rim fracture, and this is where we tend to use permanent implants, or whether there are wall defects. The size of the wall defect is of course important. And when we consider bioresorbable implants, we want to think about the rate of resorption as well. And so for us here in NUH, or the ones that we frequently use are that of titanium implants for our permanent implants. We do use rapid sorb as well as osteomesh quite regularly as well. And over here, I have here delineated just some advantages and disadvantages, or the considerations that I have and we have as a team when we look at our patients with orbital facial trauma. Sometimes you may need to employ a mix of implant types. Over here, we have a patient who had extensive cranial orbital facial fractures. And in here, we employed a mix of both titanium implants. We also use rapid sorb as well as osteomesh in view of the extensive involvement of injury for him, and he's recovered quite well since. The seventh lesson we have here is that no team operates alone. We learn to work within. We also learn to work with teams. And here in NUH, we do enjoy a very broad cooperation, an esprit de corps between all tertiary teams that starts from the emergency physician who hands over to the relevant teams, the trauma team, which includes that of the eye surgeons, the ENT teams, the neurosurgeon, plastics, oromaxillofacial, the anesthetist, and also hand in hand, we do work together with other surgical trauma teams, the internist and the intensivist. The eighth lesson we have here is that the traumatologist always has a constant challenge. We always have to evaluate the role of patient-specific treatment, and we always want to provide accurate treatment at accurate time. And so therefore we think to ourselves about the role all the time about intraoperative navigation as well as patient-specific implants. Over here, we do have the striker and brainlet navigation, which we use more often than not to ensure that implants are placed in the right position. We also have patient-specific implants here, which we have used for our patients, together with imaging modalities such as that of cone beam, CT scans as well, and also more often than not and frequently, we also starting to migrate towards that of augmented reality and mixed reality with that of the HoloLens. And over here, we have Dr. Ganga using the HoloLens to visualize defects in accordance with imaging that we have performed on CT scans. And so CBCT imaging is one of the forms of imaging which we find is increasingly a good alternative, cost-effective scan, which we are able to request for with regards to timing as well as immediacy and to evaluate the positioning of our implants. We also want to therefore highlight the last two lessons, which are also very important, and that's lesson 9 and 10. Lesson 9, which emphasizes that recovery is a long-term journey for the patient and as well as the teams involved. Frequently, it is not just the surgery that causes the patient to recover from their initial trauma with immediate effect. More importantly, more so than not, communication with the patient and key stakeholders is also critical. It is also important to understand that recovery may not always be a smooth process. And sometimes, and unfortunately so, rehabilitation may not be for visual purposes. Over here, we do have a patient who had polytrauma after a road traffic accident where he had degloving injuries of bilateral upper limbs as well as that of his left foot, and also had a complex cranial orbital facial fracture. We followed him through, and post fixation, there were some complications that occurred with continuous bleeding through his wounds, and he had to undergo a second surgery. And this is him after 2 months of a very long-term stay. And thankfully, he recovered very, very well. We do also have to understand that sometimes sight may be unsalvageable. We have here a patient who had no perception to light after sustaining an open globe injury. And for him, unfortunately, after the initial heroic attempt to salvage the globe, he eventually proceeded on towards that of an enucleation, together with that of reconstruction of a medial wall blowout fracture. And this is him with a conformer in situ, and he will therefore progress on for a prosthesis placement with that of ocularis. So when our part for surgical intervention is done, we do have to still walk with our patients further, sometimes learning and teaching the patient to undergo certain rehabilitation exercises is also critical. In this case, we do have a patient who is post-orbital floor repair, and he needs to be evaluated on a constant level, a regular level, and enable him to perform his duction exercises more frequently than not in order to rehabilitate to his full potential. And so we summarize here the 10 approaches to orbital facial trauma to understand that all basic principles are important, to speak the same language, to communicate across the teams. And although not all of us may always enjoy the wonderful cooperation between all teams available in a tertiary setting, it's also a good start to think that it might be important to build this in any trauma service, and to always ensure and to understand that your patient and your key stakeholders are also part of your team in the process of recovery. Thank you very much.
Thank you, Dr. Lim, for a wonderful coverage of the topic, very exhaustively presented. Let me request Dr. Marine and Dr. Gangadhar sir to have a few comments on the topic.
Dr. Lim, thank you so much for an very extensive, elaborate lessons we should learn. Or we should look for in a case of craniofacial trauma. I would summarize in a case of orbital trauma, basically we have to look for two things, like immediate management, late management, and immediate rule out of two things, like optic neuropathy and orbital foreign bodies. Sometimes orbital foreign bodies can be vegetative, like in our part of the world, I think we do get lots of stick injuries and all. So it needs to be tackled on an emergency basis. And second thing, late reconstruction.
So that can be planned and we can do accordingly. Dr. Gangadhar?
Yes, Marianne.
Yeah.
Nice to see you.
Would like to add on, yeah.
Yeah, good morning, and thanks to again Kozhikode Society, Kerala Society, and OTSI for organizing this. Thanks, Blanche, for doing a great job. In fact, I would say that you did a better job than I would have done in convincing the value of a complete holistic evaluation of the patient, comprehensive management. I always say that a patient who's been traumatized, no matter how well you rehabilitate, the patient is traumatized for life, both physically, structurally, functionally, and psychologically. So I think addressing that aspect, you highlighted that very well. It's a journey, a process, which I think is very important. One of the other challenges that happens in these ocular and adnexal trauma, ophthalmic trauma, is sequencing surgeries. When you have adnexal injury and globe injuries, who goes in first, who goes in second? Do you do it together? Do you stage it? That's an important aspect. And one of the take-home messages for working as multidisciplinary teams, even within ophthalmology, there are egos between the anterior segment surgeon, the posterior segment surgeon, the ocular plastic surgeon. And as surgeons, we all have big, fat egos. The essential rule is lay the ego aside, put the patient first, and do what is right for the patient. So if you have a large lid laceration and a globe injury, obviously you can leave the laceration alone. You can repair the globe first, and then put the eyelid back together. In fact, it gives you even wider exposure. And orbital fracture repair can take a back seat. And the last message I think I wanted to get across is one of the major disservices ophthalmology has done to itself is standalone eye centers, which either doesn't see the polytrauma with severe mutilating blinding injuries, or it disconnects the orbital oculoplastic surgeon, the ophthalmologist, from the head and neck trauma teams. And hence there's a lot of delay in care and lack of translation management. Hence, I think we should divide that gap between ophthalmologists and eye centers and the head and neck traumatologists so that we can combine services and offer the best outcome possible. A great talk, all the same. Any questions or comments from other panelists and experts, please?
Yep. Grover, sir.
Excellent presentation as always from the team. And what Ganga was particularly trying to highlight was the role that multi-speciality coordination in this plays. So we almost always work with the plastic surgery team, the maxillofacial team, sometimes the neurosurgeons. And it is the approach of combined effort, the ability for the team to function together smoothly, which gives the best outcomes. It starts from evaluation of an acute case to management of at a later date of fractures, which have to be done as a teamwork. So they put together the ZMC fractures before we can take up the floor, and so on and so forth. So it's really a very, very important thing to have this multi-specialty coordination. Working with radiologists has become so important, as was pointed out, because then you have the right volume measurements and have the 3D printouts and try and replicate the volume properly. And these teamwork has become the key to management of polytrauma. So that, I think, is the most important message.
Thank you, sir. Now it's time for want of time, we would curtail the discussion and move ahead to the next talk. Sujit, over to you to introduce Dr. Deepak.
Next, we have a cataract session, traumatic cataract, varied presentations, and the pearls in the decision making. We have as main speaker Dr. Deepak Megu, who heads the cataract and glaucoma department at Meguru Eye Care Center, Bidar, Karnataka. He specializes in complex cataract surgeries, and he's very committed in online teaching. He has got a very popular YouTube channel, which I'm sure most of you may be watching regularly, and he has got many awards and best papers and best video presentations to his credit. He has more than 200 presentations at various national and international scientific meetings. So I welcome Dr. Megur. The topic will be discussed by Dr. Chandrakant and Dr. Minu Martin, two prolific cataract surgeons from Kerala Society of Ophthalmic Surgery.
At the outset, I'd like to thank the Kozhikode Ophthalmic Society, the Indian Trauma Society, as well as Dr. Sujit for having me here. Thank you for the opportunity. And my topic is of probably more interest for the comprehensive ophthalmologist, the private practitioner, and a little bit less complex compared to the previous orbital injury session which we had just now. So thank you for the opportunity. So I'll be sharing my experiences with the traumatic cataract, and we all know that we come up with a lot of surprises when we are dealing with traumatic cataract. So let me start. It has audio.
Hi. Traumatic cataracts are extremely mysterious and
Is the audio audible from the video?
Yes, sir.
It's very difficult to interpret and understand them. Let me begin my presentation with the first case. This is a long-standing traumatic cataract in an elderly patient. Slit-lamp examination reveals the nucleus is decentered. Well, is it subluxated or am I dealing with an empty capsular bag? What is the status of anterior capsule and the posterior capsule? Can't tell presently. Is there any vitreous disturbance? Again, not sure about that. Well, the B scan is normal. So begin my surgery, and as I puncture the anterior capsule, I realize that the zonules are quite healthy. So it was very easy to perform the rhexis. But as I'm about to manage the nucleus, I realize that something is not right. I become suspicious. I inject OVD and push the nucleus aside to realize that I have a big PC tear underneath, which is probably pre-existing. Now, how do we go about in such a situation? I prolapse the nucleus out into the bag and I decided to go ahead with the IOL scaffold technique. A multi-piece IOL is placed into the sulcus and then the nucleus is emulsified above it. Well, the outcome was very good in this case and the patient recovered excellent vision. So in traumatic cataracts, one has to be ready for the surprises. But in this case, there was a clue. When I went back and looked at the biometer, the antechamber depth is unusually very large. And this should definitely have raised some suspicion about a pathology in the posterior capsule because the nucleus was quite posterior. So looking at everything is so critical when you're trying to deal with a traumatic cataract. You have to keep your eyes and all your senses open just to find out that you may not be missing that one thing. So like life, traumatic cataracts are mysterious. You never know what you're going to get. In traumatic cataracts, prognosis varies from poor to excellent depending upon so many factors. But in my experience, I have divided them into 4 important factors which can lead to a poor prognosis. And my 4 poor prognostic indicators are a presence of a posterior segment involvement, that is presence of a retinal tear or retinal detachment, large corneal tear involving the visual axis, presence of an optic neuropathy, traumatic or because of glaucoma, lastly infection. If none of the above are a factor in a concerned case, then the prognosis is quite good. Traumatic cataracts come in various different sizes and shapes. The first variant would be they may come with nothing at all, that is with an intact capsule and a healthy zonules but a history of trauma. Number 2 would be ruptured anterior or posterior capsule. Number 3 would be rupture of both the anterior and the posterior capsule. And lastly, we could have a subluxated cataract. But in all these situations, no matter what the situation is, invariably the prognosis is very good provided you have a good retina and a good cornea. So whenever we encounter a case of traumatic cataract, it's mandatory for us to rule out whether it's associated with a corneal tear, which is sealed or not sealed, rule out presence of intraocular foreign bodies, and always perform a B scan to rule out posterior segment pathology. And in many situations, presence of coexisting pathologies like corneal tear or posterior segment pathology, the case needs to be dealt with appropriately staged surgery involving multiple interventions, and obviously teamwork has a great role to play in such situations. Now moving on to the next case, this is an 8-year-old boy who has had a penetrating injury with a stick 2 days prior to presentation. This was about 4 to 5 years back. He has a sealed corneal wound. The wound is not in the visual axis, luckily. There's a split in the anterior capsule and the lens matter is swollen. The antechamber is extremely shallow and the pressures are high. When the anterior capsule is open, it's always mandatory that urgent intervention has to be done in such cases. The surgery is being done under IV sedation and a posterior subtenance block. The capsule is stained so that delineation can be done very well. Soft lens matter is aspirated out with ease.
In these cases, I think maintaining the antechamber is going to be extremely critical, because otherwise the split can extend beyond the equator and go into the posterior capsule. So maintain the chamber equilibrium becomes extremely easy, not allowing to shallow it or suddenly deepen. But as the last bit of lens matter is being aspirated out, I realized that quite a big posterior capsule tear is staring at me. Without withdrawing my irrigation cannula, I inject diluted tricot to check for any prolapsed vitreous, but thankfully there was none, and the anterior hyaloid was intact until this stage. When we encounter such a situation, our goal is to ensure that the posterior capsule tear does not enlarge and we don't have an anterior hyaloid rupture. By following the simple philosophy of maintaining the chamber equilibrium always, we can implant the lens into the bag, as I did in this case, and also remove the OVD behind the lens without enlarging the posterior capsule tear and without rupturing the anterior hyaloid. Post-operatively, the patient did extremely well and he enjoys an excellent vision. It is 4 years in surgery and I saw him a few weeks back and he continues to do well. Moving on to another variant of trauma, an elderly man with a blunt injury has presented with a subluxate cataract which is intumescent. There is 3 to 4 clock hours of zonular dehiscence. The first thing I need to do is to rule out a vitreous prolapse, and this is done by using a triamcinolone acetate. And in fact, it is confirmed that the vitreous is indeed prolapsed out. So before even we do rexus, it's mandatory that we deal with the vitreous first. Antivitrectomy is done, and then dispersive OVD is used to tamponate that area. Now I need to begin with my cataract surgery. The rexus is done. A capsule hook is used to support the area of zonular dehiscence, and then the CTR is placed into the bag. Now with these two instruments in place, the bag is reasonably stable so that I can go ahead and perform my phacoemulsification. The nucleus is emulsified. And once the cataract is removed, I need to deal with the vitreous still, because the vitreous continues to prolapse through the zonular weakness area. So in this case, I am going to the past plan approach to deal with the vitreous. Once it is done, a multi-piece lens is placed into the sulcus with the IOL trap technique, wherein the optic of the lens is captured in the rexus margin. These are the post-op pictures. Again, the patient had an excellent visual outcome. Moving on to the next variant of presentation. Now this is a 35-year-old man who presented with a workplace injury, and this is the picture. There's a corneal tear, a large foreign body is in the antechamber, there's a ruptured anterior capsule and a possible traumatic cataract. The B-scan does not reveal any posterior segment pathology at this moment. He is presented just about 4 to 5 hours after the trauma. The patient is counseled regarding the guarded visual prognosis following the surgery, and also explained the need for secondary surgery in the event of any subsequent complications like retinal detachment or infection which he may develop in the post-op period. Now this is how the eye looks in the OR table. We can see that the anterior capsule is split wide open, extending up to the equator on either sides. Let us be clear about the goals of the surgery. First thing would be to remove the foreign body, then suture the corneal wound, and then deal with the traumatic cataract. An incision is planned and created in an axis which is parallel to or oriented with the long axis of the foreign body. Under the cover of dispersive OVD, the large foreign body is extracted out gently. The corneal tear is then sutured. Once it is done, I'm having a look at the lens, and the lens needs to be dealt with now itself because the anterior capsule is already split wide open. In these cases, you get this intraoperative corneal haze, which makes visualization a challenge. But once the soft lens matter is out and we get a good glow, the management becomes much more easier. So this is some of the things which we commonly see when we switch.
It is not difficult to aspirate the soft lens, and once it is done, the intraocular lens is implanted into the bag. Now, before implanting the lens into the bag, I trim the anticapsule a little bit using Vanna scissors and forceps. For IOL power calculation, we did the biometry of the other healthy eye since the biometry of this eye could not be done.
So patient did,
and in spite of such a bad presentation, the patient did extremely well simply because his posterior segment was normal and the retina and other things were absolutely normal. And even with these sutures, he enjoyed a good visual outcome of a 612. The sutures were removed later. 2 years later, he came with posterior capsular opacification, which was yagged. And then again, he continues to do well. A 3-year-old boy with a penetrating injury 2 months back. We have a sealed corneal tear with a scar, traumatic cataract, a posterior synechia, and with a suspected anterior and a posterior capsular tear. The B scan does not reveal any posterior segment issue. The goal is to remove the cataract and put in a posterior chamber lens, either in the bag preferably or in the sulcus. Meticulous planning is necessary to deal with such situations because our ultimate goal is to preserve whatever anterior capsule and posterior capsule which is still present there, because if we can manage to implant a posterior chamber lens safely, that could provide an excellent visual rehabilitation for this young child. So our planning and surgical steps have to be extremely careful and very well planned. So the first thing I do is to go back with my bimanual cannula and begin aspirating the soft lens matter. After clearing one quadrant, the hands are switched. Very early into the surgery, I realized that the posterior capsule was already torn because of the injury itself. Vitrector is a great way to deal with such situations. Well, it actually acts like a multifunctional instrument. It's a vitreous cutter to deal with the prolapsed vitreous. We can also use it to aspirate the cortex. And also, it is helpful to trim the capsular margins, whether anterior capsule or the posterior capsule. Well, it's an invaluable tool to have in an OT, whether with traumatic cataract or otherwise as well. In such cases, if you can deal with the prolapsed vitreous efficiently and remove 100% of cortex, the outcomes are excellent in spite of the lens being placed in the sulcus because of the situation in this eye. And I'm following this case for the last many months and the child continues to do well. So to summarize, the traumatic cataracts can present very variedly. Thorough pre-op evaluation with good counseling to the patient is the key to ensure realistic expectations from them. A special note for the individual private practitioners who are practicing in smaller places. My recommendation would be to get equipped with 2 essential things: B-scan and a functioning vitrectomy unit. If you already have it in a phaco machine, that's great, because a reasonably skilled cataract surgeon can give good outcomes in these deserving rural patients if certain basic principles are followed. That's it. Thank you for the opportunity and thank you for watching.
Thank you, Dr. Deepak, as expected and as usual, beautiful videos. Now I expect the discussion to Dr. Kant and Dr. Meenu Mathan to carry forward the discussion.
CK sir there?
CK sir is there. He actually left in between.
Okay, then I'll add some points. Yeah,
Yes,
great
sir.
videos, Dr. Deepak.
and thanks for sharing all those. So I would have some points to add on to the finer parts aspects of the surgery. See, some cases in blunt trauma, even if we see a uniformly intact looking anterior capsule, they can present with a posterior capsule rupture also. Alone, standalone posterior capsule rupture. That is one point which we have to keep in mind, even though the anterior capsule is intact. And then some of these blunt traumas, they have zonular loss. In two ways they can have zonular loss. There may be a limited zonular loss with all the other zonules very much intact. And phaco in that kind of cases is much easier because the limited zonular loss can be easily dealt with. But some of them have diffuse zonular loss, and most of the zonules are present diffusely, but diffusely some of them are absent. So that will create a wobbly lens. A wobbly lens being dealt with is more difficult than the previous one. So another thing is vitreous presenting into the anterior chamber. See, as said before, we have to do a limited vitrectomy initially itself. Otherwise, we'll be dragging it along during all the maneuvers. But then, once we start doing vitrectomy, especially through the anterior route, vitreous keeps coming. So we keep doing vitrectomy. So a lot of vitrectomy if you do, there will be a lot of absence of vitreous in the anterior vitreous, and you will have the lens dipping too much into the AVF while doing a phaco. So a limited vitrectomy, especially with the staining, as Deepak has shown, staining, and once that is gone, stop, and then put viscoat or dispersive viscoelastic in that area so that it can plug. But during surgery also have a look at that area, because that area always you can have vitreous coming in during surgery, and once it comes to the port, it sucks in the vitreous, is not good for the retina, and also your phaco stops. That point identify and then cut the vitreous again. And one more thing is to have a VR surgeon near you. See, anytime your posterior, sometimes you will be lucky to get away with the posterior capsule tear and intact AVF and all this. So you might have a loss of nucleus piece or epinucleus pieces into the vitreous at any point of time, or even the assessment of the subluxation can be completely done only on the table. We don't know. 6 clock hours, it may look stable, but on patient lying down, always do the supine test on before surgery. Sometimes patient sitting up, the lens will be right in the pupillar area, but on the table you'll see that it's dipping into the anterior vitreous. So that also has to be done, and the VR surgeon's support also is very, very crucial when we are dealing with, as he said, see, we can give good results ourselves in most of the situations, but then when there is subluxation, vitreous in the anterior chamber and the lens is wobbly, please have either tell the patient that we won't implant the IOL or you may need a second procedure, or I do mostly in the VR routine nowadays and with the VR surgeon standing by. Thank you very much.
It is important to do a primary posterior capsulotomy and vitrectomy, particularly in pediatric age group, to avoid the subsequent interventions. I think that is an article what we studied and published in IGO.
Great. Thank you, sir. I think we can also have a vitreoretinal surgeon's perspective. Dr. Mahesh, if you are there, what would be your red flags for the anterior segment surgeon when you see a traumatic cataract as a VR surgeon? Mahesh, Dr. Mahesh or Dr. Gopal, if one of them can take over.
I think Professor Natarajan sir is here. I think we'll have his opinion.
Yeah, his talk is subsequent, so I can have your opinion as a red flag for the anterior segment surgeon when they see a cataract ahead.
Yeah, so whenever there's a traumatic cataract, especially in a child, you should, the first thing is it a penetrating trauma? So if it is a penetrating trauma, the whole thing moves into the posterior segment in a lot of times. One, with endophthalmitis, or two, with PVD, traction and rupture and all those things. And whenever we have a penetrating trauma, we should be looking for what Dr. Natarajan will talk now on the retained intraocular foreign body. So the second thing would be if there is a PC rupture, which is very eloquently dealt with in these videos which we saw right now. I think retained intraocular foreign body requires an evaluation. Maybe it requires an imaging, and that should not be missed. Just because you're seeing a cataract, don't jump into it, because you should do imaging to actually pick up if there is any foreign body or anything like that. And the nature and mechanism of trauma will give us a great insight into probably what would have happened. All right. And posterior capsular excess is definitely required to prevent further problems. Thank you.
Thank you, Gopal. I think you
Prashant
wonderfully
sir.
illustrated the role of vitreoretinal surgeon. As equally important is just finishing the IOL surgery is not important. There might be pre-existing silently lying posterior segment disorders, and so an evaluation after successful cataract surgery is equally important. I think.
Entry segment OCT also is important evaluation of posterior capsule. It is possible to evaluate posterior capsule with entry segment OCT.
Okay.
Dr. Chandrakant sir is there.
Dr. Chandrakant sir.
I would just like to add that all the aspirations which happen in the anterior segment with the PC open or vitreous has to be under very low parameters, especially the aspiration flow rate. While aspirating, it has to be very, very low so that it doesn't aspirate all along from the sides. We should aspirate only at the area we are planning to aspirate. Thank you.
I can see Chandrakant sir's name, but I think he's offline.
I think we can move ahead.
I'll just try, sir. Just a second. He just messaged me. Right. So you please introduce our next speaker, Narajan sir.
Yeah.
I'll talk.
So our next speaker is going to be Dr. Professor Natarajan sir. I think no one needs an introduction. Everyone knows him. In omnipresent person who is a Padma Shri awardee, which is one of the highest civilian award and ophthalmologist he has got. As an ophthalmologist, he has dedicated his life for bringing back the light in the eyes. Over past 36 years, he has performed more than 60,000 exclusive vitreoretinal procedures, and he has trained more than 68 vitreoretinal surgeons from across the globe. He has performed more than 200 complicated VR surgeries on pellet injury eyes in Kashmir, taking all the due risk and going over there and operating for government of Maharashtra, government of Jammu and Kashmir. And that's why he also got an award from state of Kashmir, that is state award to Dr. Professor S. Natarajan for his meritorious public service. He has multiple articles were published for Dr. Natarajan's dedication and commitment towards the service done for ocular trauma victims in Kashmir. The New York Times and many other newspapers and magazines all over the world carried this. He has been conferred with Chartered in Retina Hall of Fame, where only 2 Indians are listed. A proud moment for all of us. Dr. Natarajan and our own guru, Dr. Badrinath sir's name is there. So, along with the pioneers in the field of ophthalmology like Dr. Charles Shapens, Alvar Gullstrand, Jules Gonin, who are the big names in vitreoretinal thing. Has appointed him as an ICO Board of Trustees for the year 2018 to 20. The Sark Academy of Ophthalmology has honored him with SAO Excellence Award for 2018. I think I would continue with this in next 15 minutes. Before
I know.
I would request sir to continue with this.
Yes. Thank you. So I have to share my screen.
Yeah.
We'll have our own KOS faculty, Dr. Gopal S. Pillai from Amrita Cochin and Dr. Prakash V.S. from Comcast Eye Hospital, Kozhikode, as for the discussion of the topic.
You have to stop sharing. Thank you.
Sir.
So thank you, Prashant, and thank you, Kozhikode Ophthalmic Society, for having me. And I told Dr. Sujit yesterday I missed the coming to Kozhikode, and I would have loved to come there because last time I enjoyed very much. Wherever I forgot the name of the hotel, but really wonderful. So I'll share so you can see my screen. So I'm talking on intraocular foreign body. Today is the World Trauma Day. And I just read the internet, and I think Government of India is also doing a lot, and mostly head injury, and whole thing is to prevent the trauma and then the consequences. So in trauma, this is what I learned from Ferran School, strategic thinking, which is the individualized approach. Think again and again, what's the most suitable line of management for the given patient. In the previous presentation on traumatic cataract, a lot of discussions are there. And I always said the textbook or the publications are done after the injury has happened and how we are managed. A systemic approach based on scientific literature and genuine personal experience, and Ferran School rightly advised no trial and error basis. So I always recommend a two-step approach, repair of corneal sterile tear as a primary wound closure, which should be done by any ophthalmologist who is well trained to restore structural integrity and do the second stage, which will be seen. And this is the philosophy of International Society of Ocular Trauma. I'm happy this is what is my philosophy for long. Eyes with no perception of light should also undergo a primary repair, even when anatomical success is estimated to be less than 1%. And I always explain what is 1%. That is, if you have 100 patients and only one patient can be successful. And this is a 34-year-old male presented with closed funnel detachment, which looks like nothing can be done. And I'm happy at least the previous primary wound which was done, and probably the entire center of cornea was cut, and they have sutured and sent and said, actually nothing can be done, but still you can try, either go to Shankar, Dr. Natarajan, and they came here. So they have already been prepared, which is what I mentioned, that don't give any high hope just because an experienced surgeon is going to operate. And I think you have to reduce their expectations so that you can deliver. So you see, I'm doing a heightened the whole eye was with and you can see I tried injecting PFCL, but it's a total temporal retina, which is a giant retinal tear, which is torn and incarcerated in the nasal retina. And then I cut all the retinectomy, and now I put a endo elimination using the channeler way, and then using two forceps, I'm opening up the funnel, closed funnel, and then you can see PFCL I injected through the bray, and then you can see the retina is attached, and I use the retinal brush to straighten it, flatten it, which was a retinal massager introduced by Dr. Jonovich. Even retinal brush was introduced by Jonovich, and we don't have it in the 25 or 23 gauge. We only have it in 20 gauge, but you can see there is some amount of supracortical hemorrhage, but the retina was totally attached. So I think don't give up, and that's what is my advice. But at the same time, prepare the patient so well that they know what to expect, and that's the important part. And this was the pre-op and the post-op. You can see the retina was attached. And unfortunately, 3 months later, the patient had a recurrence, and then we had to reoperate again. And these are the, the clinical management, intraocular foreign body, location is important. That's why history is important to know the composition and size, delineating extent of ocular and orbital trauma, and decision to remove or leave it alone. And there's an increased risk of endophthalmitis with intraocular foreign body, and it can be difficult if the fibroscleral membrane or alveolus vitreous or retinal detachment provide your prolonging. So now Dr. Fensman has come out with the principle of 0 to 100 hours. That means the primary repair done at 0 hour, and then within 100 hours, within 6 days to 7 days, you should do the secondary intervention. We have several types of forceps, several types of magnet, including the rare earth magnet, and then electromagnet, and then this is a 13 millimeter opus, a Stornikov from Russia actually gave me when he came in 95. And this is there are publications of using ureter forceps. I've used ENT forceps in Indigo Hospital when I was operating a case. And this I made a suction over the forceps and called it a Natarajan forceps. And this thanks to Manish Papai and Mahesh Shanmugam, who have made a 4-pronged forceps made by, I don't have any financial interest, by India, and and then so the idea is to clasp the foreign body and remove. And PFCL, we use it for floating the foreign body, and we have to do all sorts of procedures. This is a patient from Kashmir, where you can see a meticulous corneal wound repair done, traumatic cataract with vitreous hemorrhage, and there was a submacular hemorrhage. So we actually did Dr. Kavita Rao did the cataract with the intraocular lens, and then I did the 3-port pulse spirometrectomy, went submacular space, removed the submacular hemorrhage, and used silicone oil. And I actually, this is again another intraocular foreign body, again a pellet-ocular injury, which was removed. And you can see already a lensectomy and a wound repair was done. And now I'm making an incision in the 12 o'clock cornea and sclera, and then removing the foreign body, grasping it within the vitreous hemorrhage before it rolls and falls out. The idea is so that even though it's a very lightweighted pellet, which is 4 into 4 millimeter irregular size or a polygonal size and made of lead, you can grasp it like this with the forceps designed by Manish Bapai, and then complete the close the wound, and then complete the 3-port pars plana vitrectomy, which is basic excision. And then sometimes PVD is not there in these sort of eyes because of the young age, and then you induce PVD, and you can see they're clearing the vitreous hemorrhage. There's an exit wound next to the optic disc, and I'm using the retinal brush to make sure nothing is incarcerated there, and treat it like a coloboma choroid and retina, and then do a laser around it, not close to the optic disc, so that you treat it like a coloboma choroid. And then, since the retina is attached and a good basic excision done, do a fluid air exchange and conclude the case. And then we can do a secondary scleral fixated IOL or a glued IOL and a second sitting. And that's what I recommend, because you can study the cornea and then the stability of the other parts of the eye too. And then we have this is a 76-year-old male with a traumatic hemorrhage who had a expulsive hemorrhage. And then, so this I'm doing after the primary work repair. Within a day, I interfered. Patient was injured in Lucknow, and then he was the chief secretary's father. And then you can see this is a second surgery where he developed expulsive during the first surgery. I'd used heavy oil, and the heavy oil is gone subretinal. And then I removed the subretinal heavy oil using the viscous fluid extractor, and it looks like a golden bubble. And usually the heavy oil sinks down, and you can see the total retinal detachment with PVR. There was a macular hole. I used repeated under the endodrainage and air, and then finally do a endodrainage through the macular hole, making sure that the macula is set. I don't recommend for any of the beginning surgeons to do that. And this is a PFCL oil exchange was done. And then this is that was done. And you can see there was a macular hole. I've done a laser around the macular hole, and the break was large in the temporal side and attached retina. And this is again a similar palatocular injury. And this was again an expulsive hemorrhage which had happened following a traumatic cataract surgery. So I told them to leave the surgeon called me, and there was a discussion about a vitreoretinal surgeon and a cataract surgeon. And I think if there is a cataract surgeon is operating and then has a problem and he doesn't have a vitreoretinal surgeon, better to have a dialogue with the vitreoretinal surgeon. And in case the patient can take an opinion and come, and then if something like this happens, this is rare, but if something like this happens, then the patient can be referred. And the patient, the surgeon asked me, what do I do? I said, close the wound and send the patient, and that's what is happening. And you can see vitreous hemorrhage, there was not much of PVD, and that's a problem with the young patients who have intraocular foreign body and trauma. And then you clear the vitreous hemorrhage, and then also use PFCL to clear the subretinal hemorrhage. And this was the post-op, 3 months post-op. And then this is again the patient who had a PK done, and then he was using his Sardar, he was using his whatever the thing to put the hair, and then this happened. So there was an expulsive hemorrhage, and so I do a drainage, and you can see a posterior sclerotomy is done. And I don't know, in spite of waiting for 2 weeks and saw in B scan a liquefaction, the suprachoroidal hemorrhage is draining very less. And then I used a vitrectomy and used perfluorocarbon liquid injection, like the Vinod Lakan pulse technique, which was published maybe 3 decades back, to remove suprachoroidal hemorrhage. And then you can see the suprachoroidal hemorrhage is being drained. This clot was quite thick, and I felt it was prematurely interfered. So that is again a judgmental thing. But you can see some part of the suprachoroidal hemorrhage was liquefied, and then it's being drained. So I was doing repeated increasing the intraocular pressure using the PFCL and also liquid, and then make sure that you can see that I'm using the and then finally did a PFCL oil exchange. So I mean, the problem with the oil is you can have a problem with the cornea. So a heavy oil may protect it, but again, I'm not sure, because even those eyes we have seen. And this is I think maybe the final video where I'm showing, which was taken in '92 when I was in this is 20 kg 3-port pars plana vitrectomy, then vitrectomy done. One boy and a girl, 5-year and 6-year-old, were playing with a toy gun in UP. And then I think it was a aluminum bullet which was straight went into the eye, and they came about 3 weeks later. And you can see now I will actually hold I did a fluid direction, but continuously it was oozing, the blood was oozing, and the surgery was under general anesthesia. And I'm actually, you can see the aluminum bullet within the eye. If you had a real bullet, the child would have died. And please make sure that, there's again prevention of trauma. I remember somebody was playing with a gun in Pune and then had this bullet going near the eye, and it's really risky. So I think if it's a real bullet, then you had it. I think the child would have died. So I have now removed. I tried. I thought sclerotomy will be too big, so what I did is I did a sclerocorneal incision, which I'll be doing now, and then we coated the posterior surface of the cornea with the viscoelastic. Now I'm trying to hold the bullet using the vitreous forceps through the port, and then I'm making the sclerocorneal wound with one hand. I use the blade that time. If you have a diamond knife, you can use it. And the idea is that it's better to remove transvitreal, transpupillary, transcorneal approach, and then close the wound. And this patient, they were not ready for a second surgery. I remember that they would definitely need for the vitreous hemorrhage and PVR a second surgery, because they couldn't clear the hemorrhage during this side. But when I removed the bullet, the parents were happy. That's another problem in 90s, when you just remove the foreign body, don't worry about the vision, was the philosophy of the doctor and the patient. And now they demand, and medical legal cases are there. But nevertheless, we have been trained in Shankar to explain that I operated the Operation Blue Star, the Bindranwala time in 84, and then IPKF in 87 in Sri Lanka, where they were admitted in the military hospital in Guindy, which is in Chennai. And then this is how the wound is closed. And then they say, if at 20 gauge, you can see that. So I'm happy I could get back the old videos. So this is again, we were discussing about the traumatic cataract, and this is a cataract. You can see the corneal wound done. So I decided to do a lensectomy and vitrectomy. So I always say that you have to decide what type of procedure is good for that particular patient. And that's why I said the strategic thinking, think again and again what is good for the patient, and no ego, see what is the best way to manage. And that's why I also written a chapter, after Steve Charles has written a chapter called Surgical Self-Education in Vitreous Surgery book. And I have written a book in Springer called the Cutting Edge Vitreous Surgery, where I have a surgical self-education chapter along with Dr. Asta Jain, that you check your own integrity, your experience, whether you can manage these sort of cases, and whether are you capable, whether you have instrumentation. You can't be searching the instruments on the operation table, and that's what Steve Charles has mentioned. You have to do a mock session the evening before with the fellows, with the OT staff, and make sure, until I have a game plan like a soccer, and always soccer team, you have a game plan, but the opposite team also will have a game plan. Here, the opposite is vitreous hemorrhage, foreign body, submacular hemorrhage, retinal hemorrhage, and so on. So you can see this patient has a subretinal hemorrhage, and then in the peripheral part there was a break, which has been, a laser has been done, and then you complete the three-port pass-penile vitrectomy, make sure the retina is attached, and then do that exchange. And this is an endophthalmitis patient. I don't know whether I have time. So this is again a patient with a stone injury, and then probably the stone was removed, and then the patient was sent. But they sent 20 days later. You can see necrotic cornea. I planned for a temporary keratoprosthesis and do the PK, but it was so bad. Oh.
He lost connection, or?
I think we have lost him. We otherwise also he was at the end of the thing. I think we can invite the discussion for the further.
Gopal sir, you can.
Yeah. Dr. Natarajan has brought in a very important perspective of planning. So whenever we have a posterior segment trauma, including foreign bodies, yeah, sir is back. So we'll just hear his final words before we move to the discussion.
Gopal,
Yeah, you continue, sir. You continue.
I forgot to put the laptop on charger. Anyhow, I think it's getting charged, but I came back on the mobile to answer the questions now. I think thank you very much for the opportunity.
I was just telling that, sir, planning and strategizing is a very, very important, as important or even more important than actual skills intraoperatively would be the planning and strategization, localization of the foreign body, where it is exactly, how are we going to plan it, and looking at what are the possible problems that we are going to encounter while we are doing the vitrectomy. Where is the detachment? Where is the traction? Where is the sclopet area? Is the foreign body impacted? What are you going to, how are we going to remove it? Through the sclera, through the limbus? Are we going to disturb the lens? What are we going to do about the intraocular lens? All those strategization has to be done pre-operatively. And that, I think, is a very key thing in
Hello.
Hello.
He's also yeah.
Dr. Prakash, you can continue the discussion.
Yeah. Natarajan sir, it was an excellent talk, and it had been, as always, great listening to you, and especially really appreciate those cases where those closed funnel retinal detachments with subretinal hemorrhage. Anybody would hesitate to take those cases. You have done so well, and it's really nice. And one thing I want to add on to what Gopal was, the strategization, that's very, very important. And what I see many times, upcoming surgeons in intraocular foreign body, one take-home message I would like to add is, always never forget or never delay your dilated indirect ophthalmoscopy, because localizing the foreign body with the naked eye with an indirect ophthalmoscope is possible, because a traumatic cataract will develop within few hours. The cataract will become completely total cataract within a few hours. So in the hurry for medico-legal documentation, imaging, CT scan, MRI, you might forget to do a indirect ophthalmoscopy, careful indirect ophthalmoscopy. So that is very, very important. Never forget to do that as early as possible, as quickly as possible, before the cataract becomes mature or a total. You do a indirect ophthalmoscopy and localize the foreign body, because nothing can replace that. And rest of the things what Gopal said, I totally agree with him. It's very important to plan. You should have the proper instruments. The timing of surgery is very, very important, especially you can do it as an emergency procedure if you are well prepared. Otherwise, always do it as a planned procedure after proper planning. So one thing, I don't know whether Natarajan sir is there. I wanted to ask him.
I'm there.
Yeah,
he said, if there is a clear lens and intraocular foreign body, would you sacrifice the lens in those cases? Prefer to sacrifice and take it through a limbal route, or always you take through the scleral route?
What is the size of the foreign body?
Say it is a moderate size, more than 6 mm, 6 to 10 mm, or around 4 to 10 mm, say. Foreign body, not a very small foreign body.
No, the main thing is, if you do a sclerotomy, you should know, in spite of all the basic excision, there is risk for retinal dialysis post vitrectomy. So I think if there's a possibility, and I rarely seen a clear lens with such a big foreign body without a so if possible, I think I don't remember having removing a clear lens, but most of the eyes are having problem of hyphema. You can't see. So you have to do a lensectomy, vitrectomy. And as I showed that bullet being removed, that aluminum one, I do a scleral, as a trans corneal, because that's better than removing through the pars plana. But if it is less than 5 millimeters, I do with the pars plana. Pars plana sclera, yes. But you have to remember that,
You have any preference of silicone oil over gas in these cases of foreign body? Because I feel there is a lot of epiretinal proliferation. Whether once it has impacted the retina, there is a lot of epiretinal proliferation that we see in spite of having an attached retina in this case of intraocular. So do you feel silicone oil will prevent to some extent rather than gas?
Prevent what?
Epiretinal proliferation and complications later.
No, this is what I always learned from Dr. Jovanovic, because when I went to Madame Bonnet in Lyon, Paris, she said, "Oh, you went to you are a student of Jovanovic, you are a Siliconovic," she used to tell. They spoiled the name that silicone oil will do everything magic. No. And that's what John Scott did by just injecting oil. Oil will not do magic. You have to do the, like as Gopal Pillai said, you have to plan the vitreous surgery and remove all the vitreous. And wherever, see, if you have seen severe trauma with lensectomy, vitrectomy, with base excision, when the retina was attached, I used gas. But if there's a PVR, retinectomy done, and I think gas will not work, so you have to use oil. But under oil also membranes can happen. And then under oil also subretinal proliferation can happen. See, oil is only a tamponade. It cannot prevent anything unless a lot of like daunorubicin and so many things, 5-fluoroaerosol, everything they tried, but it's not working. So we have to get some anti-PVR drug. And I think there's a trial by my friend Dean Elliott, chairman of Harvard. He is doing weekly methotrexate. I don't know, I was not convinced. Weekly intravitreal methotrexate following trauma for avoiding the PVR, which I'm not sure. They did a trial. I don't know what's the result of that. The only thing I want to convey with the last video is the patient was sent 20 days. So I always suggest we should do the 0 day, the wound repair, wherever it is, the smallest part in India, where everybody is well trained. Then immediately refer to a tertiary care center, maybe 100 kilometers away, 200 kilometers, by making sure, take photographs pre-op, intra-op, and whatever post-op, and the same day, tell the patient that I've called the doctor, make sure you go. Sometimes they'll say, bus name, I didn't get a bus, or I didn't get a train, all that. But what I'm suggesting is, every ophthalmologist in the village or any remote part of India they're operating, they should have a license with if they are trained in a tertiary care or anywhere nearby in a city, and then call them and make sure that you tell them the patient is coming, maybe they are coming, they take appointment at 2 and reach at 4, but take them. And then always tell the first surgery was done wonderful, but still we'll do the best. The reason is not only supporting, I think psychologically they are traumatized by I think Gangadhar Sundar was saying once trauma is a continuous trauma, but I think we have to make sure they're psychologically known. Same time telling all the risks so that you lose the eye, and not only vision, lose the eye, and whether there is a possibility you can save the eye. So without giving false hope, I think we have to do, and I think that's why now I tell them, in spite of every day talking this, somebody has an injury, the eye is gone, no PL, they come. I have to explain again. The reason is, whatever is your experience, still the patient expects, no, I heard, sir, you repaired that fellow, he's doing well. Okay, you're doing well, but we don't know whether you'll do well or not. So I asked repeatedly, I'll do my best, and if you don't see, what do? I said, you have to thank God. Whether you see or you don't see, thank God. If you're ready, then come back for surgery. So early referral and do the surgery within 6 days. Earlier they told 14 days is the second window. Ferran Schoon and we have decided that better to do 6 to 7 days. Don't delay more.
Thank you very much, sir.
Thank you very much, sir, for all the comments. Thank you.
Thank you, Gopal.
Thank you, sir. Can we move to the next?
Meenakshi has joined from Delhi.
Yes. Delhi was supposed to be on traumatic macular hole. We'll jump the line. Dr. Natasha has to attend a KSOS meeting. So next talk is traumatic optic neuropathy, current guidelines by Dr. Meenakshi there, who was here is still a KSOS member who spent almost 2 decades in Cochin, who established the Department of Ophthalmology at Amrita Institute of Medical Sciences, has now relocated to Delhi, and I think she's again relocating to Rishikesh. So welcome, madam, and the discussion will be by Dr. Natasha Krishnan from Amrita Institute of Medical Sciences, Cochin, and by Dr. Dalia Krishnan from Kozhikode Ophthalmic Society. Over to you, madam.
Thank you, Dr. Sujit, for inviting me to this wonderful array of topics on the Ocular Trauma Day. And it's a pleasure to be meeting all my Kerala friends. And it's a privilege to be speaking in the presence of my teacher, Dr. A.K. Grover. I'll start my sharing. I hope my things is visible. Can I start?
Yes, madam, please.
Yeah. So coming to traumatic optic neuropathy, it's the acute injury to the optic nerve from direct or indirect trauma that results in visual loss, which may not improve with or without treatment. It is found to be in 0.5% to 5% of all closed head injuries and in 2.5% of patients with mid-facial fractures. The site of the injury could be either the intraorbital or the intracanalicular or the intracranial. The intracanalicular is the most common one since there is a tight compartment, and these patients, the only clinical sign may be a relative afferent pupillary defect, and the fundus would be normal, and it will be only after 3 weeks that there will be an optic nerve head parallel. This injury occurs, and it is the optic nerve is most vulnerable to the shearing effect between the fixed and the mobile portions of the nerve at the beginning of the optic canal. Apart from the mechanical shearing forces, the other damages which can occur secondarily to the optic nerve is due to inflammation, lipid peroxidation, bradykinin release, apoptosis, and demyelination. And all this leads to visual loss. It can be either in the setting of a patient who's conscious and complains of the visual loss following trauma, or many times it is in an unconscious patient who has multiple fractures, is intubated, and has a low Glaucoma score due to traumatic brain injury. Here, only the RAPD will be the indicator, and visual loss, if this RAPD is missed, may be discovered only weeks later when the patient comes up. And this can emerge as a medical legal issue. The trauma is always a Pandora's box, and the nature of injury could be anything from assault to stab wound to, apart from the most common, which is the road traffic accident in India. It could also be iatrogenic due after a simple blepharoplasty, lateral anesthesia. And the most important is prolonged orthopedic or neurosurgical procedures with the patient in a face down position where malposition of the face on the headrest may inadvertently occur and tamponade the cone. The mechanism of injury could be either direct or indirect. Direct injury to the nerve could be due to a penetrating injury. The optic nerve axons or vascular supply may be damaged due to the strain. There could also be a compressive optic neuropathy secondary to the intraorbital hemorrhage, producing an orbital compartment syndrome. It could also be an intrasheath hematoma, which may lead to edema. But the one which has a worst prognosis is the fracture of the optic canal. There could also be a laceration with bony fragments or other foreign bodies. The indirect traumatic optic neuropathy is more common, and head injury in this case may be mild, and all one may see is a scar on the lateral 1/3 of the eyebrow. And it could be either of the anterior or the posterior type, depending on which anterior is to the entry of the central retinal artery. The direction of the vectors of injury forces is that it immediately attacks the optic canal, and the optic nerve may get injured here. The anterior indirect TON is generally due to a blunt trauma, and there could be a complete avulsion of the optic nerve, and thankfully it is rare. There is a hemorrhage at the optic nerve head, and here the optic nerve is forcibly disinserted from the retina, choroid, and vitreous, and the lamina tuberosa is retracted from the scleral rim. These patients may have a hyphema and a vitreous hemorrhage that may obscure the view of the fundus, and in these patients, if we do an ultrasound, we may be able to detect it. This is one of the patients reported by Girdhar Eye Institute in IGO, where in a 6-year-old child, first it was an incomplete avulsion, which went on to becoming a complete avulsion. In posterior indirect traumatic optic neuropathy, head trauma is the cause, and the only thing which you see is RAPD, as I've already said, and there would be an normal ocular examination, and also a normal MRI and CT may be there. Most cases are following an RTA, and in patients who are driving two-wheelers, classically in India without helmet. It is a concussive injury, and there could also be a fronto or maxillary bone trauma. The transmitted forces damage optic nerve at the orbital apex at the intracanalicular part, and there could be shearing of the optic nerve and its vascular supply in the optic canal. The International Optic Nerve Study Group, the demographics that they found was that most often it is in males, young ones, between 20 to 40. Left eye seems to be more involved. And apart from the bike accidents, it could also be the abusive injury in small children, or an assault or a fall. In 1/3 of these patients, there could be loss of consciousness, and these patients could also be having a headache. The visual loss may be very profound, going up to no PL. There would be a color vision defect if vision is present. There would be a altitudinal visual field defect. 1 in 5 present with a subconjunctival hemorrhage. The disc may be hyperemic or normal in more than 50% of patients at presentation, and in some there may be a temporal pallor. The craniofacial injuries in 75 to 85% of patients of TUN cases may be found. VEP can be done both to confirm and also has predictive value. The imaging of choice here is a CT scan of the brain and orbit with 1 mm thick sections with bony windows, and MRI is useful to rule out intrasheath hemorrhage. Here one can see one hematoma tracking along the posterior globe, or one may see a hematoma tracking along the optic nerve. One can also see an extracorneal hematoma. All these were the findings of one patient. In another patient, there was an intracorneal gas could be found within the nerve sheath tracking down along the optic nerve, and there may be other areas of gas present in the orbit without any intracranial presence of this thing. There could also be a fracture of the optic canal roof, which may be picked up and along with other fractures. So there has to be a very, very diligent application and interpretation of these CTs by the radiologists. If it has incidentally been found that the peak systolic velocity is increased in the central retinal artery following at the indirect TON, and it may be unrelated to the amount of visual loss. In the visually evoked potential, the latency is increased and the amplitude is decreased. In OCT, which is a tool now which is being used for everything, here in traumatic optic neuropathy, there can be thinning, which can be detected first in the GCC at around 2 weeks and later in the RNFL. And at presentation, both may be normal. So there is no point in trying to order an OCT at presentation. Luckily, 50% of these patients have a spontaneous recovery. It starts 3 to 4 days after injury and peaks at 3 to 4 weeks and can occur up to 8 to 12 weeks. These patients may have an altitudinal scotoma, which is because one of the short posterior ciliary arteries may be involved, as we know that there is one artery present above the nerve and one below. The steroids in this situation, the idea came from the second National Acute Spinal Cord Injury Study, and where within 8 hours of trauma, they were giving high dose of methylprednisolone. But when they tried to apply it and do a formal study with the crash, they had to abandon it because there was mortality in severe head injury patients. And also the other choice of surgery management is the open, the optic nerve decompression, which may be open or endoscopic. Endoscopic is more popular. Here in this picture, you can see that the optic nerve canal has been released by removing part of the optic canal. And the International Optic Nerve Study Group, when they tried to randomize this study of using extracranial optic canal decompression along with megadose steroids or steroids alone, they later changed on the type of study also, but there was no final conclusion and there was no clear benefit was found for either corticosteroids therapy or with optic canal decompression surgery. So in treatment of indirect traumatic optic neuropathy, the treatment still stands controversial. we should avoid steroids in patients who have severe brain trauma, have CSF rhinorrhea, have systemic traumatic injuries, and traumatic brain injuries. And they classically say that there is no use of giving steroids after 8 hours of injury, but patients do, normally people do end up giving steroids, IV methylprednisolone, if patients present between 72 plus. Please remember, do not give if the patient has a low Glasgow score. So the other things which have been tried are at erythropoietin intravenous. 2 pilot studies have been found, have been done, and they gave it 2 to 3 weeks after the injury. The rationale was that it would provide neuroprotection and support axonal growth. The improvement in vision was found. Also, they have used levodopa, again for a neuroprotective effect, along with the steroids given within 6 days of the injury in 32 patients, and they found that 9 patients improved. There are many other neuroprotective agents which have been used, like hypothermia, glutamate inhibitors, and FK506 crystalline. There's a recent report which says that there is actually evidence of contralateral visual tract involvement also after damage to which is unilateral. And there are also, to study and understand TON, there are many, they're developing a head model with the biofidelic orbit to understand the pathophysiology of this disease. So in the points to ponder are, when we are approaching a patient with all head trauma, we should assess the vision. In unconscious patients, we should remember that TON should not be missed. And it may end up delayed in patients with severe trauma. Imaging surrogates the diagnosis. Pupils may be the only thing which is abnormal. And this was a very interesting article which I came across. And let's hope that there is good coordination between all the specialties, so the radiologists can actually ensure that this is a patient in which ophthalmological consultation should be done soon, because the patients go in for imaging immediately after arrival, even when the trauma is very severe. And there are many unanswered questions, whether and to what extent inflammation, altered metabolism, or other processes occurring outside the optic nerve or retina influence optic nerve injury, degeneration, and/or recovery. And to what degree do other neurological deficits after traumatic brain injury influence recovery? Also, what are the possible approaches that could be used to provide effective treatment for traumatic optic neuropathy directly or for secondary processes that contribute to worsening of optic nerve injury after head trauma? To conclude, no confirmed protocols are there for prevention, mitigation, or treatment of this disease. Most reports are anecdotal. We need to have a robust database to identify patients with TON, develop both in vivo animal and virtual human models to study mechanism of damage and potential therapies, and development and analysis of clinical databases should be there to better understand the natural history of this condition. Thank you for patient hearing.
Thank you, Madam. Dr. Natasha, can we have a few quick comments on the topic? Also, Dr. Dahlia, please.
Thank you. Thank you, Meenakshi ma'am. That was an excellent presentation covering all the known facts, the unknown facts, and the controversies that exist around this topic. And since we are running out of time, you already summarized what are the injury signs to look for when we have to suspect traumatic optic neuropathy. We said we should not miss it in an unconscious patient. We should not miss checking the pupils before we dilate and examine for any retinal injury. And that will probably give us the greatest clue regarding the existence of traumatic optic neuropathy. One question to you is there a window period, if at all we are starting IVMP? I know that's still controversial, but
I would say that like in the data, they have shown that within 72 hours, yeah, we should start IV methylprednisolone therapy. But beyond that, it is within 72 hours.
Within 72 hours.
And the earlier, the better. But we should ensure that the patient is not having any of the like a severe trauma, and in those patients try and avoid it. Actually, when they try to, with the literature that we have, they use much higher doses. In India, we use much lesser doses. So we actually should do a thing in our Indian, everybody says on a podium that don't give methylprednisolone, but they actually do give it. So there should be a more true representation of what we do, and so that we can analyze our results in a much wiser manner. And that's what I would like to say. And this optic and a good vigilance around the time that, because especially when I was at Amrita, we used to be called for these consults. And I remember still that there was one intraorbital hemorrhage which was causing an TON, and this happened around 15 years ago. And one had neurosurgeons intervened, and there was a optic nerve sheath fenestration done, and the patient is still going on with 6/6 and an altitudinal defect, and is a very thankful patient. So this is something, simple measures can go a long way.
Yes, ma'am. And that brings me to the next question. Surgical decompression, if it is indicated, how early should we go about it?
See, once you get the imaging and you know that you need to do it, it's the neurosurgeon it should be done as early as possible.
I think both the IVMP and the surgical decompression should be in conjunction with the neurosurgery opinion, because they can give us an opinion about the head trauma as well, and about the timing of
a combined approach. So you'll be good at that with your neurosurgical approach coming from home.
Yes, ma'am. Dr. Dalia?
Yeah, thank you, Meenakshi ma'am, for that elaborate talk. You've covered all aspects actually. I just wanted to know, because these patients with TON, they are very anxious, they have a very anxious bystander. They may come early, they may come late to your OPD, and they need to be given some sort of solace in the form of what natural history of the TON will be, and when they can expect any improvement. What can we tell the patient, ma'am?
Actually, I feel it's one has to be frank, because if you give a person a false hope, the patient ends up, you have to put it in words that it doesn't come as a shock to the patient, but one has to be clear that although things are seeming normal, we cannot prove that the patient's recovery will be there. Because as I said, in more and more patients, the optic nerve head is normal at presentation after optic trauma. After the trauma, it will be only 3 weeks later that it will appear. We can tell them to come back for an optic for an OCT after 2 weeks, and then maybe if we start seeing changes, where then we can say, see, there are two scenarios. Either the vision is bad, you have to tell the patient, will it improve or not, or if it is to improve, how much will it improve, and it becomes actually very disheartening. And the only thing which I say, like another speaker had said somewhere else, is that these are the best people to educate the public that please wear your helmet, so that the number of people with a similar thing, it's very, very disheartening to see a 25-year-old coming with a PL negative in one eye and not having any reports.
Exactly, ma'am, exactly. In fact, since RT is one of the main causes of TON, I think the safety measures, and I think we'll do some public campaigns as part of our alert program also about the safety aspect. How can we prevent, about the seat belts and the helmets? I think that's very important. Rightly pointed out. Thank you, ma'am.
We'll go to the next talk. We'll try to.
Thank you, Dr. Sujit.
Thank you, madam. Thank you very much. Thank you, Dr. Natasha and Dr. Dalia. We'll move to the next talk, that is traumatic macular hole by Dr. Prashant Bawankule. Will be discussed by Dr. Vivek Dave, vitreoretinal surgeon from LV Prasad, Hyderabad.
Yeah, I need to share my screen. Is my screen visible? Hello?
It's visible, Dr. Bawankule.
Yeah, thank you. Thank you, Vivek. So it's time for me to speak about traumatic macular hole. Well, trauma is the second most common cause for development of macular hole, and the incidence in a closed globe injury is as high as 1.4% versus open globe, which has 0.15%. They have a classic features that they are seen more commonly in young and males because the trauma is more predominant in this particular subset. And they have, unfortunately, poor visual acuity at presentation, and somehow they do not have correlation between the visual acuity and the size of the macular hole seen on OCT. And importantly, as already Dr. Rajiv Raman also has pointed out, that spontaneous closure is not unknown in this particular category of macular hole. These macular holes have associated retinal morbidities in the form of choroidal tear, commercial retinae, horseshoe tear with a subclinical RDs, hemorrhage, choroidal ruptures, which can further alter the prognosis of management. You can see a lamellar hole here over here, a subretinal scar in this particular case. Well, mechanisms in a blunt injury can be countercoup, or and in this cases, immediate visual loss is because of primary dehiscence, while the delayed visual loss is because of the dehiscence of fovea, which happens because of a pull from a vitreofoveal adhesion. Classically, these holes are more horizontally bigger. They have a more diameter, horizontal diameter is more, and that is what we call elliptical. And on OCT, you can see larger basal diameter, basal area is more, the retinal thickness is less, and they might have PVD, not necessarily. Spontaneous closure happens in 10 to 40% of the patients, especially in younger age group, and this happens as early as 2 weeks to 1 to 2 months. And what are the OCT predictors where you should wait for surgery rather not rush through is the absence of PVD, smaller holes which are less than 300, 400 microns, and the absence of intraretinal cyst. This is one of our case. This patient presented to us 1 week post injury. You can see a classic macular hole over here, as you can, but the hole size was small. We washed him, and 4 months later, you can see the spontaneous closure of the hole. And these are the various mechanisms why a hole can close spontaneously in a case of a trauma. So when do we intervene? Preferably after 3 to 6 months, especially in young patients with small holes and good visual acuity, and if they have a PVD which is attached. Early vitrectomy is mandated only if the macular hole is too large, which usually say 700, 800 with associated RP abnormalities, and in pediatric patients where a fear of amblyopia development because of delay is likely. And the surgical option is vitrectomy with ILM plea, which you can do an inverted flap, and here the anatomical success rate is as high as 93%, but somehow the functional rate success is not as rewarding as in a case of a idiopathic macular hole. I'm going to share a few cases from our series. This is a pre-op OCT of this traumatic macular hole. As you can see, after doing the vitrectomy, staining the ILM peeling being done, and the flaps, because this hole is more than 700, 800, I have planned for an inverted flap technique, and under fluid I'm doing, and then at the end of the procedure, that is at the completion of FACS, we are stuffing the inner flap into the macular hole. And this is the picture for you, pre-op and the post-op, where you can see the macular hole has adequately closed. This is case 2 here. Because of the cataract, the view was not that good, and this is a small macular hole, less than 500 microns. We took him for surgery about 4 months later. Here, what happened after the peeling? Usually, initial days, I used to do the stuffing of the ILM under air, and while I'm trying to do the whole stuffing into the air, unfortunately, it comes into my forceps and it gets dislodged. But what we learned from this is that there is no necessity of doing an inverted flap technique in macular holes which are smaller than 500 microns. And here, in spite of losing the flap, well, just by ILM peeling, we could have an adequate macular hole closure. Case 3, this is a very large macular hole. As you can see during the video, the size of the hole is as big as disc, almost 1500 microns. Well, after completing the vitrectomy, I'm peeling the hole, peeling the ILM, and then under PFCL, after putting the PFCL, I'm stuffing the flaps into the hole. And you can see the post-op closure. Here, we couldn't achieve type 1 closure. It is a type 2 closure where the size of the hole reduced and the edges which was elevated came down. Well, this is an interesting case of a traumatic macular hole where you can see a large macular hole along with on its two sides, two lamellar hole, which you can see well even on an OCT. Well, what we decided to do is to continue with the same strategy of doing a vitrectomy ILM peel and to stuff the ILM into the macular hole as well as lay the flap over the lamellar hole. And the same strategy worked, and you can see I'm peeling and stuffing into the full thickness macular hole. And this is the end of the surgery and beautiful closure on OCT. This is 4 weeks post-op where you can hardly see the hole as well as the lamellar holes in both the case, OCT as well as color picture. Well, not all traumatic macular holes are just plain macular holes. They might have associated retinal detachment along with it with a severe PVR. So in such cases, you have to treat the associated retinal comorbidity in the form of detachment. Here, there is a severe peripheral PVR. So just peeling the ILM and stuffing it here is not going to help. You have to relieve the peripheral traction. Then only the macular hole will collapse along with the flattening of the retinal detachment. And you can see at 1 month post-op with silicone oil in situ, the whole closure is there, even in such cases. And this is the last case. Well, sometimes you have associated anterior segment comorbidity where you have a subluxated cataract along with a traumatic macular hole. Well, we have done here a phaco with a CTR, put the lens, and then after putting the lens over here, I go ahead with the CTR being put inside the subluxated lens. So it's a combined surgery where after closing, a standard vitrectomy being done and the ILM being stuffed into it. And this is the picture at the end of it. So, well, to conclude, traumatic macular hole. Trauma is the second most common cause for development of macular hole. They have poorer visual acuity because of mostly associated injuries into the retinal tissue and the other organs. Spontaneous closure is quite common in 15 to 40% of the patients who are younger with smaller macular holes and in the absence of PVD. And therefore, it is preferable to delay surgery for 3 to 6 months, at least in small macular holes with a PVD absent. And the procedure of choice in this case is going to be vitrectomy with ILM peeling with C3F8. Thank you.
Thank you very much, Dr. Bawankule. I think very nicely elucidated in his videos all the possible scenarios in which a macular hole can occur and how you go about its management. For the want of time, I will just ask you one question, Dr. Bawankule.
Yes,
given a case of macular hole, do you have any working clinical guidelines based on which you decide whether you are going to operate or are not going to operate a given case of macular hole post-trauma?
Yeah, basically because Vivek, I have seen that unless it's a very badly scarred RP over there all across the posterior pole with a large macular hole where, well, the case number 2, which was a large macular hole as big as the size of a disc, you could see case number 3, I believe. In that case, even though RP was atrophic, the patient had he moved from 3/60 to 5/60, and he could appreciate. So in younger age group, I would definitely like to give benefit of doubt to the patient. But yes, if it is a badly scarred macula, I might not do it. But otherwise, I would definitely give benefit to the patient.
Yeah, I think that's an important message, that because these patients are largely young, even if we feel there is a small semblance of chance that the vision may improve with appropriate counseling, I think it is worth giving one attempt at surgery. So as far as a traumatic macular hole is concerned, I'll just try to summarize what he has shown in his videos along with some points of discussion that I thought I'll bring onto the table. So as he mentioned, traumatic holes are commoner in the younger age group, largely so in the male gender, because trauma is in general commoner in the male gender. Unlike idiopathic macular holes, one clinical feature is that these ones are more elliptical horizontally rather than round. And a big pathophysiologic difference is that unlike an idiopathic hole, which has slow progressive tangential traction occurring at the fovea, here, due to the counter-coup mechanism, there is actually an acute tangential traction which causes the hole to form. So if you sort of imagine the posterior aspect of the eyeball in this way, a sudden sort of a pressure will cause this posterior aspect to flatten out and then go back to its position. So this sudden flattening causes a stretch at the fovea, and the fovea actually gives way. And because the compression is released and the tissues to a certain extent tend to come back, that is the reason why these holes have a tendency of natural spontaneous closure as against an idiopathic hole where the traction maintains. And as Dr. Bawankule showed, that there are certain OCT features which can help you predict which holes will spontaneously close. The biggest predictive factor that is known in literature is presence of cysts around the hole. This is a negative predictive factor. If there are cysts around the macular hole in a case of traumatic macular hole, the chances that it will close are on the lesser side. So that could be one thing that one can use while counseling the patient. Another feature that is also known is the ellipsoid zone attenuation. So if you have a case of traumatic macular hole and you do an OCT, one should look at the ellipsoid zone right at the base of the hole. And if you find that the ellipsoid zone is lost for a length of more than around 2000 or 2500 microns, these are the holes where the visual improvement may be limited. So this can again be sort of a counseling point. And a few other factors that can predict a relatively poor outcome are the health of the RPE, which one can actually look at the base of the hole by doing an autofluorescence, a large hole diameter, more than 500 microns, and any associated retinal injury. Suppose you see a choroidal choroidal rupture, or you see a subretinal hemorrhage around the hole. So these again bring down the overall final visual prognosis. And a basic clinical skill that one can also fall back upon is to look for a frank RAPD, because these are blunt eye injuries, and a traumatic macular may also have an associated optic neuropathy. So given these factors, if they are present, one can use them to sort of have a preoperative discussion with the patient with respect to prognostication. And as he very nicely showed in his videos, I would say as of right now, ILM peeling in a vitrectomy would be the standard of care, and one may look at a reverse peel technique if the holes are large. So I mean, I would summarize this session at this point. Thank you, Dr. Bhavan.
Thank you, Vivek.
Thank you, Vivek. Thank you, Prashant sir, for the wonderful discussion. We'll move to the next topic. It will be the pediatric part, challenging trauma cases in children by Dr. Mehul Shah, and it will be discussed by Dr. Laila Mohan from Kozhikode and Dr. Lakshmi C from Kozhikode. Over to you, sir. Mehul sir.
Is my screen visible?
Yes, sir.
Yeah.
Yes,
Thank you, Kozhikode Ophthalmic Society, as well as Dr. Sujit, Dr. Prashant, for allowing me to be here and share our experience with pediatric ocular trauma here. We have one of the large database of pediatric ocular cases, and we published this article with the database of 12,087 cases in general. 41.8% were the pediatric cases. It is important, and 4.7% were the toddler cases, which we consider 0 to 6 years. So because they have more years to live and more economical burden to the society. Directly coming to the interesting cases, it is very important, like there has been long discussion about the no-PL cases. I will be showing some no-PL cases. Because of lockdown, there were neglected, services were not available, and this penetrating injury patient came after 7 days following injury. The first image is showing on presentation, and second following intravitreal injection. Then we straightway did the vitrectomy to clear the lens. And optic nerve was reasonably healthy. The patient was no perception of light. Then also we've taken the patient in. And after clearing everything, we followed up. At the end of 1 month, the BCVA was 612. So we decided to take this patient in for scleral fixated lens. And here we are implanting our newly designed self-sustainable lens, which is the term as a scleral tuck lens.
I think you have to optimize the clip for video clip. It's playing lagging.
So there are flippers which are taken out and they remain self-sustained outside the sclera. This lens remains nicely in the place and self-sustained without any suture or without any glue, which makes a very economical option. This patient was 612 after 1 month. These are another neglected cases which were not infected. These are the old trauma cases which were picked up from the outreach rather than presenting themselves to the hospital. The another case which had a very thick anterior capsule, fibrous. One more case. So any delayed presentation case also can be taken care. Any provided there is no amblyopia, patient will regain good vision. This is another case of a retained wooden foreign body, and this was a big foreign body inside. This was again an OPL case. Vitreous was removed, but exudates were very tough. We could not remove the complete exudate, but central exudate only we could remove. And foreign body was pushed from inside. Then followed by laser and oil. This patient had only hand movement vision. Somebody operated the traumatic cataract of a girl at the age of 4 years. This is again a refractive challenge. When a girl visited to us at 14 years of age, we could find that she was -12, maybe because of deprivation as well as refractive changes. Another lens was implanted and she improved fully, despite and followed by amblyopia therapy was given. Again, this is a traumatic endophthalmitis with no PLI. This was by end result, and this patient remained no PL only. This is the traumatic cataract case. We did the lancectomy, vitrectomy, and used our scleral tuck lens to manage the aphakia. This is the challenges post-operatively. This case patient was treated with the globe rupture repair as well as traumatic cataract, but patient developed this 3-year-old female. She developed such a tough membrane. It was despite of performing surgery in time and everything well, but patient did not regain much of a vision. She remained finger counting. So this is important challenge what we face. Despite of multiple time membranectomy, ultimately end result was this, and this patient remained only hand movements. This is another interesting case where some insect was there in subconjunctival space, maybe because of release of some toxin. She developed the esotropia. Following removal of that insect, the esotropia was corrected. And these are some foreign bodies which are of unusual type in children. This is again large traumatic macular roll in children, and there is a large intraocular foreign body. This is a very high grade commercial retinian optic nerve avulsion. This is the traumatic reticon. Factor affecting not improvement of vision, what we studied in our database of 1630 eyes. 18.3% were just not improved because of corneal opacities, then recurrent inflammation, then lens malposition, then secondary glaucoma. Other important factors were amblyopia, astigmatism, and after cataract. We did one study. It is important to understand prediction of visual outcome in children, and we designed one score like toddlers ocular trauma score. We have OTS, we have POTS. We have published the designed and published the POTS in Graphia Archives. This was the course study which was designed to develop and compare TOTS and POTS as compared to other predictive models. I'm not going to the details, but important is between 0 to 6 years of age, we studied the ROC curve, and for sensitivity and specificity, the important is the low score grade POT is doing better than POTS and OTS. For higher grade, both of the scores are not relevant. These are the comparative study between POTS and OTS, and we calculated percentage of achieved vision as well as predictive vision, and these are the comparative study. In OTS score 2, 3, and 4, they are doing extremely well. So OTSI has taken the initiative for general awareness, for early reporting for the children, awareness in general ophthalmologists for good primary repair and early reference and advocacy. Thank you.
Thank you very much, sir. Laila madam, your valuable comments and any extra points from your experience. Also, Dr. Lakshmi will be joining.
Wonderful presentation of the worst.
Ma'am, you are muted.
No.
Can hear.
Yeah.
Am
Yes,
I?
yes, yes. No, ma'am. We can hear.
Yes, we can hear him.
Wonderful presentation, sir. And of course, the most important thing is in the very young children, visual acuity is not at all, cannot be relied upon. And the history is very, very important because they don't volunteer to say where exactly, what exactly happened. So a complete evaluation is very important. And I still remember there was a child who had who was watching a cockfight, and during cockfight, it seems they tie blade on the foot of the cock. And there were a lot of injuries on the scalp and face also, which were not obviously seen when we evaluated in the clinic, but we had to do a complete evaluation, and suturing of those scalp injuries were also necessary during the surgery. And how early we will do a cataract surgery, because cataract progresses very fast after a penetrating injury, and often the PC is also ruptured in those cases. And how early we have to manage, and the The earlier, the better, and also management of amblyopia to start catching as soon as possible when the child can open the eyes. That is the most important thing, because the otherwise child can develop an strabismus. Amblyopia can be very dense if you delay surgery, and sometimes we may have to do a strabismus surgery as well. And also when there is a corneal opacity which is central, which is not unusual, we may have to do an optical iridectomy as well in these cases, where before going in for a corrective procedure. Yes, I think some of the there are very many occasions where we had to a child was brought in the wheelchair who was drowsy after a fall on his face, and not much of contusion or chemosis was seen in the eye, and white-eyed blowout fracture, which is also to be thought of when the patient is brought in as a sick child, which need to be immediately tackled. These are some of the special things which we have to think of. Over to Lakshmi. I would, Lakshmi.
I think most of the important points are covered, madam. And as you said, the most important thing is amblyopia management post-operatively, because whatever you do, amblyopia management paves the way for the final vision. One question to the panel, how early would you advise a multifocal intraocular lens, or do you at all in suitable cases in pediatric cataracts?
Should I answer that?
Particularly in traumatic cases, patient may have many comorbidities like corneal opacities. It will not be a very clean like normal cataract. Yes. So it is extreme. Plus, patient you may require the further intervention for vitreoretinal surgery. So for this multifocal might be obstructing the view for the VR surgeries. So for our cases in trauma, normally we don't do the multifocal lenses. Prashant, what do you say?
Sir, for a trauma, basically the inflammation and the visual prognosis, if you can overcome, if it is a minor trauma, anti-segment trauma, where you have a peripheral corneal opacity with a linear scar, well, you can consider a multifocal, explaining the patient the expectations. Regarding the point whether we can manage subsequent vitreoretinal procedures through a multifocal or a trifocal, I don't see any reason, because even in elderly patients, we do surgeries with equal comfort with a wide angle viewing systems. So that would not be a restraint for not using a trifocal, but yes, expectation versus reality, what you can offer in a trauma.
But important is in trauma cases, there will be irregular astigmatism, which will interfere with the refraction as well as the comfort level of the patient. And number two, madam, answering another question is, these are toddler's ocular trauma score that depends upon the finding and not primarily on the visual acuity. Our POTS and ocular trauma score that are directly dependent upon the primary visual acuity. And here between 0 to 6, we can't expect primary visual acuity. So we define only on the findings.
Yes, sir. I saw that POTS and TOTS, they are prognostically very good and not depending upon, not giving much weight to the visual acuity, and very good prognosticating scores in these cases, rather than go by just OTS. So really nice to hear your very large statistics with a very huge number of trauma in pediatric cases, and good. We could hear it in person from you.
Thank you.
Thank you, madam. Thank you.
Prashant, that was a very nice session, sir. Thank you.
Thank you.
Prashant, one question.
Grover, your question, please.
Extended depth of focus or trifocal? Of course, having ruled out all the factors that Mehul pointed out, a subluxated lens, a corneal astigmatism, a corneal opacity. Once you've ruled those out and chosen to do a presbyopia correcting lens, which is so-called presbyopia correcting lens, then would you use a trifocal or an extended depth of focus?
I would not call it a contraindication for a baby who is more than 5 to 6 years old, sir.
Which of the two, EDOF or trifocal?
I do not have much experience with EDOF, frankly speaking, sir. I'm more comfortable either with a trifocal or a monofocal.
I've used a few EDOF and I've preferred them over trifocals for possibly the reason of increased contrast, no compromise in that. And I think the patients have been quite happy because they're going to be unilaterally pseudophakic for a long time. So that is one of the reasons in uncomplicated cases one would consider an option like that.
That's a pearl of wisdom from you, sir. Thank you.
And cost is less.
Possibly.
I think, yeah. I think we can move ahead for want of time with further discussion. We'll leave it for the last part of it. Sujit? Yes, Sujit, you are audible.
Yeah. Yes. So our next talk is actually, we are jumping the line. Sir wanted to leave early. So I request Grover sir to have his presentation. Dr. Anju Chandran and Dr. Soumya will discuss that.
Can you see my screen share?
Yes, it's visible.
So thank you again. I really enjoyed this session, which has been really very, very useful and very contributory to my knowledge. I'll be speaking on management of eyelid and canalicular injuries. We know that the adnexal injuries constitute almost 1/3 of the cases in our country. And as we said, they are often a part of polytrauma involving the face with multiple involvements. When we carry out an eyelid repair, we need to establish the anatomy, which is also the basis for restoring the important physiological functions of protection of eye, tear drainage, and many others that the eyelids play. But the restoration of aesthetics is also critical because it has an important bearing on the patient's ability to face the world, and this should never be forgotten. Primary repair is the most desirable and gives the best results. However, a delayed repair by 3 to 4 days also can be carried out while making sure that edema or infection is taken care of, because this also yields very satisfactory results. However, if the patient presents even later where the scarring has started, then it may be best where the procedure can be delayed till about 6 months after injury when the scar has matured. When you carry out a primary repair, it is important to choose the right anesthesia. Cases like canalicular repair, where you want to avoid bogginess, make general anesthesia may be considered. Children, of course, definitely are an indication, or an associated globe injury, again, are important reasons for general anesthesia. Taking good care of the wound is important by preparation, by taking care of contaminants to prevent infection, including use of copious betadine wherever possible. And then, of course, a proper wound management. In this, we'll talk about the repair of lacerations, particular emphasis on margin, levator injuries, canthal injuries, and where canalicular injury is associated, that must be tackled well. Simple lacerations can be managed well by simple, direct, interrupted, or continuous sutures, making sure you cause a good eversion of the wound to get a good scar. Complex lacerations may require more complex repairs, taking care to fit in the jigsaw pieces well, and at the same time ensuring that you do not give any tension to the wound by either undermining or using flaps wherever possible. Grafts generally avoided at primary surgery because of the risk of infection, but may be necessary in certain stages. Eyelid margin repair, of course, is most important and critical, and it must be undertaken well. There are a number of techniques, but this technique where I use a 6/0 suture as vertical mattress sutures, starting just behind the gray line, starting 3 millimeters from the cut edge, going 3 millimeter depth, coming back 1 millimeter from the cut edge and 1 millimeter from the depth, first at gray line, then at the anterior and posterior part of the margin are very important. A suture such as 6-0 silk has a greater advantage over nylon because the ends are not so sharp and will not irritate even if rubbing against the cornea. However, once you have passed these 3 sutures, you also try to pass all the ends of the posterior sutures through the most anterior suture, thereby ensuring that these would not rub against the globe. Vertical mattress sutures give a little pout to the wound, as you can see, which ends up very nicely as level. Then the tarsus is closed with a Weichel suture, which is partial thickness, not full thickness, to avoid any irritation to the cornea. And after the sutures are given to the tarsus, then skin sutures can be made with your interrupted sutures. Lacerations can be managed very well, and the rich vascular supply of the eyelid ensures very good results. If orbital fat is exposed, you must think of the injury to the levator aponeurosis, and it must be put together after marginal repair with the use of 5-0 or 6-0 Weichel sutures, making sure that you reattach it to tarsal plate to avoid post-operative ptosis. But it is the management of canthus which is of great importance in preventing deformities. In addition to the canalicular repair that you often need in these cases, it is avoidance of telecanthus which is important, and it is the deep crust of the medial canthal tendon which must be put back. Where the ends can be seen, they can be put together by a Prolene suture. In other cases, it may require fixation of the medial canthus to the periosteum behind the posterior lacrimal crest, and we'll see that technique when we talk about management of deformities. So microplating and transnasal wiring are the other techniques which are needed, which we will subsequently talk about. Lateral canthus again needs to be reattached at its appropriate position. If there is an avulsion, you need to take a double arm bite with, again, a permanent suture like Prolene, and then take a bite through the lateral orbital margin at the Wittnall's tubercle. And you must start behind the orbital rim with a bite through the periorbita and coming out anteriorly in the periosteum in front of the margin. With those firm bites, you can ensure a good anchorage using a double arm suture. At other times, you may need to make a periosteal flap where there has been some loss of tissue, or drill holes through the orbital rim in order to do this fixation. But the fixation of canthi is vitally important in all these cases. Some example of medial and a lateral canthal both being everted, which can be put back. And fortunately, if they are put back well, the results are quite gratifying. So early meticulous repair is vastly useful in restoration of normal anatomy and gives excellent results. Even with complete avulsions like this, with loss of tissue, it may require advanced flips. Because of the rich vascular supply, you can get extremely gratifying results. However, if the repair is delayed or inadequate, then deformities are the rule. And these may comprise marginal misalignments, which can lead to entropion or ectropion with fatal results for the integrity of the cornea, eyebrow malposition, canthal displacements, ptosis, eyelid defects, cicatricial ectropion, and so on. We'll discuss these briefly. When you have a misalignment like this, an ectropion may lead to permanent epiphora, or an entropion may lead to corneal irritation. And if it is within a week or so, you can remove these sutures and put back with a good marginal alignment to take care of all the misalignments that this patient had, and can give satisfactory results. Eyebrow malpositions are usually because they were not apposed in the appropriate position. So you need to open up all the wounds, reoppose them, and you can get a good apposition once again. Canthal displacements are due to a number of reasons: avulsion of the medial canthal tendon or bony deformities. This is an example of a traumatic telecanthus. The principle of medial canthal reposition is that you must anchor the medial canthus to the area behind the sac, that is at the posterior lacrimal crest. And this is done by exposing that area and taking a bite through the intact periosteum there. Sometimes this bite cannot be taken well. In that case, we may need to use other means like drilling holes and using microplates. So when this is anchored in that position by a conjunctival incision, then you can really put back the medial canthus quite well. Some clinical examples are, this is a telecanthus where we've done a YV plasty combined with a transconjunctival approach to the posterior lacrimal crest in order to get back the right position. Sometimes these problems may be combined together, like you have an unsightly scar which needs to be revised, the brow needs to be put back, and the telecanthus needs to be done. So a scar revision is combined with a posterior placement of the medial canthus and the apposition of the brow, which can yield very good results. And ptosis can later be corrected. So this is an example of a downward displaced canthus where we have done a Z-plasty and caused the canthus to be repositioned, but at the same time, you need to fixate the medial canthus well by putting in wiring at the posterior lacrimal crest region. Associated bony defects need to be tackled either by transnasal wiring or with a stainless steel wire, or you can use Prolene sutures, or more often the low profile mini plates are used in that region. You need to use small 2 to 4 hole plates with short screws. This is an example of microplating with the titanium with 2 holes only and fixation, so that this can now be used to fixate the correction of telecanthus. And this is an example of an extreme telecanthus following an injury, corrected by removing the deformed bone. You needed a bone graft to have a point of fixation and then a canthal wiring in order to, at the same time, scar revision to get a reasonable correction in a case like this. Bilateral traumatic telecanthus, bilateral traumatic NLDO, where we did bone grafting with a plastic surgeon with a bicoronal flap, transnasal wiring, and open sky DCR for both the eyes, which improved the appearance as well as corrected the dacrocystitis. She lost vision in one eye, which needed a cosmetic squint correction later. Lateral canthal displacements can be tackled by totally mobilizing the lateral canthus, augmenting the posterior lamina with a hard palate graft so that we could reposition the lateral canthus to be much similar to the other side. Traumatic ptosis needs to be evaluated like any other ptosis, and appropriate procedure carried out for the correction, which may often include levator or sling procedures. Lid defects are evaluated like any other case of lid defect. They take care of the special features of trauma like a lateral canthus, which is misaligned here. This needed to be opened up first before we could convert the defect into a pentagonal shape and carry out a tensils repair for correction of the defect. Cicatricial ectropion needs to be assessed for whether it is localized or generalized. In a localized defect, you're able to lengthen the direction of shortage by one of the plasties, either a Z-plasty, where you are able to lengthen the long axis by placing the central incision in the line of shortage, or by a VY plasty. An example is an ectropion here and an ectropion here. So a Z-plasty in this line of shortening and a VY plasty in this line of traction worked well, so that that lift from the globe that you could see earlier has now disappeared. Example is a cicatricial ectropion, both of the upper and lower lid, a VY plasty for the upper lid, and skin grafting for the lower lid was needed, which could result in a very significant correction. So when you place a V like this, you need to really undermine in order to get the lid to fall back in position, and you need to remove all the scar leading right up to the margin. So once you have released this traction and removed all the scar, the margin falls back into position, but you find that you are left with this huge defect and the flap only comes up to this position. So we need to mobilize the skin from both the ends in order to then close it like a Y and cause a correction in this long axis. So this is how we close it up and it corrects the ectropion. So this is the example, this is the post-op appearance of the case that we had seen earlier. More generalized cases will require either a fold thickness or a epidermal grafting. Example is this patient with chemical burns, one eye lost, the other eye being lost because of severe ectropion, which worsened within days to such an extent, and then an epidermal graft after excision of scar tissue was done, and we could, in a few weeks' time, get back a good closure and a good aesthetic appearance with good closure. Full thickness skin grafts are more useful in the lower lid. This was following a few lacrimal surgeries, couple of failed lacrimal surgeries, which caused loss of skin, where we did a skin graft and could correct the ectropion. So management of deformities can be extremely gratifying, and this is one of the things that I love doing. And this not only restores function and aesthetics, it helps transform lives for these individuals. Canalicular injuries is the last thing that we're going to discuss. Now, lacrimal injuries can be to the nasolacrimal duct as a part of a naso-orbito-ethmoidal fracture, which needs to be tackled primarily. If not, then you need to carry out a secondary sacrocystorhinostomy, which can be quite a tough surgery. But canalicular injuries are the more common one. Some are quite obvious, but others may be hidden. So you need to have a high index of suspicion in these cases. The obvious ones are these, but the occult ones like this, as in this young child following a blouse hook injury, needs to be carefully looked at and then repaired to make sure that you have a success. Early repairs within 24 to 48 hours is desirable, should be done in your own OT. So it's fine to take up to 48 hours, but work in ideal circumstances under a microscope with good assistance. But even if you're operating up to 5 days, most cases are successful. It is important to identify the cut ends. Lateral end, of course, is easy as you pass a probe from the punctum, but it is the medial cut end which is important to identify. Then the ends must be approximated, and we must pass a stent which should be retained for a period of about 6 weeks for it to give the appropriate closure without fibrosis of the lumen. Now, localizing the medial cut end is the important thing. If you work in high magnification of microscope, you're able to identify the medial cut end as a shiny, rolled out white area rather well. Only if the cut is very medial, you may need some other assistance. So if you pass a probe with the lid placed in normal anatomical orientation, going through the lateral cut end, it will often point to the area where the medial cut end is. If that's not possible, the method that I found most useful is taking a large 10 ml syringe, making a pool of saline here, injecting from the opposite normal punctum while you put a pressure on the sac region to avoid the air passing into the nose, and you can see the air emerge from the medial cut end. Now, once you see that, you may not always see the opening. So just pass a traction suture, a fine 8-0 suture in front of the area from where the air bubble is coming, and you pull that area and you will almost invariably be able to see the medial opening. A dye like a trypan blue can be passed from the other punctum to get an idea of where the medial cut end. And pigtail probes are a favorite for some people who are experts at it. I haven't really had much experience with this, which are passed from the opposite quantum. Mini Monaca is very much the material of choice and is the simplest thing to do because it is now available as a not too costly alternative, but silicone intubation sets can be used. And in those situations where you do not have a Mini Monaca, you can use a Teflon set, and we look at this technique. So the surgical technique essentially involves identifying the cut ends, as we said, by passing the probe in an anatomical position. And this intracat, which is generally number 24 that we use, can be used by cutting off the sharp end of the bevel and passing it with the entire support of the thing intact. Once it is passed into the lumen, medial end, passing directly up to the bone till the bony resistance is felt. And then a pericanalicular suturing is completed and the marginal suturing is completed. And then this end is cut off after withdrawing the stellate. And this is fixated to the skin, but this usually is not enough. So we also take a bite upwards and inwards with this to give it a line of traction medially in order to retain it. And this is the technique shown here. So let's look at this video. So we are using this tube after the intracat tube number 24, which is a Teflon material. So a punctal snip allows us in all cases to be able to pass this tube rather easily. This is the lateral cut end, and when you localize the medial cut end, you can see that it passes very easily directly up to the bone. And then it is important to pass 80 sutures of vicryl, pericanalicular, all around. Generally, 3 sutures can be passed comfortably to get a good closure of the pericanalicular structures. And then the marginal repair that we spoke about can be undertaken. And then once the marginal repair is accomplished well, there is enough support for the tube. So those are the classical 60 sutures that we spoke about at the margin, passed as vertical mattress sutures. This is the anterior suture. You may not be able to pass 3 sutures through this region, but if you are able to pass 2 vertical mattress sutures, that is also adequate because this part is relatively narrower than the rest of the eyelid. And then the rest of the associated defects can be tackled and the tube fixated as we spoke about. Mini Monaca intubation is much easier, where you are able to pass the Mini Monaca and you have a device for easy fixation of the tube. As you can see here, once you passed your probe, identified the medial cut end, you can then pass your tube. It's best to come out through the proximal cut end and then pass it through the wound in the distal cut end, like where the cut is very minimal and you did not want to open the wound much. And then you can fixate this very well. You may need to shorten the tube a little many times. So this self-retaining part of the tube is excellent. In children, we may give a securing suture as well. So these children do very well and you can get good results in all cases. Success rates are close to 95% in most series, and we've had excellent results with these techniques. Thank you. If there are any questions, I'll be happy to take them.
Thank you, sir, for the wonderful talk. I think there is nothing left to be told in this lid and canalicular injury. It is almost like an atlas with all the good videos. I would request Dr. Anju and Soumya to take up any questions.
Thank you. In the end, sir. Okay.
You can ask, Anju.
Thank you, sir, for such a beautiful presentation. It is trauma and role of oculoplasty in trauma in a nutshell, basically. Not only you highlighted the importance of lid tear, but the subsequent complications, how they ought to be managed. So it was, and for most of us, it's not just about doing your cases, but it's also about photo documentation, which Sir has beautifully shown in all his cases. Thank you so much. In the want of time, I over to Soumya now.
Good morning, all. Excellent talk by Robert sir as usual. Sir, this one common type of injury is the animal bite injuries in our area. So in that case, there are a lot of confusion regarding either to suture or weight. Sir, can you please elaborate the current algorithm?
I think the current thinking is that we do undertake a repair primarily after all the precautions, including use of serum locally as well as systemically, as well as the injections for as required for the dog bites. But you do go ahead with a primary repair after all those precautions. That's the current thing.
Okay, thank you, sir. And about your experience with the glue in case of lid tears.
Usually glue alone does not do as well. You may also need to put in some sutures. And of course, you do have the factor of additional cost as well. But in a marginal repair, particularly, you would prefer to have some sutures as well in position. For skin repairs, sometimes skin laceration, yes, you may sometimes do, particularly if you have a few other cases as well, and you can use divide the cost into a few cases.
Thank you, sir.
Thank you, sir. Thank you so much. Next, we have our glaucoma session. Dr. Long time for his turn. I'm sorry, Dr. Siddharth. He's a consultant at LV Prasad Eye Hospital, Hyderabad. He'll be talking on the traumatic glaucoma, predictors, prognostic factors, and the management tips. Will be discussed by Dr. Thomas George and Dr. Bindu Ajit. Over to you, Dr. Siddharth.
Thank you, Dr. Sujit. I will require permission to share. Okay, I can share now.
Yeah.
I hope the slides are visible and I am audible.
Yes, all fine.
It's a pleasure to be in presence of such stalwarts as Dr. Grover himself. And thank you, Dr. Sujit. Thank you, the Kozhikode Ophthalmic Society. It's a pleasure to be here. I will try to be brief. I have also edited some slides out of the presentation, and I will restrict myself to the discussion about the conservative or medical management and evaluation of patients with trauma, because surgery, they essentially remain same when it comes to trabeculectomy and implants. At the outset, the predictors, which are very important when we are looking at a patient, because that is going to decide on how urgently do we intervene, how frequently do we follow up. It is quite well known that patients with closed globe injury tend to develop glaucoma in about 20 to 30% of cases. But do not forget that even open globe injuries, especially if there has been a surgery, can also develop glaucoma. The range within various series is between 5 to 25%. The predicting factors or risk factors for development of glaucoma remains essentially the same across the spectrum, which includes the initial visual acuity at presentation, older age, amount of inflammation or hyphema at presentation, amount of injury to the adjacent tissues like the angle, ciliary body, the iris, and the lens. One of the important things that we now know is that more is the hyphema, more is the risk of developing glaucoma. And going from 1/3 to half to a full chamber hyphema, the chances of glaucoma also increase during the follow-up period, even if the intraocular pressure is low at presentation. Just sharing one of the images which forms a landmark in my residency days for the benefit of residents. And this is an image from Shingleton, and also present in the review article and in the OCNA, which you can access through the AIOS membership. So do take advantage of the membership. because these are rare images which are there for you. One very important thing is, even if you don't do the ocular trauma scoring at the presentation, it is important to keep an eye on which of these factors is present in the patient or the eye that you are seeing. And it is well known that this can absolutely and very predictably give you the outcome that you're likely to expect after the initial acute phase is over. So presence of endophthalmitis, presence of relative afferent pupillary defect, you are probably looking at slightly poorer outcome if these were not present. Let me take you through a few cases which will help me highlight a few basic pearls of management of glaucoma in patients with blunt trauma. This is a patient, child, young adolescent probably is the best word, who had injury with a friend's, or probably not a friend, fist injury a week back before the presentation, and the vision had been poor for the entire duration. The patient was on prednisolone acetate and 3 anti-glaucoma medications. Visual acuity was counting fingers 1 meter, and intraocular pressure was 36 millimeters of mercury. RAPD was present, and the B scan showed a quiet vitreous, eco-free vitreous, and the retina attached. Now, one of the first questions that many might ask is, if this is the view and the pupil is fixed, how did you assess the relative afferent pupillary defect? Well, I'll just take you through two videos. This is the kind of setup that you require. The left eye is normal. Need to have an illumination here. You're just able to see the pupillary margin clearly, but don't tend to constrict the pupil. And while one person can hold this light to enable you to see this pupillary margin, you can start testing for relative afferent pupillary defect in a traditional manner. Now, while the light is on the left eye, you see a well-constricted pupil, but the moment you shift the light to the right eye, you see that the pupil gradually dilates to a mid-dilated position. It is not as well dilated as it would be without any light, but definitely there is no initial constriction and a greater degree dilatation, which points out towards an RAPD of around grade 2. So this is the way you can check relative afferent pupillary defect even at presentation. And while there might be a slight RAPD of grade 1 just because of the raised intraocular pressure, a higher grade of relative afferent pupillary defect probably suggests that there was a traumatic optic neuropathy. The patient was referred to the neuroophthalmic department and received IVMP as per protocol for traumatic optic neuropathy. From the glaucoma point of view, we increased the prednisolone acetate. It's very important to give a significant amount of anti-inflammatory medication if there is significant amount of dispersed or layered hyphema. We also advise cycloplegic and added another anti-glaucoma medication. Though using prostaglandin analogs is not an ideal situation in such a situation where you have inflammation, if you weigh the risks and benefits for a person who has 60-70 years of life ahead, to have a slightly increased amount of inflammation compared to a significantly high pressure for a few more weeks, we would rather have a little more inflammation than a pressure of 36 millimeters of mercury. We also gave oral acetazolamide for 5 days and decided to review after 1 week because the intraocular pressure was quite high. But after 1 week, the visual acuity had still not improved completely because of dispersed hyphema and small layered hyphema, but the intraocular pressure was 10 millimeters of mercury on 4 medications. Remember that we had stopped acetazolamide 2 days prior to the visit, so that enables us to assess the level of intraocular pressure control with the topical medications. Also to note is the fact that as the patient improves, there is no active bleeding. You're likely to get some more layered hyphema over the few days after presentation. as the red blood cells which were in circulation tend to settle down. So this should not be taken as a negative sign. It is to be expected. And given the fact that the intraocular pressure was quite low, or in fact very well controlled with 4 medications, we decided to take off the PG analog and reviewed the patient after a month's time. The vision was quite good with a refractive error, and intraocular pressure was 18 millimeters of mercury on 3 medication. At this visit, it is essential to perform gonioscopy and dilated examination with indentation, now that there is no inflammation and the eye is pain-free. And this is what you see on gonioscopy. You see ciliary body band all around. But what if I tell you that this is not the eye that has been affected with trauma, but the other eye? Now, this is very interesting because we need to differentiate between the naturally occurring visibility of ciliary body band to angle recession. Now, I'll try to put the images of both eyes side to side, quadrant by quadrant. And what you will see is that the ciliary body band, which is visible in normal eye, is much narrower than the eye that is there with the trauma. So inferior angles, superior angles, the temporal and the nasal angle all have wider ciliary body bands, which is most clearly visible in the nasal angle in the affected eye. So this is suggestive of 360 degrees angle recession. Now, what if the patient has only one eye and there is no eye to compare? Some clues that can tell you that there is angle recession: irregular ciliary body band, a ciliary body band that is wider in the superior angle than the inferior angle, ciliary body band which is wider than trabecular measure, which is not the usual case, and pathognomonic is presence of torn iris processes, which suggest a pathological angle recession. Now, for this child, 16-year-old is not a child. I have to train my mind, right? So for this patient, we saw the fundus, and the fundus did show a diffuse pallor. There were no breaks, and the HDF showed generalized depression. The AGMs were continued, and the patient was asked to review after 4 months. We planned an annual visual fields for the patient. So, like stressed at multiple points of time during the day, the prognosis is always guarded till the examination is complete. Here you could not see the fundus or assess the optic disc or perform visual fields. So even if everything seems fine, do not give the patient a false assurance that everything is going to be good. There might be a traumatic macular hole despite a normal B scan. Relative afferent pupillary defect can be assessed with a fixed pupil, and is essential to do not only for prognosticating, but treating traumatic optic neuropathy timely. You can use prostaglandin analogs in setup of blunt trauma and hyphema if the intraocular pressure is not controlled otherwise. Temporary acetazolamide can play a significant role in enabling the topical medications to act and penetration of these drugs through cornea. Reduce the anti-glaucoma medications when the intraocular pressure is low, especially lower than the other eye, and perform gonioscopy and indentation only when the patient is asymptomatic and there is no inflammation in the eye. Now, just a small pointer, and this is something that Dr. Deepak had pointed out in his case about lens subluxation. This is a patient who had trauma and angle recession with glaucoma. You can see that the distance between the optical section on the iris and on the cornea is wider in the inferior margin of the pupil compared to the superior margin. Now, if we need to decide on which is the part that is, whether there's an anterior subluxation superiorly or a posterior subluxation inferiorly, gonioscopy might help. So you see an angle recession temporally, nasally, and inferiorly, whereas superiorly, the PTM is just visible, just a glimpse of the ciliary body band. So a presence of a narrower angle superiorly, a wider angle inferiorly suggests a posterior subluxation. Now, A scan can help you recognize subluxation not only in presence of anterior but also in presence of posterior subluxation. So the A scan that you see on top is showing a very thick anterior chamber compared to the right eye, despite having a thin lens. So this is possibly suggestive of the fact that there is a posterior subluxation of the lens in the left eye. Now, when you go to the A scan in the bottom half, you see that the lens, yes, it's thicker in the right eye, but not so significantly as to account for the depth difference in the anterior chamber depth. So this is suggestive of a anterior subluxation. So do look at the lens thickness and the anterior chamber depth and the amount of lens thickness that can contribute to this difference. So if the difference in the anterior chamber depth is more than that of the lens thickness, suspect a subluxation. Going to the next case, this was a carpenter who had a blunt trauma while cutting wood, and the intraocular pressure was 48 millimeters with PR accurate vision. The scan did not reveal any abnormality. For this patient, we gave him acetazolamide tablets to stat and decided to give IV mannitol after an evaluation of the blood pressure and an examination for renal abnormalities. The pressure did not come down, and then we decided to go ahead with an AC wash. I wish I had the video for this patient, but we will still discuss what to do. Now, the indications classically for performing an AC wash or a surgery for such a patient is widespread. Now, when you have just seen this patient and the hyphema is not full chamber, you can't be waiting for 8 more days just to fulfill this indication. So the thing is that once you know that the disease is severe enough and is not responding to medications, oral and topical, or even to IV mannitol, you know which direction is this going in. Any intraocular pressure above 30-35 millimeters of mercury is a risk factor for vascular occlusion, and you should try to treat it as urgently as possible. Now, some tips for anterior chamber wash in patients with hyphema. Now, while you can choose to do it with a Simcoe or a bimanual, my preferred instrument is a bimanual irrigation and aspiration. I always do it with an ACM on because we need to avoid a sudden collapse of the anterior chamber. The hypotony should be avoided in all manners. The extent, the suddenness, and the duration, which is countered by an anterior chamber maintainer, because it can cause a rebleed by dislodgement of the clot. Do not forget to irrigate and aspirate near the angle. In an eye with a hyphema, a lot of red blood cells, pigment, and debris can be lodged between the folds of the iris, which is dilated or mid-dilated. So while you're doing it, just use the bimanual to shake the eye up, and you will see a lot of pigment dislodging from the iris. You can also direct the irrigating irrigation probe to the iris to dislodge these pigments. And if you have a rebleed, I prefer to leave an air bubble in the eye rather than viscoelastic. That should take care of preventing the rebleed further. So this person responded well, and the first post-op day did not show any significant rebleed. The air bubble probably did the job. With the dilatation that we performed at the end, we could see the fundus slightly hazily, but yes, we could have some kind of a view. And this patient responded quite well. There was no breaks in the retina or angle recession in this patient, and we continued to follow up despite having no glaucoma at the end. So do intervene if the intraocular pressure is high on maximal medications in presence of a large hyphema. Don't wait for the regular compulsory number of days. Do a cautious but complete AC wash in the early stage and perform a fundus examination at the first instance. One quick case to wrap it up. This was a patient who had a trauma quite some time back. I think this was 1 month after the initial presentation, and was on difluprednate 6 times a day with 4 topical anti-glaucoma medications. This is not the best view, but what should be visible is that there are only pigments in the anterior chamber. Now, probably the treating physician mistook these pigments for red blood cells. One very good clue that you can have is the amount of congestion that you see around the cornea, or the circumcorneal congestion, which gives a good idea of whether there is an active inflammation or not. So for this patient, where we saw that the disc was quite healthy, there was no major effect of trauma, and giving intravenous mannitol reduced the pressure to 22 millimeters. We were a little reassured and gave the patient acetazolamide, replacing difluprednate with loteprednol. And these patients are, just because they had trauma, that does not mean that they cannot have steroid response. It's something like the endocapsular thing. So use as much as you need, but only as much as it is essential to do. Do not overkill with steroids, because these patients can have steroid response, and that alone can cause raised intraocular pressure. And that is what this case showed to us. Take home messages. I have refrained myself from going into the surgery because to save time. The prognosis is always guarded till the examination is complete. RAPD assessment can be performed in a patient with a fixed pupil, either because of trauma or cycloplasia, and may tell you when you need to intervene immediately for traumatic optic neuropathy. Do perform a gonioscopy and indentation after inflammation and symptoms settle down. Use steroids. It's an essential part of treatment of hyphema and uveitis associated with trauma, but make it very judicious. And early intervention in case the IOP is uncontrolled, especially in presence of large hyphema, should not be delayed in order to fulfill the requirements of protocols. Thank you so much, and I will be happy to answer questions, if any.
Thank you, Siddharth. When I told you the topic, I never knew that there's so much in it. Thank you so much. Dr. Bindu and Dr. Thomas George, sir, actually was here, but he had to leave in between. Kindly, can you initiate the discussion and let us restrict it to one or two questions if possible?
I would like to add one more thing about the angle resection. More than the width of the ciliary body, I go by, if I see a torn iris process, I would be more confident calling it an angle recession, because the width of the ciliary body also can be varying between the two eyes of the same patient. And about the steroid, difluprednate gives us more of an IOP response than anti-inflammatory response, is my personal opinion. So it's best avoided in all situations, other than in hypertonia. I got a few patients on difluprednate, uveitic glaucoma, uveitic hypertony, which are being maintained on difluprednate for the IOP purpose.
I completely agree with you, and yeah, the ciliary torn iris processes are the pathognomonic findings suggestive of angle recession. Completely agree. Thank you, Dr. Thomas.
Dr. Bindu.
Thank you, Dr. Siddharth. Surgery.
Yeah.
Or how late? I'm sorry.
Sorry.
Dr. Siddharth, how early or how late should be the surgery in event?
Okay, yeah. So I think if you have hyphema, the first surgery to go for is an AC wash. In the absence of hyphema, I would like to delay the surgery till the inflammation is completely under control, because inflammation and the presence of inflammatory aqueous de novo causes two problems. One, there will be initial hypotony, which is likely to occur due to ciliary shock, and more chances of fibrosis because of the inflammatory mediators in the aqueous. So wait for the inflammation to settle. If you can't, just take God's name and go ahead, but as far as possible, just wait. Just like in a chemical injury, probably that Dr. Vikas deals with a lot.
Okay.
Just one point to add, we can't overemphasize the follow-up of these patients. Even though the injury is trivial, the occurrence of secondary glaucoma can occur anytime. So a lifelong follow-up has to be emphasized in all trauma patients. That's one point. The other thing, and I want to ask a doubt, we had a patient actually with trauma with vitreous hemorrhage, and the IOP was normal. So when he was reviewed after 3 weeks, we found that it went into a hypotony. And then actually we couldn't do even a gonioscopy. And on doing an ASOCT, we could see a cyclodialysis cleft actually. So how will you manage a case, and what is your management in case of a cyclodialysis cleft?
Right, very interesting. I, in fact, just am following up. I saw on one of these patients the other day. So the treatment for these patients is strong cycloplagia and mydriasis. So atropine along with phenylephrine and tropicamide combination. If you see some inflammation, it might actually be helpful in causing that adhesion between the ciliary body band and the scleral spur, the ciliary muscle and the scleral spur, which can lead to resolution. And I don't know if difluprednate would be a friend here by causing a rise in intraocular pressure and thereby settling the cyclodialysis cleft. But ultimately watch for 4 to 6 weeks. If there is no hypotony maculopathy and the visual acuity is retained, OCT may be a very good instrument here to look for subtle hypotony maculopathy. And if nothing else helps, then a repair by, I think my preferred technique is the sewing machine technique, which helps.
Thank you. Thank you. Over to Sujit, I think.
Yeah, Sujit, I think we can move ahead.
Yeah. I'll invite Dr. Vikas. Please talk corneal laceration repair. Vikas is a prolific corneal surgeon. I need to introduce him. He's from Ambala, and he has got numerous experience in presenting at various forums from national and international. Over to you, Vikas.
Thanks so much, Sujit. And I think I must congratulate the whole KOS team. This is a wonderful resource that we have built up on trauma itself, and covering everything in ophthalmologists. Congratulations, and thank you so much for the kind invite. This was the last slide of my previous visit at Kozhikode, and it was an amazing, as Sujit was mentioning, it's a wonderful city, and definitely we all also are missing our physical presence there. That was on lamellar keratoplasty, and this time he said that I need to talk on corneal lacerations. So that's fine. So what I'm going to do here is that I'll just share our experiences. What do we generally do when a tear repair comes? And I'm going to focus on the practical aspects and how do we generally do here in Ambala. So we as a corneal surgeon, as general ophthalmologists, we keep seeing corneal tears and laceration. And I think for an ophthalmologist, it's mandatory that you know how to repair a tear, because it can be life-saving and it doesn't need much of the skills. It's just that, if you're an ophthalmologist, you can definitely repair these kind of lacerations. So I have divided my talk into 3 parts. So suppose a patient of corneal tear comes to you. So what do you do before the patient? You take the patient to OR. What do you do in OR? And what do you do once the patient is gone out of the OT? In OT as well, what you will do there, I have subdivided into 2 parts. Before picking up your needle or, doing all those needle things, what do you do, and how you perform your suturing in these cases. So let's go one by one. So patient has come in the OPD. What do? You have not taken the patient into OR yet. First and foremost would be evaluate as much as possible. So sometimes patient sits on a slit lamp and patient can't open their eyes. Sometimes they squeeze, so you can't do much. You need to just ensure on slit lamp that the globe is intact or not. Is there a perforation? If possible, if you can make out which is a full thickness perforation or lamellar perforation. So evaluation should be as much as possible. That's there, but you don't need to be aggressive. You can keep something for evaluation in the OT under the microscope. Any full thickness perforation needs repair, no doubt about it. You don't that is a full thickness, I'll put a bandage contact lens, I'll do this, that. No. Any full thickness perforation should be repaired. Lamellar laceration, depending upon how it is, may be exempted. Another important thing is you just document what is the visual acuity, and if possible, do a gentle B scan. Again, this is not mandatory, and if you want to do a B scan, should be very gentle. Basic aim is because you need to understand what is the injury, what was the injury pattern. You need to spend some time with the patient, with the relatives. Sometimes, you know, in your OPD, there'll be with the one patient, there'll be nine or 10 people because of trauma. So you need to understand how you take a feel, how these people are, whether to follow up and do it nicely, that you have to document. And gentle B scan to see if there is any foreign body inside, so that you can explain what is the prognosis. Extremely important, more important than doing the suturing per se, proper counseling and the consent. You need to tell patient that, okay, this is just a repair. We are going to see what is there in the backside of the eye, what is there in the retina later on, and if needed. And it is not for the vision we are doing at the moment. We are doing just a repair, a primary repair. That should be very clear, because we see, you know, suppose a patient who had repaired elsewhere comes to you after 1 year, 2 years, somewhere else. You ask him, okay, what has happened? So he'll start from, oh, I had a surgery there, and because of the surgery, my eye became like that. You know, so it is important we tell them that, see, it is an injury which is serious stuff, and we are just doing a repair, and later on you might need multiple surgeries, might need 1, 2, 3 surgeries. We are not sure how the prognosis, that thing should be very well consulted to the patient as well as to all the relatives. Better to make them all sit there and explain what it is. So once this thing is done, evaluation is done, you know there's a perforation, you know there's a full thickness, you have ruled out a foreign body, or, you know, planned whatever you want to do. Then if you have decided that surgery is to be done and patient is ready, post for the surgery as early as possible. Don't delay, as early as possible. And then decide whether you want to do a general anesthesia or local anesthesia. So what we generally follow is, if there is a limbal to limbal tear, big tear, better to do under general anesthesia. But again, if the patient is cooperative, you can do under local anesthesia as well. In LA, you need to give some good retrovulvar anesthesia. It ensures that you don't give too much of block, otherwise it will increase the pressure, and the iris which is inside may come out, lens matter may come out. So you need to be careful. If you have a doubt, please take a decision in favor of general anesthesia. Of course, the patient is not cooperative, like children, you have to take it under general anesthesia. If the patient, suppose that you are seeing the patient now in the morning and you have planned surgery after 2 hours, 3 hours, or if you have seen in the evening, somehow you have to do the surgery next morning, shield it, don't patch it. No pressure patching, only shield. No topical medications, but give systemic antibiotics, and if needed, tetanus toxoids. So this is what you are going to do before you take the patient into OR. So now the patient has come into OT. It has been, you know, given the whatever anesthesia you want, and a very gentle drape has been applied. Now what you will do? So before you pick up the needle, you need to do 2 things. What are those 2 things that you need to do? Evaluate and wash. Evaluate, why? Because as I said, in slit lamp, sometimes you are not sure what is the extent of tear. So sometimes it looks like that the limbus is not involved, but when you evaluate, it looks like that the actual limbus is involved. So evaluation is extremely important to see what is the extent of wound and what is the type of wound. If there is anything else, all those things you need to evaluate. So before you pick up your needle, please spend some time and see what kind of wound it is, whether it's a perpendicular wound or it's a shelved wound, whether the wound has an apex or it doesn't have any apex, whether limbus is involved or limbus is spared. How's the status of intraocular stuff, whether there's an iris prolapse, there's a anterior capsule rupture, if there's a vitreous, all those things you need to evaluate first. So perpendicular or shelved, you know, if there is something like there's an entry wound and an exit wound is at 90 degrees, so it's a perpendicular wound. Shelved is it's an angle. Why we need to know about this is, when we are suturing, sequence of suturing will depend on what kind of wound it is. So if it is a perpendicular wound, that generally needs repair first. So first suture generally goes at a area where it is a perpendicular wound. So these kind of wounds, so it is possible, you know, so one area is perpendicular, one area is shelved. So just see, evaluate what kind of wound it is. And then next is whether that tear, that laceration has an apex or not. Apex means, you know, sometimes you have this. So this has an apex, all this pointed. So this also has an apex, although just 1 minute. Okay, so although it's curved, but still it has an apex. Here it is a zigzag, but still it has one apex here, one apex here. This doesn't have any apex. It's just a kind of linear kind of laceration. So you need to see what it is, because sequence of suturing will depend on this. We'll cover later on. So next would be, you can see this tear, this laceration, this has an apex. So I can see the apex here. So I know that this laceration has an apex. Whether limbus is involved or spared, very important, because if the limbus is spared or limbus has teared, so you need to focus on that area first. Again, that will come. So you need to document, or you need to see whether the limbus is involved or not, or sometimes it is one limbus to other limbus, sometimes one part of the limbus only. So that will depend which suture you are going to take first. Next would be, as I said, whether the iris is prolapsed. So how old is the tear? How old is the laceration? Suppose 2 days, 3 days, you might plan to excise this iris, or suppose it's fresh, you might plan to reposit the iris back. Then if it's a cataract, so preferably in primary sitting, so we don't do any cataract surgery or any other surgeries or IOL. Preferably in primary, just do the primary repair. You can do the cataract surgery. Even if it's a child or it's a phacolytic kind of thing, you can take it after maybe a 1 week, 2 week also. So preferably, as far as possible, do plan any other surgery later on, although any other loose lens matter that you can plan to remove in this setting itself. Again, if there's a vitreous, you need to plan that you need to do some vitrectomy in the wound, so you need to free your wound from the vitreous down there. So this is what you are going to do evaluation before picking up the needle, what kind of wound it is and what are the other things that are involved. Next is wash. Again, wash is very important. Our aim is to clear the wound margins. There can be dust, you can't leave it, it may cause infection. There can be a foreign body there itself, need to remove it. There can be iris, so you need to plan whether you need to remove the iris or you need to deposit the iris, and then there can be membranes, there can be fibrins, so you don't want to leave the membrane there. You need to free these wound margins. So wash is very important. Spend some time to do a good quality wash of the margins. Again, iris, you don't want to suture the iris in the wound, because if you see one sympathetic case, you will remember it throughout your life. So you cannot afford to leave iris in the wound. So in short, the wound margins are clear. So once you see what kind of wound it is, then you wash it and ensure that your wound margins are free. Now you are going to do your needle work. So while you're doing your needle work or you're doing suturing, what is the basic aim? Basic aim is to restore the anatomy, restore the dome of the cornea, restore that the kind of cornea it is. The anatomical landmarks are well opposed. And very important is the wound needs to be at the end watertight wound and minimum possible astigmatism. I've done it with red because you cannot leave a wound which is leaky. Even if you need to do some of the other way, you have to ensure that it is a watertight at the end of the surgery. You need, so what we generally do is we use 10 nylon. It's important there's a cutting needle, a spatulated needle, so that it can give, because the edematous cornea, edematous stuff. So it is important that you don't have to, take multiple sutures in one go. The suture should come. Again, very important. Each laceration is different, and we need to customize repair pattern as per the laceration. So it's not that just one thumb rule can apply to any laceration, although the basic principles remain same. So once that patient in the OR, at that time you might think of taking one suture before, one suture later. It's absolutely fine, but the basic principles remain more or less same. So what are those principles? So when we when we do a penetrating keratoplasty, we generally follow ALTR. ALTR is apposition, length, tension, and radiality. So those all that ALTR gets, we can apply on your corneal laceration repair as well. What do you mean by apposition? So apposition is anterior surface to anterior surface apposition should be very good. That is our principle. Because if there is a overriding or gaping, there'll be some epithelial defect, that you can have Dellen, you can have the weird kind of astigmatism. So anterior to anterior apposition is very important. That is our aim. Length should be the equidistant. So if okay, so if there's a tear, so from the laceration, I don't know if I can move the cursor. Okay, it need to be equidistant from laceration, but equidistant from the posterior margin. So if it's a shelved incision, from the most posterior margin, it should be equal. And then next would be tension. As you can see, there should be no gaping in the lower half. Here, I can't show you the cursor, unfortunately. Okay, so in the lower half, the last photograph, you can see, although on the surface, it will look like it is unequal distance from the wound, but actually from the posterior margin, it is almost equidistant. Because if we do it from the anterior margin, there can be an overriding or gaping. So it is important that the length is equidistant, but from where? From the posterior margin, the exit wound of that particular whole laceration. Tension, you need to keep the suture slightly tight because these are edematous. Because suppose there's a 500 micron cornea, this has become 1000 or maybe 1500. So once you have taken the suture, that 1000 micron is going to become again 550 microns. So what will happen? This suture will get loose. So it is important to keep suture slightly tight. Overall, tighter in the periphery and optimum in the center. But again, you cannot keep the suture loose. It has to be on a tighter side. Radiality again, you need to be perpendicular from at the area where you're in the line of the laceration. So you can see, so these sutures will not be parallel to each other. They will be perpendicular at an area where this laceration is, as you can see in these. So these are not parallel sutures, but what I'm doing is just at that point, there will be a right angle. You can take a right angle, and in that area, you need to be perpendicular. So, so this is what are the basic principles: the apposition, length, tension, and radiality that you need to keep in mind while you are operating. What will be the sequence of suturing? So this will again depend what kind of wound it is. If it's a perpendicular wound, that part of the area will be sutured first. So one part, suppose, is perpendicular, one part is shelved. So you are going to take first suture in the area where there's a perpendicular cut. So for example, in the center, if this is a perpendicular, so you will take this suture first, and in the below, if this is shelved, you will take this suture later. The apex will be sutured first. So first suture will be at apex, and next will be on the margins, the edges. And then this one half will be divided, you can see, into two. And if needed, if you feel that there is a leak or there's still gap, you can put more sutures in between two. So you have to take first suture at the apex where you have an apex. So if you have more than apex, one or two apex, you can see this will become a stellate kind of wound. So here you can use a mattress suture also, or purse string suture also. I have never taken, in all these 15-20 years, I've never done this purse string or mattress suture, but this is there, and this can definitely be used. These stellate wounds, these kind of wounds, these are really challenging, and sometimes any kind of suture, it is difficult, and you might need to use some glue or canalicular glue as well. Again, you need to ensure these kind of wounds, whether there's a tissue loss or not. So any tissue loss is very difficult to suture. So that also you can see whenever you are having difficulty, just check that if there is any tissue loss as well. So next is perpendicular shelf we have discussed, apex we have discussed. Suppose a linear laceration. So first suture would be on the edges, and then it will be divided into two, and then each half will be again divided into two. That's how we are going to do it. So I'll show you a quick video. Again, first is wash, as I said, ensure that all the dust, membrane, everything is taken care of. You can see this is a shelved kind of incision. And again, when you do the eyes, this is difficult. So I just will highlight this again. So when you do a AC tap or you do a MVR, on both sides. Again, as far as possible, no touch technique. Try to keep as long as sutures. Longer suture will have more compression zones. You'll need less sutures, and this will be perpendicular to this area. So if this is a line, this will be perpendicular to this. So here it will be perpendicular to this. Here it will be perpendicular to this. So perpendicular, go at 90% depth. Don't be superficial. It should be 90% depth on the both sides. And then, try to bury the knots away from the pupil. And then once you have done it, see if there is any leak. If there is any leak, don't hesitate in putting up another suture wherever there is a leak. As I said, you have to take a decision on table. And then you, as you can see, I was seeing some leakage here. So I'm taking 2 more sutures in these areas. Sometimes you take 1 suture and you see the previous suture has become loose. In this case, the first suture, it became loose. It's absolutely fine. Go ahead, remove it and take another suture, and then bury the knots and place a bandage contact lens if you want. I like it because it makes the patient comfortable. So this is how a wound which has an apex is sutured. Next important thing is where if the limbus is involved or not. If limbus is involved, limbus should be sutured first. The first suture will be at the limbus, and it will be a pretty long and tight suture. Then will be then at the edge, then again same, divide into 2 and then again divide into 2, and you finish it off. In the periphery, larger, more tighter sutures. When you are coming toward the center, maybe a slightly smaller size. So here again, you can see there was a limbus tear. So I can see there is a tear in the limbus. So this is broken. So first suture will be at the limbus. I have not even, seen this. I'm not trying to reposit this iris or anything. I'm just securing the limbus first. Sometimes 2 parts of the limbus are, 2, 3, or even 4 mm away. So you take suture in one end and then take suture in another end. Ensure you have made this anatomy of limbus perfect. This will be the first suture that you take. So now I'm seeing where it is. So I'm just trying to separate all the membranes. Because it was a fresh wound, I'm trying to deposit the iris back. And here I can see here, there is a limbus in this area is also involved. So again, so next suture will be again at the limbus, the other opposite side of the limbus. So this again will be, so this is as much as possible, we should avoid this. But sometimes, as I said, it is not possible. So ensure that your suture, first suture, the limbus is well spared. This will be very tight. You can see it is very tight. So once these are tight, then you go ahead and make these all perpendicular. Same concept. Then larger, preferably go from the non-edematous area. Here you can see this will be perpendicular to this part. So it will not be parallel to the other suture. It will be perpendicular to where the incision is. So I'll just fast forward it. Again, this is a small apex. I'm suturing this apex. I'm suturing this apex, and then in between we will now since there is some part is restored, I'm placing a viscoelastic from the side port, ensuring that there is no part of iris is in the wound. So you can see here both from up and below, both I'm just ensuring that there is no part of the iris is left over. And then same concepts, and sometimes you can see there is a wound here also, there's a tear here also. So that also you need to repair. This will become a Y kind of incision in this area. So again, in case you feel later on there is some leak, you can always place some bandage contact lens and some glue. In this patient, I think we had used some glue here in this area. So again, as I've already explained about the intraocular thing, that these things will be taken care of later. If there's a vitreous, go ahead and do the vitrectomy. So now we know in the OT, before picking up the needle, you need to evaluate, need to wash, and while doing the suturing, what are the ALTR and what are the sequence of suturing. So once suturing, everything is done, visco wash is done, patient is out. What do you do after OT? Systemic antibiotics, post-op topical steroids, cycloplegic, and B scan on first post-operatively. It should be must, because you need to document how the vitreous, is there any verticose, any foreign body or anything, and then you explain further, and you plan whatever you want to do, a cataract surgery, you want to do anything, and these sutures, they tend to get loose. Watch for them and ensure that any loose suture should be removed. If you are removing within 1 month, replace it, otherwise you can remove it. Routine suture removal would be around 3 months. In children, they tend to get they heal early, so you can plan a slightly early suture removal as well. So I have just repeated this slide because each laceration is different and you need to customize it. But just remember the basic principles, how we are going to oppose these 2 margins and what are the sequence of suture that we are going to use. So I hope that I could do some justice to this, but this I'm open to any other suggestion, because this is what we generally do here. So I acknowledge our department, especially Vishwa, Yatri. We did a class the day before yesterday to understand it more. Thank you so much.
It was a wonderful class, because it was actually a master class, I must say.
Exactly.
Thank you so much. Dr. Vijayalakshmi and Dr. Sina will have a few questions, if any quick
Actually,
questions.
I think there are no questions. I think Madam has asked whether you prefer to do air injection or to repose the iris back. I must ask a question about it.
Okay, so I generally like to use viscoelastic to deposit the iris back, but at the end of the surgery, if you want to use air, it's absolutely fine. But as a principle, we should make our wound watertight, not the airtight. So once you are sure, and then suppose you are seeing that there is air is again coming and iris is again coming, you want to place some air bubble, it's absolutely fine.
Yeah, and you routinely give intracameral antibiotics after the
So preferably yes, but again, we generally preferably, because these are bad wounds, so it's better that you can give a preservative-free moxifloxacin or cephalosporin if you want.
Yeah, one request: if you can upload this module as a class into the YouTube, it will be very, very useful.
Sure.
Really useful for all PGs and all fellows and even senior residents and even practicing ophthalmologists, because not given or explained anywhere so beautifully. A wonderful class, all the tips included. Dr. Sina?
Any quick questions? Yeah.
In iris, if the iris is outside the wound, when to do the reposition, when to do the excision, everybody will be having a question regarding that. I would like to get an explanation from you.
Okay, so what I see, if possible, reposit the iris back. That is best. We need to restore anatomy as much as possible. Having said that, we need to understand that why is this problem? Why is this question? This is because if this iris is already necrosed, it is not going to serve any purpose inside, right? So if this iris is out for more than 24 hours and you feel that iris is not healthy, it's better to remove it. So whenever you have a doubt on the health of the iris which is prolapsed, please cut it off. But if possible, generally within 24 hours you can reposit it back, but ensure that you wash it well. Very important, spend some time, wash it well. If there is any dust, anything, just wash it well and then you can deposit. So if you want a thumb rule, you can think of depositing it within 24 hours. After 24 hours, you can, chop it off. But again, you need to take a decision on the table as per the case.
One more question. If there's a punched out lesion, like in a pen injury, how do you go about the suture? Do you put a crisscross suture, put glue and BCL, or do you have some other technique? You have not used purse ring, you have mentioned. That's why I'm just asking.
Yeah. So I had this pen injury, I think just a couple of months back. A child, he was playing and did that. So fortunately that he came to us 4 or 5 days later, and by that time there was already some pseudocornea and everything was, even forceps was negative. But yes, if you want, you can use a cross suture, absolutely fine. These are generally round wounds and they seal well. It's generally nothing happens unless where do you see problem? Problem is when we have a loss of tissue. So suppose 1 mm of cornea has been lost, 2 mm of cornea is lost, then you'll have it. Then it is very difficult. You have to put multiple suture. You have to put some glue also, but it's absolutely fine. You need to ensure that at the end of the surgery, you have a good watertight wound.
Yeah. In that case, when there is tissue loss, there will be loss of astigmatism once you have sutured it, right? Do you use an amniotic membrane to cover that?
No. See, no. Amniotic membrane, it's not that we are filling that defect with the amniotic membrane. No. So at that time, just seal it. Ensure that you have close the wound, let it heal whatever way. In case it's a weird kind of astigmatism, deal with it later. When everything is quiet, you can even sometimes, you have a really bad wounds and you have to do a penetrating keratoplasty later. It's absolutely fine. So at that time, so I don't think that there is any role of shoving in some amniotic membrane and do it. So, and we have not done it yet.
Thank you so much, Dr. Vikas.
Vikas. Yeah, thank you.
Thank
Vikas.
you so much. Thanks so much.
Let's come to the last talk. It's basically about the chemical injury. An expert, Dr. Bhaskar Srinivas, he has got vast experience in this. He will give an overview on the acute care and the follow-up management. It will be discussed by Dr. Anil Radhakrishnan from Amrita Cochin and Dr. Sandhya Somasundaram from Government Medical College. Over to you, Dr. Bhaskar.
Can I share my screen?
Yeah, sure.
A very good afternoon to one and all. It's been a wonderful session, very educative. I'm sure not just the attendees, even the faculties have learned a lot during this course in terms of how to manage ocular trauma. I would briefly be taking you all through management of chemical injury, the acute care, and what are the follow-up that you would want to do in the acute phase. No financial interests here. So basically, when you're looking at chemical injury, it's a true ophthalmic emergency, which is potentially devastating with significant ocular morbidity. And primarily, you have the younger people who get affected, either because of work-related injury. And if you're looking at severity, it depends on the type of agent which has caused the problem, the concentration of the agent, the contact time, the area of the contact, the intraocular penetration of the agent, and the added mechanism of thermal or mechanical injury, which can complicate the outcomes in these eyes. So when you're looking at an ocular injury, it's important to actually grade the severity, and we have to go ahead from Dua's class, from Rupert Hall to now at least start classifying people with respect to Dua's classification, which basically grades it on the basis of conjunctival defect and corneal epithelial defect, and gives you a grading as to how you would want to prognosticate in these eyes. But even with Dua's classification, there are lacunae. An eye which is absolutely white like this indicates the prognosis is very poor, because Dua's classification doesn't take into account scleral ischemia, it doesn't take into account IOP related issues, it doesn't take into account exposure. So if you look at both these images, both these would come as grade 6, where there is complete bulbar conjunctival defect and total conjunctival corneal epithelial defect. But the prognosis for both is different. This we were able to salvage. This actually required a keratoprosthesis after multiple attempts at salvaging the eye. So when you're looking at management, you need to know, you need to first get rid of the chemical which has entered the eye as much as possible. You need to retain or regain the stem cell function, if any. You need to retain the clarity of the cornea as much as possible. You need to overcome the fornicational shortening effects of nature and try to maintain a fornix as best as possible. And you need to prevent sight-threatening complications like corneal melts or perforation from happening. And for all this, the most important thing in chemical injury management is to get an intact epithelium as early on the ocular surface. So when you're looking at a broad management, obviously medical management would be with respect to antibiotics and cycloplegics in the initial phase, but do not forget steroids. Steroids play a very important role in managing the inflammation in chemical injuries. And the only worry with steroids is in terms of a melt, but that is going to happen after a 10-day period. So, and if there is a defect which is persistent beyond a 10-day period, you need to take the patient up into OR, because you might want to consider putting in an amniotic membrane for that patient. So we've looked at chemical injuries in terms of in terms of I's and E's. You have the inciting agent, inflammation, ischemia, intraocular pressure, and the E is basically the epithelial defect and the exposure. So for the inciting agent, the most important thing would be irrigation. Do not delay the irrigation. Whatever solution you have available in your OPD room, you can use it to wash it. You do not have to wait for specific solutions as such. You would want to wash it at least for about 10 to 15 minutes, and you would want to check the pH at the end to be sure that you have washed the solution, washed the chemical of the eye as best as possible. In case of patients with tuna injury, sorry for the video, yeah, you can actually flip the fornix and you can see the tuna which is coming from the fornix, and you need to remove this in the OR. Sometimes the tuna might actually stick to the sclera or embedded in the sclera and the cornea, and in the early phase you might have to remove that, because unless you remove that, the inflammation is not going to come down. Corticosteroids, like I said, plays a very important role, and it needs to be started very early in the phase of the disease. Yes, there is a defect, but you're more worried about the inflammation causing a corneal melt rather than steroids causing a corneal melt in this situation. If the defect is small, you might get away with a contact lens. If the defect is large, you might need to use an amniotic membrane transplantation. And if the defect is significantly large, grade 4 or worse of Dua's classification, we have had reasonably good success using allogenic limbal cells along with amniotic membrane to epithelize the ocular surface faster. These are some of our patients where there was a grade 6 or grade 5 chemical injury. We have been able to epithelize the ocular surface just with one-time amniotic membrane with an allogenic limbus. Once the surface is epithelialized, after the standard period of 4 to 6 months, you can go ahead and do an autogenic limbal stem cell transplant from the other eye in case of unilateral injury. The idea there is basically to stabilize the surface and heal the epithelium. And this is what we published when we compared our alloslet outcomes versus the outcomes of amniotic when we were doing only a plain amniotic about 8-10 years back. We felt that doing the alloslet resulted in less number of surgeries that we required to heal the ocular surface in these patients. We had less symblepharon formation in these patients. We were able to visually rehabilitate these patients earlier, and the amount of patients who required an LK or a PK subsequently significantly was lesser because we were able to get the epithelium on the cornea faster. Again, the other thing which you need to look at is ischemia. A localized ischemia might be managed without any surgical intervention. But when you have a global ischemia like this, you will need to consider tenonplasty, which has been described by Rhyme long back. And basically, you need to mobilize the intact tenons as far as possible from the peripheral fornices and suture it close to the limbus with vicarial sutures. You must mobilize it such that there is no fornicial shortening. This video shows the surgical principles involved, where there is a complete bulbar defect. There is ischemia. We are cutting the conjunctiva. There is no bleeding as such. We go deeper and deeper till we reach tissues with vasculature. We mobilize it, suture it to the surface. Then we have used the amniotic to drape the ocular surface and the back surface of the lids, suture the amniotic membrane to the lid margin, and then cut the allogenic slit bits and secure it on the surface and put a contact lens. This grade 6 injury we were able to salvage, and with a couple of alloslits in the chronic phase, he's maintaining 624 vision in his own eye. The other eye, he had phthisis when he presented to us. The intraocular pressure, whether it is high or whether it is low, needs to be looked at and managed appropriately. Exposure is again something which needs to be addressed, because if your lids are like this, obviously the cornea is going to get exposed and melt, and you have to make sure that you get an oculoplasty colleague on board and release these scars, whether with or without a skin graft, and do it. If it is a significant SCR, you might have to do an SCR cut down and make sure that you cover the ocular surface either with a tarsorrhaphy or with a skin graft to salvage the eye to live another day. If you have a perforation which is already there, you might need to do a tectonic procedure either with an LK or a PK. In this side, we had to do a LK first and subsequently did a PK, and he retained some vision. If there is a perforation, you can also combine it with a keratolimbal allograft in the acute phase. It gave a source of limbal cells for the graft to survive a little bit. And when the graft started failing, the epithelium started failing, we did a CLA. This was done about 8 years back. He's still maintaining vision in that eye about 636. So when you're looking at it, you're looking at the eyes, the inciting factor, the inflammation, the ischemia, and you're looking at the ease, the exposure, and the epithelial defect. And the most important in the entire jigsaw is the epithelial defect, because once you get the epithelium to heal, most of the other problems settle. And so we've come out with an algorithm which basically tells us what you want to do. If the ischemia is less, you can observe it. If it is generalized, a tenonplasty. If the exposure is mild, you might do a lateral tarsorrhaphy. If it is moderate or severe, you might want to do a complete tarsorrhaphy or with or without a skin graft. And if you're looking at an epithelial defect, you need to know whether there's a corneal defect or a conjunctival defect. A corneal defect, which is small, can get treated with a bandage lens. A larger defect requires an amniotic. But when you have a corneal and conjunctival defect, you need to know the extent of conjunctival involvement. If the extent of conjunctival involvement is large, you might have to combine it with an allogenic cells along with the amniotic membrane for faster epithelialization of the surface. You could also use oral mucosa as a source of epithelium in these cases. If you have stromal melt or scarring, you have medications to reduce stromal melt in terms of doxycycline and ascorbate, both topically and systemically, that can be used. And if there is an actual perforation or melting, an amniotic or a tissue adhesive or an LK or a PK might be required. So this is just a couple of our examples. A patient with grade 5 duas with scleral ischemia. This eye underwent a tenonplasty and amniotic. It failed, subsequently required a penetrating keratoplasty with an AGV. The second eye of the same patient required an LK. We did a PK. This PK failed. And then subsequently, he underwent a Boston keratoprosthesis and has a reasonable vision in that eye. Another patient who presented with perforation with retina in the pupillary plane. We did a PK at the first instance. Then we combined a PK with a VR procedure subsequently. And we tried a surface reconstruction. The surface did not epithelize. So we went and draped mucosa on the surface, and then subsequently did a type 2 Boston keratoprosthesis through the mucosa. She regained back 612 vision in her only eye. Another patient with a severe injury initially had a PK with keratolimbal allograft in the reasonably acute phase, and subsequently that failed, and he had a Boston keratoprosthesis. He's had multiple interventions after that with respect to lamellar melts of the carrier graft and conjunctival hooding, but we've been able to retain his vision of 618 in the only eye for the last 7 or 8 years now. Another patient with a lid stuck to the cornea with a perforation, had an RD, underwent a PK VR surgery. We settled the RD, and then once the graft failed, he underwent a keratoprosthesis with 624 vision at 6 years. One of our really bad cases who presented to us, bilateral injury, query PL, psychologically she was upset. She was a vitreal arch victim. We did a VEP. VEP did show some response, so we decided to give her the benefit of doubt. We draped the ocular surface with mucosa and subsequently did a Boston type 2 through the mucosa. She has only 3/60, but at least she's self-ambulatory, and it has been a tough journey for both her and us. Another patient where there's a perforation in the acute phase with the protrusion of the lens. I'll skip this video. So basically, again, with a protrusion of the lens, you will need to take care of the lens, do an LK, and then subsequently the eye lives to fight another day, and we did a keratoprosthesis, maintaining some vision in her only eye. So to conclude, when you're looking at acute chemical injuries, you do have options of trying to save the eye, so that if you're not able to restore vision immediately, at least 6 months, 1 year down the line, you have some option of visually rehabilitating them as far as bilateral injuries are concerned. When you're looking at unilateral injuries, it's much more simpler. You have the other eye to take limbal stem cells from and do the fornix reconstruction and do a limbal stem cell transplant. So we've come out with an algorithm as to how you would manage a unilateral limbal stem cell deficiency, and this is freely available in APJO as an access for everybody. And when it is bilateral, you are looking at whether it is keratinized or it is not. If it is keratinized, you're probably looking at keratoprosthesis. If it is not keratinized, you can try forming the fornices and then try some kind of an allogenic limbal cells or a cultivated oral mucosal cells to see if you are able to visually rehabilitate these patients. So to conclude, desperate times require desperate measures. You might sometimes need to think outside the box in these cases. An acute phase management significantly decides the chronic phase outcome. And in a patient with a bilateral injury, every effort needs to be made to restore the possibility of some vision in these unfortunate victims. I would acknowledge our patients and the team at Shankar Nethralaya, Dr. Geeta and Shweta, who manage the ocular surface clinic. Thank you.
Excellent talk, Dr. Bhaskar. It's always a pleasure to hear you. Wonderful set of cases you have shown. Anil sir, any quick questions, comments?
Yeah, that is Bhaskar for you. Very fast and very comprehensive and loaded with a lot of information, as always. And I think they show the most gruesome cases in India because of the excellent clinical that managed ocular surface clinic that they have in Shankar Nethralaya. I think for the benefit of practitioners and the residents, I think if you have a total epithelial defect, will you go ahead with hourly steroids in the acute injury? I just wanted to stress that point.
Yes, I mean, if there is a corneal defect alone, you expect the defect to heal. Even though it comes under grade 6 of DUAS, you would expect, even if the limbus is damaged, DUAS doesn't talk about limbal deficiency, it only talks about limbal involvement. There is going to be inflammation because of the chemical, so you will need to give steroids. But if your conjunctiva is still okay, like only 10% of conjunctiva is involved, even if it epithelializes, it will epithelialize by the conjunctival phenotype and you can subsequently do slit. So the idea would be to control the inflammation, put a contact lens for comfort, put steroids 8 times, 10 times in a day and observe. The only worry that we do have in an Indian situation is the risk of fungal infection with a BCL, with a steroid. But once you inform the patient that this is required and you make sure that there's no mark on the surface, clean the lids properly, and then put the contact lens and make sure that you see the patient frequently every second day to be sure that you're not dealing with an infection. So yes, I would put bandage lens for large defects. Yes, I would start steroids. If I have a significant bulbar conjunctival involvement, which is going almost till both the fornice, till both superior and inferior fornice, I would prime the patient that he will need an amniotic at the beginning itself. I don't have to rush with an amniotic. I'm starting the steroids, putting a contact lens, seeing by day 1, day 2, and then tell him that yes, he needs it. Because if it's almost like fornix to fornix involvement, it is unlikely that it's going to heal in 10 days time, at which point you're worried about the melting effects as far as steroids are concerned. And if it's a child, any child with chemical injury acute, I would want to do an examination to make sure that I'm not missing any lime particle sitting in the fornix.
Regarding the large epithelial defect, you would go for a large amniotic membrane survey or along with others?
If it is see, allogenic slit, we are doing it in SN because we do have access to tissue. Private practitioners will not have access to tissue that easily. I would definitely, if there is a bulbar involvement which is extensive and the defect is not healing in a week's 10 days time, go ahead and do an amniotic. If it is still not healing, look at options of referring it to your cornea colleague who will be able to help you out with doing an allogenic slit. Other option would be to do a tarsorrhaphy. We basically need to preserve the epithelium, the ocular surface. So either you give cells so that it covers it, or you close the surface and allow it to heal under a closed surface. Before we were doing alloslit for very bad injuries, we just do a tarsorrhaphy, do an amniotic, do a tarsorrhaphy and close it. The problem with that is your fornices, everything just gets shut. Your lids can sometimes stick to the globe, and then subsequent visual rehabilitation becomes more of a challenge as such. With alloslit, we found that at least we are able to retain the fornix and our subsequent maneuvers become much lesser. Number of interventions that we are requiring for a very severe injury becomes much less.
Dr. Sandhya, any questions from your side?
So it is usually said, no, there is a risk for corneal melt if you continuously use steroids in a high frequent dose. So should we taper the steroids after 7 to 10 days, or can we continue the steroids at?
That's what I said. Yeah, the reason for melting is because of the stroma being exposed to the collagenollytic effect of the steroids. So if you have a defect for more than a week to 10 days, you need to do a surgical intervention. You need to put an amniotic. With the amniotic there, you continue with the steroids. There is no issue with that.
Then again, the role of autologous serum, sir, you have any practical experience?
You do not use autologous serum. Yes, you can. The group from AIMS did publish with umbilical cord serum and autologous serum. They have said that the results were as good as amniotic membrane in their RCT that they did. But then we don't have a practical experience at our center with both umbilical cord and.
Okay, sir.
Interestingly, in their series, I think even the limbal ischemia was better with umbilical cord serum. You know, the amount of people having limbal ischemia was less in people. I don't know why it is so.
I mean, you have issues with in these chemical injuries because it's very difficult to sort the patients exactly into groups because we cannot estimate. There's no way for us to estimate limbal deficiency at this point of time. What was initially mentioned as limbal deficiency is only primarily limbal involvement, because it's only when the healing happens that you can actually grade the severity of limbal deficiency. There is no markers at this point of time for us to know what is the extent of limbus that is damaged. Till that happens, it's going to be very difficult because it's going to be your word versus mine. Even though the pictures look absolutely the same, the extent of limbus damage might be different.
Sujit, can I ask a question?
Yeah, sure.
So, Bhaskar, this was a wonderful and very good presentation, overall exhaustive, covering everything. Thank you so much. So, my question is, when you do allo slit, so do you have a time frame like how fresh the tissue should be? So, do you feel that it is within 24 hours, 48 hours? How have you, quantified that?
We've generally used it within 48 hours most of the time because you want viable cells. The only advantage with an allogenic tissue is unlike the normal slit where we put 2 or 3 clock hours, here you have so much of tissue you can actually put. So even though the inflammation will kill some of the cells, at least you expect some cells to escape the inflammatory phase and populate. What we have seen is generally by a week's time, just like in normal slit, you expect the epithelialization to happen by about a week. 10 days, you get an epithelium covering. Here also, it generally covers by that point of time. And as soon as the epithelium starts healing, the surface inflammation comes down. Sometimes during COVID times, when we did not have access to fresh tissues, we have used older tissues, and there the results have not been as good. So whether it is the time frame that we are looking at, but then we did not have a choice. We said, okay, whatever tissue we have is 4 days old or 5 days old, but we don't have any other fresh tissue because of the restrictions that we wanted to be sure about using the tissues during the COVID related regulations. So there somehow the results have not been as good as what we have when we are doing within 48 hours.
True, because we don't have we don't have an eye bank, so we are a transplant center. So what we generally get is 48 hours, sometimes 72 hours, sometimes more. And what I have found that if you take a 5 days later, it's very fragile. It comes off even with your sponge. So you can't really take a biopsy and place it. So I think that is a very valid point, that if you do it early, and that works beautifully well. And
the other thing is sometimes the eye bank corneas, they chop off the limbus completely because they want to keep it as sterile as possible. So sometimes you don't get any limbal tissue in the cornea. So unless you have your own eye bank, you can technically make sure that you get some amount of limbus in these eyes.
Thank you so much.
Thank you.
Okay, thank you. And let's go to the next session, that is interesting cases and videos. We have a few 5 to 6 cases. Videos. We'll start with Dr. Gopal Pillai from Amrita, Cochin. Sir, over to you, sir.
Okay.
Next case will be from Dr. Vivek. Please get ready. Yes, sir. Gopal, sir.
Can you see my screen?
Just starting.
Yeah. Okay. So, good afternoon to all. It's been indeed a great pleasure listening to all these wonderful talks, and I congratulate Sujit, Vijay Lakshmi Madam, Suma Unnikrishnan, and all the KOS for having this wonderful meeting and bringing in the experts. And it's been a real eye-opener on World Trauma Day, actually. Okay, so I am.
Yet. Now
Pardon me?
Yeah, now we can see your screen. Yeah, okay.
Okay. So this is a 40-year-old, very high myope who had actually a high myope of -15 diopters, who had trauma in the left eye 6 months back. And he had somewhere around hand movements, PL, PR vision at this point of time when he came to us. And he had lost vision about a month back. There was a total cataract, which is completely dislocated. And ultrasonography had actually shown the retina to be detached with a central area of a little traction peeking up. So that was the case. So as I said earlier, we need to think about what to do, strategize. So here was somewhere where complete dislocation was there. So I was thinking that, you can go inside and phaco-fragment it. All the more reason because there is a retinal detachment behind with a central traction. And so I thought that there would be some manipulation required. So if I open up the cornea, my suction would be a little less. And again, that would be a little reason why I would go for a phaco-fragmentation inside the eye. So then we went in. So this is the case starting. You can see that I've just used a MVR to remove the lens. And it is basically there because of one or two strands of the zonules, and this is the phaco-fragmentation there. So after just doing that, I made a small plane there and removed the rest of the zonules in that supratemporal quadrant so that it just fell down so that I could do it much easily. Now, when we went inside, we saw that there's a giant retinal tear there. The fold is right at the macula. And the first thing that we have to do would be to remove all the vitreous. Then since this is a high myope, there are some challenges involved in high myope. Sometimes the vitreous is very, very thickly attached to the lattices or into the periphery, and beyond the equator, it may not go. So here was the lens, which was refusing to come out. So I completed the vitrectomy completely and decided that, I will use a PFCL to force the lens out. So just putting the PFCL, you can see that the lens is slowly moving out of the subretinal space, and we put it on top of the PFCL. Now, usually in a nucleus drop, generally people don't use PFCL, but this is a case where there is a retinal detachment, which is fairly mobile, and the edge, which is very posterior, right next to the fovea. So that cushion of PFCL will help in keeping the retina stabilized while we are doing the phaco-fragmentation. So completed the phaco-fragmentation, and you can see this was a little more harder than I expected. Myopes sometimes have a little more harder nuclei. And then once the nucleus is completely removed, then we went in for more vitrectomy. You can see that it's a very posterior giant retinal tear here. Anyway, this is in the inferior area. As I told you, in myope, sometimes it is extremely difficult to peel off the periphery. So I'm using a forceps to try to remove the vitreous from the periphery and remove it as much as possible, as much peripheral as possible. In a retinal detachment and GRT, etc., if you leave peripheral vitreous behind, that will lead to contraction. One more thing I want to add here is I could have put in a buckle here, but since the ultrasound is showing me a posterior traction, that is why I did not do that. Now, this is a very peculiar giant retinal tear. This is quite posterior, and there's a lot of anterior, part of the retina there. Usually, our idea in a giant retinal tear would be to remove or ablate the anterior retina. So now I've closed the phaco-fragmentation port to make sure that the suction, we have adequate suction while we are doing the air fluid exchange. I was basically planning an air fluid exchange in this patient. I had used PFCL, but I wanted to know, I removed the PFCL. So I wanted to know whether this flap, how much is the, the rigidity of this flap. So I did a air fluid exchange there, and I was trying to work on the flap. So this is gas coming out through the port. I had done an Andos iridotomy, inferior peripheral iridotomy, so that secondary glaucoma does not occur. And otherwise in affix with silicone oil, there would be some problems. So this is a continuation of the air fluid exchange. Cornea slowly became a little hazy over a period of time. So I'm trying to straighten the flap. And as you can see, I had made another retinotomy also. Now you can laser. It is quite posterior, so I cannot come very close to the fovea, but you need to be strong because that is a flap which can again turn back. Now, the anterior part of the giant retinal tear, you can either excise with a vitrectomy probe. I basically did a cryo to that particular area so that we could ablate that, because that would be another area for problem. Why did I do that? Basically because I feel that whenever there's a large retinectomy, the visual prognosis reduces slightly. And once everything was over, I filled it with silicone oil to complete this is silicone oil getting injected, and made sure that there is a full fill. And we completed surgery at that point of time. This patient had 6/18 vision, and this would be the end of surgery.
I request the retina people here, Dr. Vivek, Dr. Prashant, Dr. Prakash, for your quick comments on the video, any suggestions?
Yeah, wonderful case, Gopal. In fact, it was a subluxated cataract, if I am not wrong, correct?
Dislocated, completely dislocated. Actually, it is mobile.
Yeah. Okay. So absolutely well managed. Only thing what I would have done differently is that I would have completed the after putting a PFCL up to the age, I would have planned to do a complete fluid air exchange and complete the base excision. And I also prefer to do what we call under air. Also, I try to remove the peel of the peripheral vitreous skirt as much as possible. And why did you use cryo instead of a laser when you had such a beautiful endolaser probe with you? Unnecessary adding more morbidity to it.
Yeah, you could use laser. It's okay. I mean, it's faster. Cryo gets bigger burns. It's a more, because anyway we have to ablate that anterior retina. So I thought cryo was a better way of ablating rather than cutting it out.
Yeah. So ablation of the anterior retinal tissue is what should be done, because it's a devitalized tissue and it can lead to rubeosis. That is the purpose why we do either a laser or a cryo. Cryo being more morbid can lead to more inflammation. I would have preferred a laser. That's what the message should go rather. But absolutely beautiful surgery at a professor's hand. What more to question?
Dr.
Vivek, any?
Yeah, Vivek.
Yeah, I had one question regarding a comment that Dr. Pillai made about adding a buckle. Do you regularly put buckles in your giant tears? Because it said that with the buckle indent, sometimes because of the large size of the GRT, you may actually cause a slippage which otherwise would not be happening.
I cannot agree with you more. I don't usually put a buckle. I don't usually put a buckle at all, but this is a very high myope. And in some cases where we are not able to remove the vitreous till our content, that small problem remains. That is all. So I also don't, especially this temporal giant retinal tear, which is quite posterior. You could not have supported that at all in the buckle at all.
Exactly.
Only thing is not a buckle, probably an encircling element or something like that. So that is a retrospective thought. Even now, I think that is not required. I don't generally put that. I'm with you.
Right. Excellent, Sajay. I have not personally come across a situation complicating a giant retinal tear with a nucleus down there. Must have really been tough.
PFCL brought it out. Yeah.
Prakash, any comment?
Yeah, it was an excellent surgery, Gopal. Very well done. And only thing my different approach is I would put PFCL completely up to the giant retinal tear and do the laser and do a PFCL oil exchange. I don't do a direct fluid air exchange with giant retinal tear because somehow it tends to slip and form a dry fold at the macula many times. So I usually always use, for any giant retinal tear, I put PFCL covering the entire thing. And another thing I want to tell for beginners or anything is just do a thorough vitrectomy before doing a fragmentation, phaco-fragmentation. So that itself can sometimes cause a not in this case, but generally you can cause a giant retinal tear if you have not done sufficient vitrectomy before fragmentation, phaco-fragmentation.
Yes, important points. When you are using a phaco-fragmentation, don't pull on the vitreous.
Correct.
Okay, sir. Thank you. Then we can go to the second case. Again, I think is a retina case, Dr. Vivek. Or is it the foreign body at the angle?
Is my screen visible,
Yes,
everyone?
yes, Vivek.
All right. So, Dr. Sujit, this is actually a list of various foreign body scenarios. So, do let me know where to stop when my time is over. I'll just go through one scenario after the other.
5 minutes, then I'll give you 2
just
minutes.
let me know at the end of 5 minutes. So, my first case is a case of a disappearing or a hidden foreign body. So, in this case, you would see that there is a foreign body which is present as shown in the CT scan, clearly seen in the coats of the eye. And if you look at the location is right there at the posterior pole. So we have this corneal laceration with a traumatic cataract. We deal with the corneal laceration.
Vivek, is it playing?
We are not seeing the video.
We are not seeing the video.
Oh, is it?
Yeah.
Okay, it's playing for me here. Is it not playing there?
No, we can only see hidden foreign body MP4.
You can click once more on the link.
Okay, just a moment.
Some message had come in between. What is it?
Can you see it now?
No.
I think you have to reduce this and open the other the video which is playing.
I think it is
okay.
Maybe Vivek, you shared the PowerPoint. You should share the screen.
Yeah.
Maybe you shared the PowerPoint.
Yeah, 1 second. Just let me know if it's visible.
You can
now.
see the link now.
Is it visible now?
No, not yet.
Not yet.
Vivek, I think you should stop screen share and again share the screen, not the PowerPoint, and then whatever is in your screen you will see.
Yeah, sorry for that. Now?
Yeah, we are seeing the videos.
Can you see the playing video now?
No.
We are seeing the folder.
It will come.
We can see your only screen.
Yeah, we can see all the videos 1, 2, 3, 4, 5, 6,
okay.
7 videos which is there. So probably
unfortunately it's playing for me here. Dr. Sujit, maybe the next speaker can come in. I'll just sort this out.
No, means it is not shared. That's why we just have to open the videos and then share. Keep the videos open and then share. Okay, that can happen. If you want to go next, I will do it.
Okay. So Dr. Minu Martin will present his cases. Meanwhile, Vivek, you can get ready with your video.
Yeah.
Minu, sir, please.
Okay. Thank you, Sujit, for this invite and very nice sessions going on. Can you see this video? Is my video on?
Yes, sir, we can see it.
Sujit?
Yes, we know.
Okay, so this is a case. Yeah, this is a case of a 70-year-old physician and having trauma. So interesting thing was his trauma was by his stethoscope, which he was rotating around like this and it hit his eye. So that also can cause injuries. So that was few years back and he came with a very hard cataract and he had a small pupil also. So here goes the phaco. So after putting in iris retractor hooks, this pupil was dilated. And then please notice the movement of the lens when I'm trying to initiate that's a diffuse loss of zonules, but some zonules are still there, but many zonules are not there, fibers. So once this happens, I'm just showing you another case of how to proceed. Many times you move the needle, the lens itself moves. So it's difficult to initiate and make a adequate size rhexis. We need quite a adequate size rhexis here. Many times it will become very small once you do this because there is no counter traction from the zonule. So this is another case, just a similar case, just to show you a technique which can be used. So it is using 2 microrhexis forceps. So once the tear is initiated, you hold at one end of the tearing end and hold the other tearing flap and then regrasp again and give a counter traction with the second forceps. Then we can make a continuous rhexis. Once that is done, see multiple areas we have to regrasp and give local counter traction so that the lens doesn't move along with the pull. Once we do that, we'll most probably end up with a 3mm, 3.5mm rhexis. So at least 4.5 or 5 we should have. to prevent later or to have a good lens centration and to prevent later phimosis. So you can cut and extend like what we showed here. So here again, after a rexus is done, I am supporting the rexus with iris retractor hooks. Preferences are individual preferences. You can use a capsule hook also. But then I like 4 iris hooks on the iris, and adjacent I have 4 iris hooks on the rexus margin. So there are 8 hooks on the eye now. So once that is done, a hydrodissection is very important, because these kind of lenses are very hard and large, and very gentle hydrodissection with a little shallow anterior chamber. Chamber should not be too full. And once the hydrodissection is gently done, the initial rotation is very easy. Otherwise, you will traumatize more zonules. So here, after first dissection, use 2 instruments. One is a chopper and second is a phaco probe for counter traction, so that the nucleus rotates well. So this is a very hard cataract, but gently, slowly, slow motion phaco, we can finish off phaco. Once that is done, the cortex aspiration again becomes very difficult, because there is still no counter traction. See, again here, during cortex aspiration, I tend to put in viscode into the bag, so that the bag remains full and extended. See, at any time, we can put in a capsule tension ring. I have not yet put it, because initially it was a very huge lens, and if you try to put in a CTR through when the lens is inside, you may cause more zonular damage. And here again, while aspirating, because I could fill the bag very well with viscoelastic, I could slowly peel it off. Otherwise, we'll see the bag also coming along. So here you can notice folds on the capsule. See, these are folds which are there on the capsule, telling that especially the posterior zonules are very much lost, and only few are remaining. But still the bag holds. So very slowly, aspiration flow rate has to be very low, and slowly we can, with patience and time, we can complete it. After that, my CTR goes inside. So CTR goes in, I like to place it in through a paracentesis, and once it is towards the end, the trailing haptic has to be held with the forceps, so that we can place it right into the bag. See, again, we should make sure that these hooks which are there in the way should not come in the way. So clear that off, place it away. Initial eyelet has to be placed in between these 2 hooks, and then it proceeds smoothly. And microrexus forceps again is good to hold the tip of the trailing part of the CTR, and then go till the rexus margin, use a Sinski to guard it and place it into the capsular bag. Once that is done, I release all the hooks from the rexus margin, and go ahead placing a 3-piece multi-piece IOL. So this multi-piece IOL goes into the sulcus, and once that is placed into the sulcus, my preference nowadays is, once the CTR is inside and there is diffuse zonular weakness, I would place it in the sulcus and capture the optic within the rexus margin. So here again, evacuating the bag as much as possible, because this is done under sodium hyaluronate. So no HPMC, no viscode, because it is difficult to aspirate off. So once you place sodium hyaluronate, it is easier to evacuate. So aspirating it will be slightly dangerous, because you may catch onto the bag. But you can gently aspirate or even irrigate out most of the sodium hyaluronate from inside the bag, and then do your complete INA. And once the irrigation on, I gently capture one part, and the other side also is captured inside the capsular bag. The optic is now within the bag, and the haptic is in the sulcus. So this is the way we end the case. After 3-4 years also, it is very well centered and is doing fine. Thank you very much.
Very good video, sir. The key points, mainly traction, counter traction. That's a very good method which you have shown. Would you prefer a little more larger rexus than this, especially when the cataract
again, the point is what we are aiming at. See, initial thing is that the hard cataract has to be phacoed, and it should be an adequate rexus. But then, if it is more than 6 millimeters, your capturing will not be good enough, and it has to be central also. So 5.5 will be an ideal thing. With 5.5, any hard nucleus can be phacoemulsified. So if you are planning to convert it into an SICS, then it's a different issue. But if you are doing phaco, 5.5 is fine.
Other than this diffuse zonular injury, if you see that it is like 3 to 4 clock hours in one side, one particular zone or particular area, would you prefer CTR or you go for a Sione ring actually?
No, if it is a traumatic one and if it is not going to be progressive,
Yeah.
Oh, yeah, I'll fix up with only CTR. That is enough for at least 4 to 5 clock hours. That is enough. It will stay because it is not going to be progressive, and the phimosis is controlled by the capsule tension ring
And then
along with the
all such
three-piece
cases,
lens.
yeah, in such cases also you prefer to do it in an optic capture and do it.
Yeah, nowadays that is my way to go. Except if it is a very large one and I have to fixate the bag, then I place a single piece lens into the bag.
Laila madam, any comment on any?
Wonderful video. Wonderful.
Dr.
Wonderfully
Siddharth,
done.
yeah, Dr. Siddharth is asking, do you use specialized capsular hooks for supporting?
Yeah, some I have used them. We have them with me, but then the problem is they are little too bulky for me, and I don't feel comfortable using them while doing phaco. So somehow I am little in my hands. I feel
So
that
which
these are
one do you use,
little
sir?
feel.
Which one do you
See,
use?
I don't have the MST one. I have the one with the longer tip, with the tip flattened and
one.
going into the MST one is also, it is better. It has a wider support for the bag, so if it goes till the bag, fine.
Actually, when
But
it
this whole
happens in
nucleus,
that,
yeah,
when it
yeah.
happens in when you have to hold it in the nasal side, it becomes a little complicated. Actually, you may not get that much of space. That's what.
The way the lens was moving, I was feeling that there is more of zonules involved. So
See, when there are diffuse loss and you cannot see the equator, that means it is there everywhere, but then it is very less.
Thank you, sir, for the wonderful video. Vivek, you are ready with your videos?
Yeah. I have.
Okay, we can go back to Vivek.
I have a compiled video, and that will end in 4 minutes. So I think that should work better.
Okay.
Is it visible?
Yes, Vivek. Yes.
Audio is off. Can you get the audio on? Or you can comment. Vivek? Hello?
Oh, they are not working.
Yeah, Dr. Vivek.
I think he is hearing the audio, that's why.
Yes.
Okay. Dr. Vivek, we can't hear you. Audio is not audible. It's not audible.
It's not audible, is it?
Yeah.
Vivek, you just go to the settings and share sound. Top view
Or
options.
you can give the commentary. No issues.
Yeah. Or you can.
All right. But you can see the video, right?
Video
exactly.
we can see. Yes.
Exactly.
All right. I'll just go ahead.
You have to start from the beginning.
Yeah. Sorry for all that. So what we are seeing here right now actually is a foreign body that is very well visible, located at the posterior pole in the courts of the eye. And very clearly the CT scan shows you that the foreign body is inside the globe. And you would expect that while you're operating, you are going to see it right there on the posterior pole. So this patient also had a corneal laceration, and the laceration was taken care of along with the traumatic cataract, which was actually removed by a lensectomy. So after having repaired the laceration as visible, we do a lensectomy, we go inside, start doing the vitrectomy. I am more comfortable using Kinocort to ensure that the posterior hyaloid is well delineated. And then what I see is actually an impression on the retina behind, but no foreign body visible. So what exactly has happened? I examine all around, and then on indentation, the foreign body is visible right there at the port. So what has basically happened is while the instruments were moving in and out of the eye due to turbulence, the foreign body dislodged from where it was when it was visible on the CT scan and came towards the port. So an important learning here was that whenever we are unable to locate the foreign body at a position where we were seeing it previously on the CT scan, it is very important to indent peripherally and try and see if the foreign body is visible, plugged somewhere in the peripheral skirt of the vitreous. Now, this is a second case which came to us with dispersed lens matter in the eye. There was an equivocal history of trauma. Nothing really was clear to suggest that this patient definitely had trauma, but then nothing otherwise was indicative of why the lens matter inside the eye should be as disrupted as it was. The preclinical examination did not reveal any visibility of the posterior pole, whereas the ultrasound showed us a retinal detachment which seemed to be funneling. Now see what happens as we attempt to clear the lens matter. As we are clearing the lens matter, we see this brownish shadow which is sort of popping up and going back in the posterior aspect of the eye. And as we continued with the surgery, it became more and more evident that this is possibly a foreign body. Right here we are able to see it, which we were not able to exactly correlate with the history. So as we continue the surgery, we realize that going inside, there is this admixture of vitreous hemorrhage and some exudates on the posterior pole. There is the retinal detachment which was visible on the ultrasound, and this large foreign body which was something like a stick which was stuck in the walls of the eye. So using a foreign body forceps, it was dislodged, and this is what we found. A large piece of wood which came out of the eye and was probably measuring about 15 to 18 millimeters. Now, this is the third case that I would show. This patient had a history of injury to the eye by a glass bulb which burst on his eye. When we evaluated this patient in the preoperative evaluation, all that we could see was small area of corneal edema peripherally right there at the 6 o'clock area. And nothing else otherwise was visible other than a small self-sealed corneal tear. So the self-sealed corneal tear, localized edema sort of told us that possibly there could be a lodged foreign body there, and it could be glass because of the history of injury with a glass bulb. So approach to the angle, we decided to do it endoscopically. The anterior chamber was entered with an MVR blade, and the entire chamber was filled with Heal-On to ensure that the chamber is maintained. Once this was done, we took our 23 gauge endoscope and entered through that opening. And once we entered inside, here we are scanning the inferior angle of the eye. You can see the pigmented trabecular meshwork. And as the endoscope scans further, you would see that we would come across this piece of glass right there in the angle. So possible movement of this piece of glass and its rubbing against the endothelium was what was causing the localized edema. So using a posterior segment forceps, the glass piece was held and then removed out safely without injuring the lens or any other aspect of the eye. So in short, in these three videos, what we basically see is if you are unable to locate the foreign body at the place where you would have suspected, think of dislodgement, especially towards the ports. Second is if there is an unclear or a dubious history of what could be the etiology, trauma should always be high on suspicion. And in such cases, you may come across an unsuspected foreign body. And finally, when you have foreign bodies lodged in the angles, which may have difficulty with respect to routine visualization or difficulty with respect to approach, and endoscope can help us visualize those foreign bodies, and with the second instrument allow for a proper retrieval. Yeah. So thank you for that. I'm sorry for all the technical glitches that my presentation had.
Thank you, Vivek. In your that collage which you show, what was the third picture? One long brown thing that was coming out.
That was the stick.
Which one? It was a stick actually. So the piece of wood.
Quite long one.
Yeah.
Where was the point of entry wound there in that case?
Yeah, so once we did that, we actually opened up the eye, and we found at the temporal end on the sclera, there was sort of a puncture wound through which possibly the stick had entered. So it is still a mystery that such a large foreign body actually went in without any clear evidence of trauma in the anterior aspect of the eye. The eye was largely quiet when we came across this patient, even without any localized subconjunctival hemorrhage. So that was the reason it was inexplicable as to why the foreign body would be there inside. The only giveaway to a possible suspicion was this fragmented sort of a lens inside the eye.
Very interesting cases, Vivek. Thank you for sharing. I once remember that you discussed about that glass case, and that's why exactly I wanted you to present that video. Thank you very much.
Right. Thank you, Dr.
So
Sujit.
for the next video, let me invite Dr. Marian Pauli for an interesting oculoplasty case.
Good afternoon, everyone. At the outset, let me thank KOS for giving me this opportunity. Let me share my screen. Yeah. So I'm directly going to the case. Mine is a 29-year-old male who presented with fall from height, and history-wise, the lid got hanged in an iron rod. So I got a call from emergency at 5 p.m. Marian, there is a small lid tear with the lid margin involvement.
Dr. Marian, can you make it full screen?
Yeah, sorry. So I got a call at 5 p.m. Like, no, Marian, there is a lid tear with the lid margin. Can you, can you manage it? So I agreed at 5 p.m. In the evening. So on examination, this is a clinical picture. So while I explored, so the lid tear, there is some crushed tissues, lid margin, and the lateral part, upper eyelid. And medially, you can see another tear involving the canaliculus. Lower lid, there is a lower lid tear also. On further exploration, you can see there is some injury here, but I was not very quite sure like what exactly is happening. This is under loop. And on further exploration, you can see this tear is extending backwards also. So this is his ocular motility. Actually, I didn't examine because here when I saw, I suspected some kind of deep injury. His vision was 6/6 and fundus was normal. So I took him under local anesthesia for a wound exploration and wound repair. So this is the video. So on exploration, like I saw the lateral rectus got injured, and immediately what I did, I tried to find out the posterior end of the muscle, and I just sutured with the 5/0 vicryl. So here the point which I want to highlight is I didn't check ocular movements because once you check ocular movements, the posterior end might go back. So the posterior end was right at it was there, and I could repair the muscle then and there itself. So now after repairing the muscle, now then comes the next challenge. Because from the picture we know the patient was not opening the eye. That means there is injury to levator. So now search for the levator. I searched up to the mid-orbit, and you can see these are all the crushed tissues. Distal end I could manage with proline, and the further proximal end, somehow I managed just beneath the orbital septum and repaired the levator with the cyanoproline. Then I managed the canaliculus with the stent. This does not require any detailed description to find out the distal end of the canaliculus. Then comes the next challenge. After mini Manoka was inserted, pericanalicular tissues was sutured with vicryl. Then you can see the caruncle is displaced. See, this is the displaced caruncle, sutured back. Then coming to the cornices. Sorry. So coming to the cornices, you can see the whole cornices are crushed. Conjunctiva, whatever is there, I tried to make extended and then made the supralateral cornix. Then the lid margin sutured, and whatever possible tissues I utilized and sutured, direct suturing was done. And there was a little defect in the skin that this I closed with the amniotic membrane, which basically prevents fibrosis and ectropia and all those things. So that is the primary management. Now what happened in the post-op period? So this is his post-operative period. Total ptosis, sutures in situ, and you can see the levator. There is a zero levator function in this, even though I tried to suture the levator. So at 3 months, the levator has started improving, and levator function was around 3 millimeters. At 6 months follow-up, levator has again improved, ptosis has improved. His ocular motility remained, it was normal, and fortunately the motility was recovered full. So 6 months, levator function improved to 6 to 8 millimeters. 1 year also remained the same. So at 1 year, I took him for ptosis correction. So this is his pictures at 1 year, that is ocular motility is full. There is a mild shortening and scarring of the lid, and he has got a relatively good lid crease. And with fair LPS, that is 8 millimeter. So I planned for levator resection. So this is his orthophoric also. So planned for levator resection. Intraoperatively, we know the lid was totally scarred and was it was a little difficult case. So this is his posterior picture at 1 month after removing the frost sutures. And this is a 6 months post-ptosis correction. Relatively good correction with a minimal amount of lag of thalamus. So traumatic ptosis, very challenging, and traumatic injury to the medial rectus also, lateral rectus muscle injury also is challenging. Ptosis, you can wait till 6 months to 1 year, and ptosis correction depends upon the degree of ptosis as well as the levator action. Similarly, regarding the traumatic fracture of muscles, you can suture directly if you see the posterior end. The take home is the eye should not be forced into the opposite field of action of the suspect muscle injury, because this can result in muscle slipping backwards through its penetration site in tenor's capsule. So thank you. It's open for discussion and comments.
Thank you, Dr. Marian. Anju, are you there? Anju or Dr. Soumya?
Laila, madam.
Laila, madam?
Yes, sir.
Yes, sir. Yes, sir.
You'd like
Actually,
to clarify
I was
something?
during this time, our squint surgeon was not there, so I managed lateral rectus.
Beautifully managed, Marian. But I had a case recently of three cow horn injury.
Oh.
Medial rectus was gone, inferior rectus was gone, and we utilized the inferior oblique to anteriorize it on the primary sitting itself, and some amount. I was completely elevated, not coming down.
Okay.
But lateral rectus, of course, sometimes, not sometimes, often we look for the muscle movements.
Yeah. Actually,
time of injury.
Yeah. In this case, I didn't, actually the seen by a senior surgeon in the OPD actually, so I didn't actually check the movements, but after the peribulbar block, then I explored, then I understood, then I actually went back and spoke to the patient's attender also. There is a muscle injury, because LPS I detected before, but muscle injury I detected only after exploration.
It is the medial rectus which is more difficult to get.
Yeah.
Sometimes if you trace back the inferior oblique and the sheets, it's mainly the medial rectus which is difficult to get, but it is beautifully managed.
Thank you.
Yeah, Anju was asking something.
Sorry.
Yes. Yes, madam. Maria, ma'am, in this case, since it was post trauma and you had a tough time locating the LPS muscle, and would you have preferred doing a frontalis sling, considering that the levator function was not very good?
Yeah, the problem with the sling, see now the patient is having levator 8, and I was the primary surgeon, I only did the primary surgery, and I know an element of levator is remaining. So that is why I confidently went ahead with levator. If I was a secondary surgeon, probably I would have gone for frontalis sling. But 6 months follow-up is doing well.
Okay, it was an excellent case, ma'am, and a very difficult one.
Yeah.
Thank you, Dr. Marian. So can we have the next case, Dr. Prayagi? Dr. Prayagi, you're there?
Yes, sir. Can you hear me, sir?
Yes. Please share your screen. Yeah.
Yes, sir.
Dr. Prayagi is working at Contrast Eye Hospital, and she'll be presenting a retina case. And Dr. Prakash is also here for the discussion.
So good afternoon to all the senior surgeons and my teachers here attending the webinar today. Thank you, Dr. Sujit sir and Vijay Lakshmi ma'am, and special thanks to Dr. Prakash sir for giving me this opportunity for presenting this video among so many eminent speakers and panelists. I'm Prayagi. As I introduced, I'm currently doing fellowship at Contrast. So we go to the case. So we have a case of a 38-year-old male who presented to us with a history of a trauma to the right eye while making a bird cage. So he presented to us within 2 hours and had an initial visual acuity of 6/60 in his right eye. So examination showed that there was a minimal lid edema with a conjunctival tear and a corresponding 2 mm scleral wound at 3 o'clock position with a minimal uveal tissue prolapse. So the lens was developing early cataractous changes, and but we could get a fundus view, and it was showing a vitreous hemorrhage nasally and 2 air bubbles inside. So, but no foreign body could be visualized inside or externally at the wound site. So a gentle B scan was done, and it was showing the intraocular air bubble and a hyper-reflective echoes along the coats of the eyeball with an average thickness of 1.5 mm, but the length could not be accurately made out. So a CT was advised, and he was asked to plan for a wound exploration with foreign body removal, and need for vitrectomy and silicone oil injection was done. So this was his So this was a CT image, the axial cut through the mid-orbital cavity, showing a hyperdense foreign body in the along the coats of the eyeball, along the medial side within the coats of the eyeball. It was suggestive of a metallic foreign body. So coming to the superior cuts, as you can see, further superior cuts, it was showing more and more parts of the foreign body. And as you can see, it is extending nasally from nasally to a supratemporal area. It was a curved foreign body along the coats of the eyeball. So he was planned for surgery. But what happened was, in between, he went to another hospital for a second opinion, and a primary repair was done. Then later he came back to us. Then the lens had become fully cataractous, and then came back to us for the second surgery. So he was taken up for surgery. First, the lensectomy was performed. As you can see, anterior capsulotomy is being performed here after staining. Entry is being done, and the cataractous lens is being removed with the help of bimanual aspiration. Then the ports for the 25 gauge sclerotomy ports were made, and it was entered. A vitrectomy is being performed anterior. The caps. So after getting inside the eye also, we were searching for the foreign body inside the eye. As you can see, there is no evidence of the foreign body. It was a very young 38-year-old patient. So we were proceeded with the vitrectomy. A PVD induction was done, and vitreous were being removed. So even after removing the vitreous, we were exploring the area for any foreign body, but we couldn't find any foreign body inside the eye. It was closely examined after removing the vitreous hemorrhage in the local area. Then we proceeded to explore the wound from the outside. So a conjunctival was opened. As you can see, the old sutured scleral wound is present. The whole area was thoroughly examined. Even the medial rectus was tagged for greater exposure, and exploration was done thoroughly. But there was no evidence of any foreign body outside also. So again, with the help of the light pipe and indentation from the outside, we were examining for the foreign body. So as you can see here, a small bit of a foreign body was found after indenting from the outside. So an entry was made. Peripheral vitrectomy and was done. And with the help of a claw forceps, the edge of the foreign body is being pushed from outside and is being grasped with the claw forceps. So as you can see, a minimal of retina is getting pulled. So we try to minimize the iatrogenic trauma we were causing, and the foreign body was slowly pulled outside. So it was keeping on coming. So this was just like a magician performing a mouth coil act. We couldn't find the end of the foreign body for a long time. So finally it was taken out. This was a curved foreign body with a measurement of approximately 42 millimeter. The iris was then reposited, the wound sutured, and a completion of vitrectomy was performed with PVD extended up to the periphery. The edges of the break is being cauterized here. An inferior iridotomy is being performed. Now a fluid air exchange is being done here. As it was not settling with by the fluid air exchange through the break, we had created a drainage retinotomy and fluid air exchange is performed. SRF drainage is being done and fluid air exchange performed. Now the endo laser is being performed along the wound edge and at the DR and also the detached part of the retina. Now silicone oil is injected. Coats removed. Conjunctiva opening was sutured. So in the 1 month post-op period, he had a visual acuity of 2/60, a phakic with a pinhole vision of 680. And in the 4 month post-op, the vision was maintained, but he was developing a shallow inferior SRF with few nasal and extending to the temporal also. So recently he underwent a buckle with re-SOI and retina was attached post-operatively and is yet to review for us next visit.
Very interesting case, Dr. Prayagi. Actually, it's like sometimes it's quite amazing, like how such long things get hidden inside the eye without any, So Prashant
it was a
sir,
suprachoroidal foreign body, sir, with no external or internal part could be seen.
What was interesting, Sujit, was this is the second time we are removing such a long foreign body completely suprachoroidal. This time we were lucky. We could see it under the pars plana epithelium, the tip of the foreign body. We could just appreciate it was completely buried under the epithelium. We suspected it is there. As we depressed the pars plana, we could see the shining. It was even though it was under the epithelium and removed it along with that. You can see the epithelium also gets pulled as we pull the tip of the foreign body. Last time, that was 4 or 5 years back, we had a similar thing, almost 6 centimeter wire foreign body, which was completely suprachoroidal. This also completely suprachoroidal. That also was suprachoroidal. But last time we couldn't find it inside or outside, and we could just palpate it on the sclera. The wire was palpable on the sclera, and we made a scleral cut down and cut the foreign body in the middle into 2 pieces and removed from either side. It was 6 centimeters. So I don't know how these wires go completely suprachoroidal and without causing any injury. And whatever the tear and the suprachoroidal bleed, you are seeing a mount of suprachoroidal bleed was caused iatrogenic by the surgery. Actually, there was nothing inside when we started with. So,
like purposefully something you have kept hidden somewhere.
The potential space, I
kept
believe,
something just like reinforced concrete.
It's a potential space. That's what it allows the foreign body to slip into that space probably so easily. So the other thought process is
it goes bending all the way along the curvature.
Yeah. The other thought is it prudent enough to really leave it into the codes where it is not causing an intraocular thing is another point of debate which we can also consider, because I think Vivek is with us.
Vivek has left.
Okay, Gopal.
Vivek is here. Vivek is there. Dr. Gopal is left. Vivek is there.
Okay, no issues. So there is another point of debate. Is it worth removing and causing a trauma? The trauma per se induced by the surgery per se can be more harmful than the leaving this thing. But it is a metallic foreign body with an iron foreign body type of a rust. That is another point. Long-term cirrhosis. We
Yeah.
need to outweigh.
Medical legal aspect, if the patient loses vision for some reason, it will be accused that you have left the foreign body there and that cause. So we will be in trouble.
It's very true. We are in a situation fix. Great surgery.
Good video shared. Thank you, Dr. Prakash and Dr. Prayagi. Actually, Dr. Deepak is here. He wanted to share one more video, but he's stuck with some case. If not, we'll have the last case. It is actually, it was supposed to be presented by Dr. Faraz Ali. He is again, he had to leave for a function. So I'll present the case. It's actually a video. He has pre-recorded the video. I'll just play the video. I was also a part in managing this case. So it's a very interesting. I'm just playing the video.
A very good afternoon to all of you. First of all, I would like to thank the organizers for giving me an opportunity to be presenting a case on the occasion of World Trauma Day.
I hope the sound is clear, right? Little feeble though.
Yeah, it's audible.
Okay, fine.
Screen.
Full screen, please.
My patient is a 39-year-old male who works in a plantation, and on a day when there were heavy rains, he took shelter under a tree along with his co-workers when he noticed a branch of the tree snap, fall on the right side of his face. He fell down to the muddy ground and had a sudden loss of vision. His co-workers checked his eye and they found that there was no eyeball inside the eye. And they assumed that the eyeball had extruded out, fallen onto the muddy ground. They frantically searched for the eyeball for some time. They could not find the eyeball. Convinced that the patient has lost the eyeball, they panicked and they rushed to the emergency department. On evaluation, the right eye was showing an ophthalmic socket. Only the palpebral conjunctiva was visible. Bulbar conjunctiva was not seen. No components of the eyeball were seen. Left eye vision was stable, 6/6, and movements were full and free. So here we tried assuring the patient that it is unlikely that the eyeball has extruded out because there were no signs of collateral injury. There's not much of ecchymosis, not much of bleed. And then to confirm our findings and our suspicion, we send the patient for imaging. In such cases where we have a suspicion for facial fractures or trauma, CT scan is one of the best modalities. So our suspicions were confirmed as seen on the coronal section, where you see the globe has been dislocated and now it's positioned into the ethmoid sinuses. And you can also see that it is fairly far away from the superior rectus as well as the lateral rectus muscle. The axial scan showing the dislocated globe, and also one can note that the coats of the eyeball is impinged by the broken fracture fragment. The sagittal section showing the eyeball in its new position, which is in the midline. One more thing is the patient did not complain of loss of vision, loss of consciousness, or even epistaxis. One of the reasons for no epistaxis could be that the dislocated globe, which has fallen into the sinuses, in itself is giving an excellent tamponade, preventing further epistaxis. So our patient had actually a right eye traumatic globe dislocation into his ethmoid sinuses. So without further delay, we admitted the patient and we planned for a repositioning of the globe along with the fracture repair. And also the extremely guarded visual prognosis was discussed in detail with the patient as well as his family members. Because there could be any number of reasons for the visual drop. Could be direct, indirect traumatic optic neuropathy. And keeping that in mind, intravenous methylprednisolone as per traumatic optic neuropathy protocol was started with the aim to shift to oral prednisolone and taper over the following weeks. Let's go a few photographs of the steps And we took help of our max fac surgeons for the surgery. And this is on table where you can only see the palpable fissures, palpable conjunctiva, no bulbar conjunctiva or remnant of the globe. And this is the subciliary incision, layered dissection reaching onto the fracture site. And once we reached onto the fracture site, a gentle repositioning was done by blunt instruments introduced into the nasal cavity and gentle pushing the globe into the orbit. And this is post repositioning of the eyeball where it actually belonged. And following that, the plating was done by a titanium mesh actually, which covered the defect. And if you see here, you can see the screws which are used to hold it in place, and these were drilled into the orbital rim. At the end of the procedure, just a small quick endonasal view showing the mesh, titanium mesh, which is forming support as the new medial wall. These two images are to show the dilated pupil, and dilated pupil could be because either of cranial nerve 3 injury or could be because of direct or indirect traumatic nerve injury as already mentioned. And we took this opportunity to also have an indirect ophthalmoscopy done, which showed evidence of vitreous hemorrhage. Post-op day 1, post-op edema, as is noticed in the image, hyperglobus, and also extreme reduction of movement in all gazes. But one good finding that we noticed or we documented is the patient had perception of light, and also the projection of rays were accurate. Post 5 days of surgery, the patient was discharged on oral prednisolone 1 milligram per kg body weight, taper weekly, and also the right eye was started on anti-inflammatory medications as well as lubricating drops. 1 week post-op, the edema was nicely settling, but still there was good amount of movement restriction in fairly all gazes. And the patient still did not complain of diplopia, obviously because the vision was very low, but it had improved to counting fingers close to the face. Vitreous hemorrhage was resolving. 1 month post-op, the patient looks almost orthophoric. Edema has settled nicely. The patient still has restriction on levo version, but one good complaint that we were happy to hear is the patient complained of diplopia on levo elevation. So this would be possible only if the vision had improved. And on checking vision, patient had improved to 636, and the vitreous hemorrhage had almost resolved. The last visit, which was a week prior, the patient appears orthophoric, and ocular movements are almost full and free. And also the diplopia had reduced further, vitreous hemorrhage had resolved, and his vision in the last visit was 6/18. The patient had also resumed his duties, resumed work, and was actually happy that he had his eyeball and which was also functioning fairly well. So a couple of points about the take-home message from this case is that although dislocated globe following blunt trauma is very rare, whenever we see a patient with an ophthalmic socket post-blunt trauma, we have to keep in mind the possibility of a dislocated globe. And whenever we have the possibility of a dislocated globe, always request for imaging at the earliest, and CT scans is a good modality. Coronal, axial, sagittal, and even 3D CT cuts can be requested for. Many times with fracture of the orbital walls, one may wait for a week, 10 days for the edema to settle and to look for residual movement restriction. But in these cases where there is dislocated globe, there is no scope for wait and watch policy. Time is of the essence. One must reposition at the earliest. And obviously the patient has to be explained about the extremely guarded prognosis. Now looking at all these points, one may achieve fairly decent cosmetic outcomes. And if we have a lucky patient like ours, we may also achieve good or decent functional outcome as well. So that's the end of my presentation, and I would like to thank you all for a patient listening. Thank you.
Wonderful.
So actually, I wanted it to be the last case because it carries a message. Never say no to such cases. Because I myself was part of this, along with Faraz, we emphatically told the patient, you're not going to get the vision. just forget about it. So from that point, the patient recovered 6/18. So it was an eye opener for us. Like Mehul sir told, even in PL negative cases, I think there's probably some hope in many cases. We don't say all the cases. So with this, we actually conclude this meeting, and it's my time for the official vote of thanks. I start with an apology because I know it's a World Trauma Day. I have traumatized you all very much. So sorry for the long because I'm helpless with so many stalwarts on a single stage. Some delay is always expected. So it all started with our president, Dr. Vijayalakshmi, talking about the trauma and the need for creating some awareness for the trauma a few months back. That's how we conceived this idea, and we are happy that we could do it in a proper way. So it's an honor for me to deliver the vote of thanks to such an esteemed list of faculty. Let me start with the OTSI and its office bearers, Dr. Ashok sir, Dr. Mehul sir, and Dr. Prashant sir, for the extreme support they have. First of all, for consenting to join with just a district club like Kozhikode for annual meeting, and also actively participating in planning, organizing it, and executing, and for all the timely suggestions. Thank you so much. Next, I would next in turn, let me thank my parent organization, KSOS, Dr. Babu Krishnamar sir, Dr. Mahesh sir, Dr. Rajiv Sukumaran, who unfortunately couldn't join today because actually the Drishti is at the 1 month away, and he's busy with all the recordings and pre-recordings that's happening. Also, Dr. Jane Chimensa is also an executive member. For the strong support KSOS has always given for the KOS in all the programs we have conducted, and also for joining through the entire day. Dr. Babu sir was, I think, I don't know whether he's there now, but he was there for till some time back. So thank you so much. We are extremely thankful to all the senior and C consultants who are all stalwarts in the respective areas, Dr. Natarajan sir, Dr. Rupesh, Dr. Gangadhar sir, Dr. Lim, and Dr. Rajiv Raman, for all sparing this Sunday for us, for accepting our invitation with no hesitation, and for active participation and teaching us various aspects of the ocular trauma, ophthalmic trauma today. It's exactly the same for me with all the other faculties, Dr. Meenakshi, Dr. Siddharth, Dr. Vivek, Dr. Vishal, Dr. Bhaskar, all of them actually did exemplarily well, but only thing is that we couldn't give them enough time for good discussion, and we couldn't extract more from them actually. So KOS is profoundly indebted to you all for your kind presence today. We sincerely appreciate your sincerity for today's meeting. Next, I have a long list of my home team of KSOS and KOS faculty, Dr. Gopal, Dr. Natasha, Dr. Anil, and Dr. Marian from Cochin, Dr. Minu and Dr. Thomas from Trivandrum, and my own KOS members, Dr. Laila Madam, Dr. Sadragan Sir, Dr. Jyoti Madam, Dr. Prakash, Dr. Lakshmi, Dr. Seena, Dr. Sandhya, with special thanks to my scientific committee members, Dr. Suma Madam, Dr. Bindu, Dr. Dalia, Dr. Mihir, Dr. Nirupama. I'm taking name of everyone because I'm really indebted to you all. And my strong pillar of support, my president. Madam, you are there?
Yes, yes.
Yes, Dr. Vijayalakshmi MS. So, and I thank all the delegates who attended the meeting right from the morning 8:30 for your participation and making this a success. My sincere thanks to Mr. Girish and team who actually took much pain in shooting that short film. And the YouTube views are actually increasing day by day, and we are getting very good response for it. We hope that it will be very useful for our awareness program in future also. And finally, I thank for the profuse support given by Microvision for the entire program, right from brochure making to the short film making. Thank you, Sini Kumar and Arun, for coordinating everything. And my special thanks to Prashant sir for moderating with me and helping me with all the planning. I hope I didn't miss anyone. Like often it happens that in we miss someone very close to and active in helping. So I hope I haven't missed anyone. With this, we conclude this program. A very big thanks to the entire crew members on behalf of Kozhikode Ophthalmic Society and on my personal behalf. Thank you very much.
Cheers to Sujit and Kozhikode Ophthalmic Club.
Thank you all. Thank you, Babu sir, Dr. Prashant. Grover
Congratulations.
sir
Well
is left,
done.
I think. Grover sir, the whole of OTSI. Thank you once again.
It was, I think,
done,
one
well
man
done.
show. So Sujit and Madam, you both of you have done a wonderful job. Our contribution has been just on papers, I should say, or nothing more. But I should really congratulate the president and secretary who are so dynamic to take the whole program on their own shoulders.
Whoever is there, please put up a big hand for Dr. Sujit. One man army.
No, nothing like that, ma'am. Actually, they all taught us the trauma. We taught them how to pronounce Kozhikode. That's all.
He's done a big job, a great job. Thank you, Sujit, once again.
Thank you, Babu sir.
KUST.
Babu sir, special thanks to you for
Thank
sitting
you. Thank you,
whole day.
Sujit.
Thank you, ma'am.
Done very well. You've done very well.
Absolutely. I echo the same sentiments, Sir Babu sir. This man really took it by heart, in fact.
He should come to KSOS.
Yes, sir.
And later AIOS.
Yes.
Sir, I am leaving, sir.
No, you have to come to KSOS. Your
should.
presence is very much needed here.
His commitment is really great.
Thank you so much, sir.
Thank you all once again.
Thank you.
Chalo, bye-bye.
Thank you, madam.
Thank you, Laila, madam. Thank you, sir. Thank you.
Congratulations.
Thank you, madam. ഞാൻ ഗുരുവായൂർക്ക് പുറപ്പെടായിട്ടാ മാഡം കഴിഞ്ഞിട്ട് ഇറങ്ങാൻ നിൽക്കരുത്.
Okay, all the best.
Thank you.
Thank you, madam.